thank Dean Dr. Pushpa Sarkar, the conference organizer and chair, Dr. Satya Guruprasad, all the faculty members from the College of Physiotherapy, and without whose relentless work, this conference would not have taken place. So I acknowledge their help and their efforts in starting this nice endeavor. Now, I have been told that around 160 plus participants from all over India are are joining this online conference, which is a wonderful thing. And the topic, and I was very moved by the vision statement, which says that the vision of the National Symposium, or the theme of the National Symposium, is from soul to soul. It's taking a step toward better health. It explains the idea behind the conference in a very simple way. Now, this diagnosis, treatment, and prevention of foot, ankle, and lower extremity disorder is going to play a crucial role in maintaining mobility, independence, and overall quality of life of many individuals. So this is, by all means, a very important topic, something, on which, young and old, athletes and old people are having problems with their foot. And, this conference, I'm sure, will address all those problems, and distinguished plenary speakers who are going to address this conference are going to talk about those things. So once again, I wish you all a very best, a wonderful conference, and I'm sure at the end of this conference, you will go home with the best of knowledge and a desire to do something new. So thank you very much and have a pleasant day. Thank you.
Thank you, sir, and thank you, ma'am, for addressing the gathering. We have an exciting lineup of speakers and panelists who will cover a wide range of topics for cutting-edge research in physiotherapy to integrative health practices that nurture the soul. I encourage you all to actively participate, ask questions, and engage in discussions, as your insights are invaluable. Before we begin, I would like to extend my heartfelt gratitude to all the organizers, sponsors, and volunteers who have worked tirelessly to make this event possible. Once again, welcome to DSU National Symposium 2024. Thank you. Our plenary sessions. Now, we'll be starting with our plenary session. The first session will be taken by Dr. Anchit Gugnani on the topic Advance in Podiatry, a physiotherapist's perspective. Dr. Anchit Gugnani is the director of Amity Institute of Physiotherapy, Jaipur, and a distinguished scholar with numerous national and international publications, book chapters, patents, copyrights on his name. Please join me in welcoming Dr. Anchit Gugnani. The session will be chaired by Dr. Dhananjayan, founder of Bangalore Physiotherapists Network and Chief Physiotherapist at Spectrum Physio, followed by Dr. Rajashekar, Senior Consultant, Safe Steps Foot Care Center, Vivekananda Hospital, Associate Consultant, Apollo Health City, Hyderabad.
Good morning, everyone. I hope I'm audible to everyone.
So you are audible, sir.
All right. Very good morning. I would like to begin with extending my heartfelt gratitude to all the core member teams, Dr. Satya, Dr. Kanchan, and everyone. I'm really glad to be a part of this symposium on podiatry. So let me just share my PPT with you guys. Okay, I cannot share my screen. If you can enable me to share my screen.
Please try now.
Uh, is the screen visible? All right, just give me a minute. All right. A very good morning to all of you once again. I hope I'm perfectly audible to all of you. All right. So without wasting any time, let's begin. So good morning. I am Dr. Anchit. I am the professor and director of Amity Institute of Physiotherapy, Amity University, Rajasthan. I'm going to talk about the recent advances in podiatry from a physiotherapist perspective. So of late, there has been a lot of chatter regarding podiatry. So podiatry has been there since many years. I mean, since the inception of medicine. But of late, it has been talked about a lot, and the reason being because there has been a lot of injuries and rehabilitation process related, especially with podiatry. So that is why there are new advancements. So I'm going to talk about the recent advancements in podiatry. So coming on to the introduction. All right. So podiatry, let's discuss what is podiatry exactly. So it focuses on the diagnosis and treatment of foot and ankle disorders, crucially that are crucial for mobility and overall health. So why specific we talk about podiatry and why is it important? Because ankle and foot, these are the primary weight-bearing joints of the body which are prone to many injuries. Uh, Being a physiotherapist, the most cases that we see are of fractures, ligament tears, tendonitis, plantar fascia, and of course, sprain and strain, the most common thing. So, if we have so much cases, so much patients coming with injuries, there are a lot of aesthetic injuries, then it brings our focus to study the specific field that is called podiatry. Physiotherapists play a pivotal role in podiatry that is contributing to the holistic patient care through rehab, prevention, management of foot-related conditions. As physiotherapists increasingly integrate into podiatric care, they bring a unique perspective that emphasizes holistic rehab, prevention, and management strategies. So what we are focusing is we are focusing on the latest advancements in podiatry from a physiotherapist standpoint, highlighting technological innovations, new treatment modalities, and collaborative approaches that are transforming patient care. So we are just seeing a bigger picture of the latest advancements in podiatry through a perspective of a physiotherapist. So we are not going to only talk about the treatment modalities that a physiotherapist use, but also the diagnostic techniques that are being used and the medical care that is being used. I mean, there is a technical difficulty. Just a minute. All right. So talking about the objectives, so what are we aiming at? To understand the recent technological advancements in podiatry that will help us to know the treatment efficacy and patient outcome, to explore innovative treatment methodologies such as regenerative medicines and advanced surgical techniques, and to discuss practical applications demonstrating the integration of these advancements in clinical practice. There seems to be some problem with the PPT. All right. So why is diagnosis important in podiatry? So in other words, why is assessment important in podiatry? So what is generally seen is that whenever a patient comes to us, we focus on the small term goals, that is the pain relief or the inflammation. Many of the therapists, they don't actually go into the deep assessment, and they don't go to know the root cause of the problem, that is the pain or the inflammation. So they focus on treating the short term goals, and what happens in the long term, the injury keeps on coming back or the pain keeps on coming back. An ankle is such a joint that if you don't treat it, if you don't rehabilitate it accurately, the pain will keep coming throughout the life. So that is why assessment, a good assessment and diagnosis is very important. So accurate treatment planning, how does it help? A correct diagnosis is the foundation for effective treatment. That, as I told you, a good assessment, detailed assessment is very necessary to know what is the problem. Is it biomechanical? Is it some mechanical injury? Is it something else? So we need to find what is causing, reaching to the diagnosis, which will help in making us a good treatment plan. Then prevention of complications. Definitely, if we know the current assessment, if we know the current diagnosis, then we know how to proceed, what are the indications and what are the contraindications, which will help us in prevention of further complications. Cost-effective care, definitely improve quality of life. As I said, that ankle is the most primary weight-bearing joint. Just in case if we are unable to remove the root cause, the pain will keep coming throughout the life whenever the patient is moving, or if it is in case of an athlete, uh, agility training or the sports will be effective. So improving the quality of life is very important. So diagnosis is a critical step in podiatry that influences the entire spectrum of patient care, from treatment, planning, and prevention to the total rehabilitation using the interdisciplinary collaboration. So talking about the innovations in diagnostic tools in podiatry. So coming to the diagnosis, so there are some very new diagnostic tools. I'm sure many medical professionals are already aware of such things, and I'm going to talk about a global perspective in such case. So despite the common things that are available, that are very small X-ray machines that are very portable, which give instant films. We are going to talk about high resolution ultrasound imaging, and we are going to talk about digital foot scanning and pressure mapping. So these are the two diagnostic approaches that we are going to talk about. So talking about first of the high resolution ultrasound imaging. So as we all know how the ultrasound imaging works, high resolution ultrasound imaging utilizes sound waves to create detailed images of soft tissues within the foot and ankle. So the most part of ankle joint that we know is the bones and ligaments. Lot of soft tissues are there. So many a times what happens usually in the cases of sprain and sprains, that there is a soft tissue injury which gives us a lot of pain and inflammation. And usually, sometimes the doctor focuses on the X-ray, and there is nothing on the X-ray, but it is majorly a soft tissue injury. So for that, we have to go in for a ultrasound, which gives us a very accurate diagnosis or the assessment of the soft tissue uh, there that can lead the in the presence of tendon injuries or ligament tears. So it has a very accurate identification of what ligament and what level of tear that is there. So it helps in diagnosing that. And a very new thing, that is the digital foot scanning and pressure mapping, which has been used globally and is very useful for determining biomechanical changes that is very important for a physiotherapist. So what it does is digital foot scanning and pressure mapping systems captures and analyzes foot pressure distribution and biomechanics. How does it function? So it tells us the pressure distribution on the ankle. So we have to step onto the machine and put weight on the machine. So what it does is it has sensors all around it, and it catches the pressure distribution along the foot. And it helps in determining if there are any biomechanical changes or any bony or functional changes in the foot. How does it help us? So knowing the functional changes and knowing the biomechanical changes, it helps in uh, forming of the orthotic devices. So it guides the design of the custom orthotics by identifying pressure points. So for example, if it is a case of flat feet or the arch is missing, so it helps us design the arches tailor-make to the patient. So what happens is that the specialist, the prosthetic and the orthotic specialist, using this pressure system makes the device, makes the arches, and the patient is then asked to step up again using that arch and again to see how the pressure distribution is there after the arch is in place. And the second application is the rehabilitation planning. That is, it helps in planning the rehabilitation programs by addressing gait abnormalities and optimizing biomechanical efficiency. So what we fail to miss many a times is the biomechanics, which is the most important aspect, because many a times we have seen that patient walks into the clinic complaining of back pain, complaining of hip pain, and on deep analysis we figure out that it is because of the biomechanical changes in the foot that the problem has been transferred to knee, and then the problem has been transferred to the hip, and so on and so forth to the back. So biomechanical analysis is very important, because if we correct the biomechanical changes, the gait abnormalities, the posture is corrected, the compensatory issues, the muscles, they are all they go into shortening and lengthening. So that is all corrected. So it is very necessary to analyze the biomechanics, and this foot scanning machine, it helps in assessing that only. So again, how does it work? So as you can see, the patient is asked to step up, and there are sensors, and it tells us how much pressure is there on which aspect of the foot. So analyzing that data, we can tailor make the treatment plan and the orthotic devices if needed. So talking about recent advancements in podiatrics in terms of what else is there for the treatment and planning. So we'll talk about technological advancements. We'll talk about advanced podiatric treatment. We'll talk about advancements in footwear and orthotics. We'll talk about advanced physiotherapy rehabilitation techniques. All right. So talking about technological advancements, so I'm only going to talk about only three of the advancements. That is the 3D printing for custom orthotics, laser therapy, and wearable technology. So there is some issue in changing the slides. I don't know if it's the internet issue or the Zoom issue. Just bear with me. All right. So talking about 3D printing for custom orthotics. So this is the latest advancement, and more than it is tailor make, and more than it is useful uh, biomechanically for the patient. The patients are using it because it is cosmetically uh, very advanced. So just for the cosmetic looks, more and more use of it is enhancing for the patient. So what is happening is 3D printing technology has revolutionized the orthotics by allowing creation of customized devices. So as you can see in the picture, customized and designed orthotics are being produced with the help of 3D printing. This personalization enhances comfort, support, functionality, and definitely the cosmetics for the patients with specific foot conditions such as flat feet or high arches. So, what are the benefits? The first is the precision. Definitely, if we are tailor making for the patient, so it is very accurate and it is fulfilling the need. Second, it is very comfortable because again, it is tailored made as per the patient's need, and the material that is used is comfortable and is effectiveness. So, if we are using it with precision, it will be very effective for the patient. So, this is if you can refer to the image D. So that is especially for the foot, and it's being largely used globally. Talking about the laser therapy, so laser has been used since a very long time, and earlier researchers showed that laser is not very effective. But now the laser which is coming has shown great result in pain relief and in healing. So laser therapy is something that now the good advanced clinics are bringing to themselves, and it is showing good. Uh, Researchers have shown that they have shown great effectiveness in treatment. So laser therapy utilizes low-level lasers to penetrate tissue, stimulating cellular metabolism and accelerating healing process. So in podiatry, it is employed for pain management, tissue repair, and wound healing. Because as we talked about, that ankle is one of the joints which is mostly used, and all the body weight is there. So a quick healing is very necessary because for everyone, resting the foot is very difficult. Going into some rest so that we don't exert pressure or weight into it is very difficult. So for quicker healing, we need very effective techniques and modalities. So laser is one of them. So what it does is it goes into micro tissue healing, increases the blood circulation, resulting in a quicker repair. And also it helps in pain management. So where is it applied? It is applied for pain management. It is applied for tissue repair and definitely for wound healing as well. In case of diabetic foot, laser is also used. Wearable technology. So if you guys, any of you have run marathon, so you must have noticed that at the beginning of the marathon they give a bib which is attached to the shoe, and the athlete is asked to run, and at the end of the race the bib is collected and all the data of the running, what all checkpoints crossed, how much time taken, where did the athlete stop, and in case of advanced bibs, even the speed, stride length, step length is also calculated. So what are the variable technologies that advances in the variable technologies that enabled podiatrists and physiotherapists to monitor gait patterns, movement dynamics, and biomechanical parameters in real time. Now, which is that is the time of artificial intelligence, the variable technology is being incorporated with AI to give us very good quantitative analysis of all these things. That is the gait pattern, the movement dynamics, and the biomechanical parameters. So what is the functionality in it? We can have a thorough gait analysis. That is again, if we talk about labs, if we talk about wearable technology. So sensors are there in the foot and in the leg, and what they do is they capture all the data. That is the step length, stride length, the walking patterns, the time taken. So they capture everything. So it tracks the walking patterns to diagnose gait abnormalities and to assess rehabilitation progress. And definitely they collect all the data which can later be analyzed as to how we can improve upon the things and for personal rehabilitation. So basically it is very useful for the geriatric patients as well because they are very prone to fall, and the balance is reduced. So it is very good for such patients. Now talking about the advanced podiatric treatment, so now we shift gears to how physiotherapy is being, technology wise enhanced for treatment related to podiatry. So I'm going to talk about, there are a lot of things that are there in the market, a lot of new things. So specifically, I'm going to talk about only a few of them. That is the shockwave therapy, the cryotherapy, and the regenerative medicine, which is being done by the medicos. Again, cryotherapy is also a very old thing. It is not a new thing, but new form of cryotherapy applications are available. Very good, easily applied cups are available, which are used. That I'm going to talk about. So to begin with, I'm talking about shockwave therapy. So shockwave therapy is a very new thing, which a couple of years ago was being used to treat kidney stones. So what it does is it involves the application of acoustic waves to targeted areas of the foot and ankle. So what happens in shockwave therapy? It's a small machine, and with the help of a transducer that is like a small gun, what we do is we apply shock waves inside the body. So it is just like ultrasound. Ultrasound also uses sound wave, and shock wave is something like that only. Just the difference is shock wave, it does not give any thermal effect, and it creates a lot of sound. Shock wave. So what it does is it induces waves inside the soft tissue, and the positive waves and the negative waves, they have opposite mechanisms. So what they do is they create, they help in doing the increasing the blood supply and doing the micro healing of the structure. Many researchers also say that they help in breaking the spasm of the muscles also. So that is how it is being used, and researchers now have coming up which are showing positive effects of shockwave therapy uh, around the body and also for the ankle and the foot. So what are the applications where it is mostly used? So plantar fasciitis, it is one of the most common thing that is there present, and especially for the people they lack those who lack arthritis and flat feet, and definitely for long-standing professions such as policemen and teachers, it is very much there. So it is very much effective in plantar fasciitis. It is effective to treat the tendinopathy as well. And the mechanism of working is that it stimulates the healing process and it helps in the pain reduction. The negative waves that are created, it helps in cavitation and it helps in increasing the blood circulation, thereby increasing the healing time. And what are the benefits of using shockwave therapy? So the best is that it is non-invasive and the success rate is very high. So that is the pain relief. The specific thing which related to the patient is concerned with pain. Patient is not concerned as to what the fascia is inside, the it is healing or not healing. As per the patient's perspective, he needs to have pain relief, which is most efficient with shockwave as well. So there are other modalities also that we use. That ultrasound is also very effective, but this is something which is new and which is being used and have has a good effective result. Now talking about cryotherapy, why I'm including cryotherapy is because it has been included since a lot of time. It is being used since a lot of time. Uh, the first thing that we read about is if there is any acute injury, uh, we follow the process of RISE, which is slowly changing, and there have been many researchers saying that in acute injuries, ICE may hamper the recovery process because it reduces the blood supply. There have been many contradicting researches as well, but it is still one of the most effective treatment methods for reducing the pain. So as I talked about, that pain is the most important thing from the patient's perspective, especially if it is an athlete who's playing on the ground, especially someone who has to get back on the ground, or a patient who needs to be active to do the work. ICE is one of the very important things, and what in advancements is there is that there are now cups available that can be applied around the joint. For the ankle joint, there are special cups. For the knee joint, there are special cups. And what we need to do is there's a small jar. We just need to fill it with ice and pass some air. And what it does is it inflates the cup with cold air. That gives a cold compression kind of a thing. So it gives compression also, and it gives the cold uh, therapy also to the joint. So that is how it is very effective. So what are the applications? That is post-injury recovery and chronic conditions as well as acute. So I'm not mentioned acute because there are contradicting researches going on. Mechanism of injury, we all know how cold application helps us. And what are the benefits? The speedy recovery and localized treatment. Coming on to something which are the medicos point of view is very important. That is the regenerative medicine. So regenerative medicine utilizes biological materials and techniques to promote tissue repair. Very common example is PRP, that is the platelet-rich plasma. That is concentrate platelets from the patient's own body is given and injected to that particular part, which helps to accelerate healing and tissue repair. And also stem cell therapy is there, which is being researched and used. Some of the researchers have shown very good results. That is the use of stem cells to regenerate damaged tissues and enhance the healing process. So these are also being used widely, and they also have a very good effective uh, results in the use. So they are used for tendon and ligament injuries and for cartilage repairs as well. So mechanism is biological signaling. If you're using the own plasma and it goes there and accelerates, works as a catalyst, increases the healing process, and it also has anti-inflammatory effects. So what are the benefits? The benefits is natural healing, its own body which is healing, and long-lasting results, good results. So talking in terms of orthotics now, so there are advancements in footwear and orthotics as well, in the form of smart insoles, advanced materials, and customizable footwear. So talking about smart insoles, again a very advanced and a very useful uh, innovation that is being used globally. That is smart insoles. So what are those? Smart insoles are equipped with sensors and electronics that collect data on the foot pressure, gait dynamics, and movement pressure. So this is just an insole. If you can see the picture beyond the in the picture in the slide, that there are sensors present in the insoles. So how does they function? Similar as the pressure plate that we talked about. So as we use them inside the shoes, they keep on collecting the data of how the gait pattern is there, where is the pressure point. So using all those, we can again use the orthotics and plan the rehabilitation. So what is the functionality? Gait monitoring, they analyze the gait parameters such as the stride length, cadence, and foot strike patterns. Real-time feedback provides immediate feedback to the users and healthcare providers on the gait abnormalities. This is done with the use of another sensors which either vibrate or with the use of app which tells you, how to move, or if you're moving incorrectly, it tells you. And balance improvement helps in improving balance and stability by detecting weight distribution changes. So again, in the case of geriatrics or in the case of Parkinson's, that is very much usable. So application is fall prevention in case of geriatrics and rehabilitation, and of course for all the other users, because it is analyzing all the data. It has multiple uses and applications. So what are the benefits? Personalized care is there because again tailor make, you have the data of a particular patient, and you know where the patient is lacking or where to work upon. So balance exercises or orthotics or anything else that needs to be incorporated can be incorporated as per the data, and continuous monitoring is there. Now some advanced materials are used. Again, this is something which are being used since a very long time, but again need our focus. So orthotic devices made from advanced materials offer enhanced comfort, durability, and performance. So just as you talked about smart insoles, the new things that are carbon fiber. We all know that carbon fiber is a very lightweight and a very durable material that is used. So it provides lightweight support and energy return. So if it is lightweight, we don't waste energy carrying the orthotic device from one place to another. If we are wearing it also, then lightweight is very comfortable. Ideal for active individuals. Memory foam is there. So memory foam is being used again a lot of places. So what it does is it confers to the shape of the foot. And how does it help? As it We can say that it takes the shape of the foot in a mirror position. So the pressure distribution gets very easy in memory foam, and it gives a lot of comfort. And there are gel inserts. So these are readily available in the market in the form of, uh, heel gels or arches that are available in the form of gels, which are being used specifically for podiatric patients. Application, again, sports performance, to enhance the sport performance because they are lightweight, can be used easily in case of agility training or sports and daily wear activities in which we need to give the patient insoles for whatever reason that is required. Benefit is longevity and patient satisfaction. And we talk about comfortable footwear. So comfortable footwear is nothing but using of all the data of pressure, uh, um, sensory information that we get of the biomechanical changes or the foot position. So customizable footwear these days, what even the good food companies are doing is they are uh, taking orders uh, as per the tailor make size of the foot and the shape of the foot, because some people, so the market usually that we have in India or anywhere is that they only see the length of the feet, they don't consider the width of the feet. So if someone who is hefty or if someone who has a wider feet, they have many problems and the leg pain and the foot pain starts coming up after some time because the shoe is very tight. So customizable footwear these days the company is doing is they are considering the width of the foot, also the width at the beginning, the width at the back, the length of the feet, and as per that they are making the footwear which is very comfortable. So customizable footwear allows for creation of shoes tailored to the individual foot anatomy and specific health needs. So how does it help? Foot shape and size, as I talked about, arch support, which is very important, which is neglected by the good shoe companies as well. Arch is very important, and very handful amount of footwear have good arch support. So arch support is given in customizable footwear, and pressure points. So definitely elevates the pressures on sensitive areas, reducing discomfort and the risk of injury, especially in case of diabetic patients. So application is orthopedic sports performance. Benefits is that it is optimized fit and functional improvement is there. So these advancements in footwear and orthotics demonstrate the evolving capabilities of technologies and materials in addressing individual foot care needs, improving comfort, mobility, and overall health outcomes for patients. Now, what are the more advancements in rehabilitation techniques? That is the use of virtual reality. I'm sure everyone is aware how virtual reality is being worked upon for upper limbs as well as lower limbs. There is aquatic therapy that is utilizes water resistance for low impact rehab, enhancing strength, flexibility without joint stress. And more than ever, aquatic therapy also rehabilitates the mental rehabilitation for the patient. It is like a fun activity for the patient. If we ask the patient to have a session of hydrotherapy, it really relaxes the patient because he enjoys doing the therapy. And also sport specific rehabilitation, that is the tailored rehabilitation programs for specific athletic need, optimized performance and preventive re-injury with the use of all the sensory information, all the sensors that are being placed these days. If you see maximum sports, they even show in the TV that they have many sensors and they analyze all the all the athletes while they are training, and using that uh, data, they improve the biomechanics and hence the performance of the athlete. So what are the goals of physiotherapists in podiatric conditions? So the goals are very simple: comprehensive assessment, as we talked about. If we are good in assessment, we are good in diagnosis. If we are good in diagnosis, we know how to create short-term low goals and long-term goals using the technology. There are assistive devices that are there which can be used to enhance the rehabilitation program. Collaboration, definitely it's a teamwork. We all need to be a team with the medical professionals, rehabilitation workers such as physiotherapists, occupational therapists, and all the other members. Foot care education is very important. What we lack is foot care education, especially in conditions like diabetes. To educate patients on proper foot care practices, including foot selection, hygiene, and injury prevention strategies, and some uh, self-management tools, that is provides resources and tools for patients to monitor their foot health, enhancing long-term management and prevention of some foot orders. So self-management tools are very important. So educate, just as the patient education is important, there are some things that need self-management tools. So example of a self-management tool. So what I'm going to talk about here is uh, I am also working on two or three podiatry related thing, and I've recently taken up a design grant on a patent for. So I've created an inversion and eversion board. So what I notice is that maximum people, especially girls or elderly, they uh, are very prone for sprains and strains. So what which hampers the ligaments, and what is there, and upon analysis we find out that the strength is very less, and which gives them more chances of injury. So I created this device which helps in increasing the strength of inversion and strength using inversion and eversion. So it is a device, as you can see, that it's a very small device, the length of the foot, and there is a very small rail which helps the patient in doing inversion and eversion, and which has resistive bands, and accordingly the resistance can be changed as per the strength, and can be increased to increase the strength. So if you see this pattern, this is the frontal view. So how the front part can be moved from left to right. This is another angle in which the heel is almost fixed. This just moves around the axis and helps for inversion and eversion. So this is it. So what it helps is another thing that I'm talked about, and further Dr. Nandini will talk about, is plantar fasciitis board. So we are as a team working for many podiatric devices that are very helpful in increasing the strength of the foot, which is usually some machines are missing. So even if we are very active users and we go to the gym, there are hardly any machines that are available for foot strength, strengthening the foot or strengthening the ankle joint. So, in the end, I would like to say that podiatry and physiotherapy together creates a foundation of movement where every step is supported by science, comfort, and care. These are the references. That's it. So, that completes my views on podiatry from the physiotherapist points of view regarding the latest technological advancements in podiatry. If anyone has any queries or want to inquire anything.
I am Dr. Rajshekar from Hyderabad. Hello
Yes,
to
sir.
all from Hyderabad. I am chairperson here, podiatric surgeon from Hyderabad. So it's a excellent presentation, Dr. Ankit.
Thank you.
Most of the recent advances you have covered. And thanks for inviting me as chairperson or organizing committee members. One or two points I want to add to these recent advances. The collaboration between the surgeon, a foot surgeon, and a physiotherapist is vital to save the diabetic feet from amputation. And high resolution ultrasound, actually, it needs to be included in curriculum of physiotherapy, at least in the master's level, because in the era of 21st century, we have so many medical legal issues. Everything needs to be quantified. Suppose if you are doing a stretching of Achilles tendon for a plantar flexion deformity, before this starting the treatment and after the physiotherapy is done, you can clearly see the pinnate angles, how they are stretched. You can document really. So it's a good idea to include the high resolution ultrasound, and every physiotherapist need to be acquainted with the ultrasound probe, at least at the master's level.
Agreed.
And one more thing, just one thing I want to add in the recent advances is, my background is orthopedic surgeon, so I see multifold increase in falls and trips and falls and fractures in diabetic neuropathy people. So a balanced platform which which quantify the fall risk in a diabetic or a elderly people is very essential nowadays to prevent the falls. If somebody's balance is poor by visual, that's different. We need to diagnose, identify, educate the patient, stress upon the need to to take the help of a stick or a walker frame by these quantitative measures. Thank you very much. It's a
Correct.
nice presentation again.
Noted, Chandra.
Audience, if any questions, welcome, please. No questions?
Any questions? I request all the delegates to please put up their questions in the chat box. I repeat, all the participants, if you have any questions, you can please put up your questions in the chat box. I would like to also thank Dr. Anchit Gugnani to share his insight on the recent advancement in podiatry. Your knowledge on diagnostic tools, biomechanical analysis, custom orthotic design, biomechanical other stuffs, which actually had included so much of variety in physiotherapy. And I would like to thank you for enlightening us on the involving landscape of the foot. Your expertise and contribution are immensely valuable and inspire us to enhance our practice for better patient outcome. At the same time, I would like to thank our chairperson for the session, Dr. Dhananjayan, founder, Bangalore Physiotherapists Network, and Chief Physio at Spectrum Physio, sir. Thank you for highlighting your invaluable insight in this particular topic.
Thank you so much once again. Again, I would like to thank and extend my gratitude to the core team, Dr. Satya, Dr. Kanchan, and everyone else who put in their great efforts to put on this symposium on podiatry, which I'm sure will be very helpful and everyone attending will be benefited. Thank you so much once again.
Dear delegates, we will be taking a short break. So please enjoy refreshment and kindly join us by 10:40. Thank you for participating. Please join us by 10:40 a.m.
The curriculum is designed to give students a comprehensive understanding of the human body and its functions, along with experiential training in the latest physiotherapy techniques. What sets our department apart is our ultra-modern facilities, including sophisticated classrooms and clinical training rooms. Our students have access to the latest technology and equipment, allowing them to hone their skills and knowledge to the highest degree. The faculty at the College of Physiotherapy is comprised of experienced professionals who are dedicated to their students' success. With our modern amenities and a supportive community, Dayanand Sagar University's College of Physiotherapy is the ideal place for aspiring physiotherapists to begin their journey.
ಇದೊಂದು ಅಬಲಾಶ್ರಮದ ಕಾರ್ಯಕ್ರಮ. ಇಲ್ಲಿ ಆರೋಗ್ಯ OPD ನಡೆಸ್ತೀವಿ. ಬರೀ ಜನರಲ್ ಫಿಸಿಷಿಯನ್ ಕೂತಿರ್ತಾರೆ, ಪ್ಲಸ್ ಫಿಸಿಯೋಥೆರಪಿ, ಡೆಂಟಲ್, ಪೀಡಿಯಾಟ್ರಿಕ್ಸ್, OBG ಅವರೆಲ್ಲ ಬರ್ತಾರೆ. ಅವಶ್ಯಕತೆ ಇದ್ದಾಗ ಕನ್ಸಲ್ಟೆಂಟ್ಸು ಬರ್ತಾರೆ. ಫಿಸಿಯೋಥೆರಪಿ, ಡೆಂಟಲ್ ದಿನ ಇರುತ್ತೆ. ದಯಾನಂದ್ ಸಾಗರ್ ಕಾಲೇಜ್ ಅವರು ರೆಗ್ಯುಲರ್ ಆಗಿ ಫಿಸಿಯೋಥೆರಪಿ ನಡೆಸ್ಕೊಡ್ತಾ ಇದ್ದಾರೆ. ನಮ್ಮ ಸಂಸ್ಥೆಯಲ್ಲಿ ತುಂಬ ಚೆನ್ನಾಗಿ ನಡೆಸ್ಕೊಡ್ತಾ ಇದೆ. ಸುಮಾರು ಕ್ಯಾಂಪ್ಗಳು ಮಾಡಿದ್ದಾರೆ. ಸುಮಾರು ಪೇಷಂಟ್ಸು ತುಂಬ ಖುಷಿ ಪಟ್ಟಿದ್ದಾರೆ ಅವ್ರ ಟ್ರೀಟ್ಮೆಂಟಿಂದ. ಸೊ ದಯಾನಂದ್ ಸಾಗರ್ದು ಇಲ್ಲಿ ರೆಗ್ಯುಲರ್ ಆಗಿ ನಡೀತಾ ಇದೆ. ಐ ವುಡ್ ಲೈಕ್ ಟು ಥ್ಯಾಂಕ್ ದಯಾನಂದ್ ಸಾಗರ್ ಕಾಲೇಜ್.
ಎಲ್ಲರಿಗೂ ಶುಭೋದಯ ಮತ್ತು ನಮಸ್ಕಾರಗಳು. ನಾನು ಶ್ರೀಮತಿ ಶ್ರೀದೇವಿ, ಕೇಂದ್ರ ಭೌತಿಕ ಮತ್ತು ದೈಹಿಕ ಬಹುನ್ಯೂನತೆ ಇದ್ದ ಮಕ್ಕಳ ಪುನಶ್ಚೇತನ ಕೇಂದ್ರದ ಪ್ರಾಂಶುಪಾಲರು ಮತ್ತು ಮುಖ್ಯ ಕಾರ್ಯನಿರ್ವಾಹಕಿಯಾಗಿ ಕೆಲಸವನ್ನು ನಿರ್ವಹಿಸ್ತಾ ಇದ್ದೇನೆ. ಮನನೊಂದನ ಕೇಂದ್ರವು 1996ರಲ್ಲಿ ಸ್ಥಾಪನೆಯಾಗಿ 28 ವರ್ಷಗಳನ್ನು ಪೂರೈಸಿ 29ನೇ ವರ್ಷಕ್ಕೆ ಕಾಲಿಡ್ತಾ ಇದೆ. ನಮ್ಮ ಕೇಂದ್ರದಲ್ಲಿ ದೈಹಿಕ ಹಾಗೂ ಮಾನಸಿಕ ಬಹುನ್ಯೂನತೆಯುಳ್ಳ ಮಕ್ಕಳು ಸುಮಾರು 55 ಮಕ್ಕಳು ವಿವಿಧ ಹಂತಗಳಲ್ಲಿ ಪುನಶ್ಚೇತನ ಸೇವೆಯನ್ನ ಪಡೀತಾ ಇದ್ದಾರೆ. ನಮ್ಮಲ್ಲಿ ಸೆರೆಬ್ರಲ್ ಪಾಲ್ಸಿ ಪೀಡಿತ ಮತ್ತು ಅಂಗಾಂಗ ನ್ಯೂನತೆಯುಳ್ಳ ಮಕ್ಕಳಿಗೆ ದಯಾನಂದ ಸಾಗರ್ ಕಾಲೇಜ್ ಆಫ್ ಫಿಸಿಯೋಥೆರಪಿಯ ವಿದ್ಯಾರ್ಥಿಗಳು ಫಿಸಿಯೋಥೆರಪಿ ಚಿಕಿತ್ಸೆಯನ್ನು ಸುಮಾರು 2 ವರ್ಷಗಳಿಂದ ನೀಡ್ತಾ ಇದ್ದಾರೆ. ಈ ಕೆಲಸದಲ್ಲಿ ಕಾಲೇಜಿನ ಪ್ರಾಂಶುಪಾಲರಾದ ಶ್ರೀಮತಿ ಸತ್ಯ ಗುರುಪ್ರಸಾದ್ ಹಾಗೂ ಫಿಸಿಯೋಥೆರಪಿ ವಿಭಾಗದ ಮುಖ್ಯಸ್ಥರಾದ ಡಾಕ್ಟರ್ ಶ್ರೀಹರಿ ಶರ್ಮಾ ಅವರು ಅವರ ಕೊಡುಗೆ ಬಹಳ ಅಮೂಲ್ಯವಾಗಿದೆ. ಈ ಇಬ್ಬರು ವ್ಯಕ್ತಿಗಳು ನಮ್ಮ ಕೇಂದ್ರಕ್ಕೆ ಬಂದು ಅವರ ವಿದ್ಯಾರ್ಥಿಗಳು ಮಾಡುತ್ತಿರುವ ಚಿಕಿತ್ಸೆಯನ್ನ ಗಮನಿಸುವುದು ಮತ್ತು ಸೂಕ್ತ ಸಲಹೆಯನ್ನು ನೀಡುವುದನ್ನು ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ದಯಾನಂದ ಸಾಗರ್ ಕಾಲೇಜ್ ಆಫ್ ಫಿಸಿಯೋಥೆರಪಿಯ ವಿದ್ಯಾರ್ಥಿಗಳು ನಮ್ಮ ಮನೋನಂದನಾ ಕೇಂದ್ರದ ಮಕ್ಕಳಿಗೆ ಇಂಟೆನ್ಸಿವ್ ಫಿಸಿಯೋಥೆರಪಿ ಹೆಸರಿನಲ್ಲಿ ಕುಟುಂಬವು ತನ್ನ ಧನ್ಯವಾದಗಳನ್ನು ಈ ಮೂಲಕ ಅರ್ಪಿಸುತ್ತೇವೆ. ನಮಸ್ಕಾರ.
ಇದೊಂದು ಅಬಲಾಶ್ರಮದ ಕಾರ್ಯಕ್ರಮ. ಬರೀ ಜನರಲ್
I feel a well-designed curriculum that has both theoretical knowledge as well as hands-on practical skills. They give us a lot of resources, be it libraries or access to research publications, mentors. We have also been very privileged to be trained in specializations in hospitals such as obstetrics and gynecology, orthopedics, intensive care units and so on. The college also comes with a lot of labs, such as the community-based rehabilitation lab, the electrotherapy lab, where we have well-advanced modalities like a combination of laser and ultrasound.
We have a well set of dedicated faculty members, while there also are academic counselors and mentors.
I would say the different approach we take in this campus. We take a research-based, proven aspects of the studies. For example, evidence-based practice. When we treat patients, we use up-to-date research. We use protocols that have been certified and verified from international institutions.
There are various resources, like we have various labs like the neuro lab, the research lab, the community-based rehabilitation labs. We have a well-equipped library. All the labs are equipped with new modalities that are, I think, very important in a healthcare field, because it's important to stay updated. Like every day there's a new research happening and every day we're coming up with new equipments. So for example, the research lab has the skin fold calipers, which helps us measure the body fat composition, or we have the hand dynamometer, which helps in the hand grip strength measurement. So I feel like it's a great place to pursue academics and will definitely also help you with your personal growth.
I feel a well-designed curriculum that has both theoretical knowledge as well as hands-on practical skills. They give us a lot of resources, be it libraries or access to research publications, mentors. We have also been very privileged to be trained in specializations in hospitals such as obstetrics and gynecology, orthopedics, intensive care units and so on. The college also comes with a lot of labs, such as the community-based rehabilitation lab, the electrotherapy lab, where we have well-advanced modalities like a combination of laser and ultrasound.
We have a well set of dedicated faculty members, while there also are academic counselors and mentors.
I would say the different approach we take in this campus. We take a research-based, proven aspects of the studies. For example, evidence-based practice. When we treat patients, we use up-to-date research. We use protocols that have been certified and verified from international institutions.
There are various resources, like we have various labs like the neuro lab, the research lab, the community-based rehabilitation labs. We have a well-equipped library. All the labs are equipped with new modalities that are, I think, very important in a healthcare field, because it's important to stay updated. Like every day there's a new research happening and every day we're coming up with new equipments. So for example, the research lab has the skin fold calipers, which helps us measure the body fat composition, or we have the hand dynamometer, which helps in the hand grip strength measurement. So I feel like it's a great place to pursue academics and will definitely also help you with your personal growth.
I feel a well-designed curriculum, both theoretical knowledge as well as hands-on practical skills. They give us a lot of resources, be it libraries or access to research publications, mentors. We have also been very privileged to be trained in specializations in hospitals such as obstetrics and gynecology, orthopedics, intensive care units, and so on. The college also comes with a lot of labs, such as the community-based rehabilitation lab, the electrotherapy lab, where we have well-advanced modalities like a combination of laser and ultrasound.
We have a well set of dedicated faculty members, while there also are academic counselors and mentors.
I would say the different approach we take in this campus. We take a research-based, proven aspects of the studies. For example, evidence-based practice. When we treat patients, we use up-to-date research. We use protocols that have been certified and verified from international institutions.
There are various resources, like we have various labs like the neuro lab, the research lab, the community-based rehabilitation labs. We have a well-equipped library. All the labs are equipped with new modalities that are, I think, very important in a healthcare field, because it's important to stay updated. Like every day there's a new research happening and every day we're coming up with new equipments. So for example, the research lab has the skin fold calipers, which helps us measure the body fat composition, or we have the hand dynamometer, which helps in the hand grip strength measurement. So I feel like it's a great place to pursue academics and will definitely also help you with your personal growth.
At Dayanand Sagar University's Haro-Haldi campus, the College of Physiotherapy is dedicated to providing students with a top-notch education in the field. The curriculum is designed to give students a comprehensive understanding of the human body and its functions, along with experiential training in the latest physiotherapy techniques. What sets our department apart is our ultra-modern facilities, including sophisticated classrooms and clinical training rooms. Our students have access to the latest technology and equipment, allowing them to hone their skills and knowledge to the highest degree. The faculty at the College of Physiotherapy is comprised of experienced professionals who are dedicated to their students' success. With our modern amenities and a supportive community, Dayanand Sagar University's College of Physiotherapy is the ideal place for aspiring physiotherapists to begin their journey. At Dayanand Sagar University's Harohaldi campus, the College of Physiotherapy is dedicated to providing students with a top-notch education in the field. The curriculum is designed to give students a comprehensive understanding of the human body and its functions, At Dayanand Sagar University's Harohaldi campus, the College of Physiotherapy is dedicated to providing students with a top-notch education in the field. The curriculum is designed to give students a comprehensive understanding of the human body and its functions, along with experiential training in the latest physiotherapy techniques. What sets our department apart is our ultra-modern facilities, including sophisticated classrooms and clinical training rooms. Our students have access to the latest technology and equipment, allowing them to hone their skills and knowledge to the highest degree. The faculty at the College of Physiotherapy is comprised of experienced professionals who are dedicated to their students' success. With our modern amenities and a supportive community, Dayanand Sagar University's College of Physiotherapy is the ideal place for aspiring physiotherapists to begin their journey. At Dayanand Sagar University's campus, the College of Physiotherapy is dedicated to providing students with a top-notch education in the field. The curriculum is designed to give students a comprehensive understanding of the human body and its functions, along with experiential training in the latest physiotherapy technique. What sets our department apart is our ultra-modern facilities, including sophisticated classrooms and clinical training rooms. Our students have access to the latest technology and equipment, allowing them to hone their skills and knowledge to the highest degree. The faculty at the College of Physiotherapy is comprised of experienced professionals who are dedicated to their students' success. With our modern amenities and a supportive community, Dayanand Sagar University's College of Physiotherapy is the ideal place for aspiring physiotherapists to begin their journey. At Dayanand Sagar University's Harohaldi campus, the College of Physiotherapy is dedicated to providing students with a top-notch education in the field. The curriculum is designed to give students a comprehensive understanding of the human body and its functions, along with experiential training in the latest physiotherapy techniques. What sets our department apart is our ultra-modern facilities, including sophisticated classrooms and clinical training rooms. Our students have access to the latest technology and equipment, allowing them to hone their skills and knowledge to the highest degree. The faculty at the College of Physiotherapy is comprised of experienced professionals who are dedicated to their students' success. With our modern amenities and a supportive community, Dayanand Sagar University's College of Physiotherapy is the ideal place for aspiring physiotherapists to begin their journey. At Dayanand Sagar University's Harohaldi campus, the College of Physiotherapy is dedicated to providing students with a top-notch education in the field. The curriculum is designed to give students a comprehensive understanding of the human body and its functions, along with experiential training in the latest physiotherapy techniques. What sets our department apart is our ultra-modern facilities, including sophisticated classrooms and clinical training rooms. Our students have access to the latest technology and equipment, allowing them to hone their skills and knowledge to the highest degree. The faculty at the College of Physiotherapy is comprised of experienced professionals who are dedicated to their students' success. With our modern amenities and a supportive community, Dayanand Sagar University's College of Physiotherapy is the ideal place for aspiring physiotherapists to begin their journey. At Dayanand Sagar University's Harohaldi campus, The College of Physiotherapy is dedicated to providing students with a top-notch education in the field. The curriculum is designed to give students a comprehensive understanding of the human body and its functions, along with experiential training in the latest physiotherapy techniques. What sets our department apart is our ultra-modern facilities, including sophisticated classrooms and clinical training rooms. Our students have access to the latest technology and equipment, allowing them to hone their skills and knowledge to the highest degree. The faculty at the College of Physiotherapy is comprised of experienced professionals who are dedicated to their students' success. With our modern amenities and a supportive community, Dayanand Sagar University's College of Physiotherapy is the ideal place for aspiring physiotherapists to begin their journey.
I feel a well-designed curriculum that has both theoretical knowledge as well as hands-on practical skills. A lot of resources, be it libraries or access to research publications, mentors. We have also been very privileged to be trained in specializations in hospitals such as obstetrics and gynecology, orthopedics, intensive care units, and so on. The college also comes with a lot of labs, such as the community-based rehabilitation lab, the electrotherapy lab, where we have well-advanced modalities like a combination of laser and ultrasound.
We have a well set of dedicated faculty members, while there also are academic counselors and mentors.
I would say the different approach we take in this campus. We take a research-based, proven aspects of the studies. For example, evidence-based practice. When we treat patients, we use up-to-date research. We use protocols that have been certified and verified from international institutions.
There are various resources, like we have various labs like the neuro lab, the research lab, the community-based rehabilitation labs. We have a well-equipped library. All the labs are equipped with new modalities that are, I think, very important in a healthcare field, because it's important to stay updated. Like every day there's a new research happening and every day we're coming up with new equipments. So for example, the research lab has the skin fold calipers, which helps us measure the body fat composition, or we have the hand dynamometer, which helps in the hand grip strength measurement. So I feel like it's a great place to pursue academics and will definitely also help you with your personal growth.
I feel a well-designed curriculum that has both theoretical knowledge as well as hands-on practical skills. They give us a lot of resources, be it libraries or access to research publications, mentors. We have also been very privileged to be trained in specializations in hospitals such as obstetrics and gynecology, orthopedics, intensive care units, and so on. The college
Morning and welcome to one and all present here. So we'll be moving on to the next session for today. The second plenary session for today will be taken by Dr. Jayant Sundar Sampath on the topic 3D gait analysis in the diagnosis of ankle and foot condition. Sir is a pediatric orthopedic surgeon, founder and director, Bangalore Institute of Movement Analysis and Research, BIMRA. He practiced in the UK and US for 15 years. Sir completed clinical fellowship in pediatric orthopedics at Alfred Hospital for Children and Manchester Children's Hospital. Sir is one of the few orthopedic surgeons in India to use 3D gait analysis for decision making in children with cerebral palsy. Sir has various international publications and book chapters. Please welcome Dr. Jayant Sundar Sampath. The session will be chaired by Dr. Nandini, Assistant Professor, Amity University, Jaipur, and Dr. Rakesh, Associate Professor, Nita Institute of Physiotherapy. So you may start the session. I request the participants, if you have any doubt in between the sessions, please put up your questions in the chat box.
Shall I start my presentation? Is it okay to share my screen? A chairperson will be making any comments? Or? Hello? Can you hear me?
You can share the screen.
Dr. Srihari, would you like me to start the presentation or?
Sir, good morning.
Morning.
So you can start with your presentation.
So your voice is not audible, sir.
My voice is not audible? I think I am audible.
Yes, sir.
Okay, I'll go ahead and start by.
Thank you, sir.
Everybody can see my screen? Yes, great. So thank you for the invitation from Anand Sagar University for me to participate in this session. It's a pleasure to interact with clinicians from different fields, and gait analysis is a subject that I've been interested in for some time, and I hope we can share some thoughts about gait analysis in the management of foot and ankle problems today. My particular thanks to Dr. Srihari, who has been working closely with us to start a certificate course in gait analysis. I will give more details at the end of my talk. My screen is not moving. So movement analysis is ubiquitous in daily life. So you might have seen a lot of Hollywood movies with movement capture. A lot of special effects that are used in Hollywood is based on movement analysis and movement capture technology. I'm sure all of you follow cricket. So a lot of decisions these days, LBW, etc., is again based on movement analysis technology. And there are various video games that also use movement of the human body to allow some degree of interaction between the player and the game environment. So it's becoming ubiquitous in our daily lives. So the same technology is what we use for 3D gait analysis in clinical practice. So gait analysis, the history goes back a very long way, 2,500 years ago, to the days of Aristotle. But Aristotle did not have any special technology. He only had his own eyes to capture movement. So these are the pictures he drew of how a horse gallops. And you can see that he is mimicking how a human being walks, which is with a contralateral gait. So where your right hand and your left leg go forwards and your left hand and your right leg goes forward. So he thought that horses would also gallop in a similar way, because our human eye cannot capture single frames of a continuous movement. So we just don't have that kind of ability in our brain to be able to do that. And then once photographic technology and film technology, cinematography came into place in the sort of 19th century, and we actually captured actual horses running, we found that there was a huge difference between how horses actually run or gallop and what Aristotle thought. So it just goes to show that just looking at things, capturing things with our own eyes and analyzing it with our brains, particularly things that are moving very fast, can be difficult, and there are inherent problems. So the slide on your right, that's Dr. Jim Gage from the United States. He worked initially in Minneapolis, and he was one of the founding fathers of gait analysis. He was at Connecticut Children's Medical Center, which is where this photo was taken. And people like Dr. Gage have been instrumental in introducing this technology and implementing it in clinical practice. And a lot of the books that are written today, the principles of that were written by Dr. Gage and his colleagues. So the limitations of observational gait analysis is that the human eye is incapable of capturing discrete events that happen at a rate faster than 18 frames per second. So this is the absolute limit of the processing power of our eyes and brain. So a child with CP or an injured athlete has problems at several levels and in all three of the cardinal planes, the coronal, sagittal, and transverse plane. And these movements are happening at somewhere between 100 and 250 frames per second during normal gait or during running or athletic activities. So it becomes impossible for the human eye to be able to capture these finer movements in detail, and technology becomes essential to aid in the clinical decision-making process. So 3D movement analysis is essentially a diagnostic test. It is a test of walking parameters. We use objective data such as walking velocity, step length, and cadence. These are automatically captured and calculated by the modern base systems. We also capture the movements of joints in 3D. This is called kinematics. We measure forces going across each joint This is called kinetics. We do that with force plates. We have EMG probes that capture the movement, the activity of muscles during different movements. And especially for the foot and ankle, we use dynamic pedobarography. And all of this data can be integrated in a time-dependent manner by the computer. So at any point of the gait cycle, you can see what is the kinematic, what is the kinetic, what is the EMG measurement, and what is the pedobarography measurement at the same time. So modern day computers allow us to do that, and all of this happens automatically. So this is a 3D gait lab. This is our previous gait lab in Bangalore. We modernized since this lab was first started about 11 years ago. So we have infrared cameras that capture the movements of markers in 3D. We have optical cameras, a force plate on the ground, and then a very powerful computer that integrates all this data. So the process is we do a history and a detailed physical examination, just like a routine clinical assessment. And then we attach markers to specific points on the patient's body. The patient then walks at a self-selected speed on a walkway, which includes a force platform. And then automatically the data is captured by the system. So this is a young man who is undergoing 3D gait analysis. You can see that he has got markers stuck at various points in his body. These are all predetermined points. But when you shine light on these markers, they become bright points in space. And this 3D space is then captured by the system, and then we get a 3D biomechanical model. So why 3D kinematics? Why not just 2D? The problem is that when you have frequently joints flex and extend during normal walking or running, and your perspective matters greatly. So if you have a joint that is bent by 45 degrees, but you're looking at it not in an orthogonal plane, but you're looking at it at an angle, you will actually see that there is less of an angle. So visual analysis has an inherent weakness in that if you have flexion and you have torsion, then it's difficult to know what is the actual degree of flexion of a joint. So this is the typical kinematic graph that we get from the system. So the pelvis, the hip, the knee, and the ankle are represented in the columns. The frontal, sagittal, and transverse planes are represented in the vertical axis. So for instance, this is the kinematic of the knee in the sagittal plane, and this is the kinematic of the hip in the transverse plane. So I won't go into the details of what these graphs represent. We have a separate course for that. But just to give you an idea that each gait cycle is captured and the movements of the joints are represented at each joint in each plane separately. And we have normal values for this based on analysis of normal healthy subjects. And then we compare the kinematic of the subject against the normal standard. So we have 9 graphs of clinical significance, and we have 6 events during the gait cycle when we are interested in what is the actual flexion or extension, or what is the movement of the joint, the position of the joint. So technically we have 54 events that happen every second during the human gait cycle. And this is the amount of data, the density of data that we capture during 3D gait analysis. And you can easily appreciate that it is virtually impossible to do this in any other way. So just to compare 2D and 3D analysis, so 2D analysis has the advantage that it is quite familiar to orthopedic surgeons and therapists. These days you can do it with your mobile phone. It's particularly good for understanding movements and position of the foot and ankle, and also the trunk and upper limb, which is important in hemiplegics and in athletes. The weakness is that it is not 2D analysis cannot provide data regarding torsion, which is particularly important in CP, but also in athletes and other things. I think that the transverse plane is also important for us to know as clinicians. And it is equally time consuming to analyze the data, whether you do it 2D or 3D. The pelvis is difficult to visualize using 2D technology, but it requires extra software to process and to synchronize videos. 3D analysis provides detailed kinematic data at all levels from the foot to the pelvis. Therefore, you're able to analyze the entire kinematic chain. We can also apply various quantitative gait indices which are useful for research. And currently, 3D gait analysis is considered as the gold standard in that it provides reliable and accurate data that guides the surgeon and other clinicians to the highest quality of clinical decision making. However, it requires specialized equipment. Sometimes you need to have a team. Swamindra, who's a therapist, he's also joined us as part of this panel discussion, and he's part of my team, and he's the person who does most of the hard work in acquiring and processing the data. So you need to have a team of professionals who work together. So it cannot be done as an individual, or it becomes very tedious to do it as an individual. Previously, 3D gate systems were very expensive, but the cost of it is going down, and I'll talk about this later. The foot model is quite simple. There are complex foot models like the Oxford foot model, but in practice, they are very difficult to apply and require a lot of training. So indications for 3D gait analysis are twofold. The first is for patients, and the other is for athletes and sports persons. The commonest indication is cerebral palsy. We also use it in children with spina bifida or post-polio paralysis in adults. We also use it for post-stroke neurological sequelae in adults, Parkinson's. A lot of applications are there for gait analysis. And I feel in the 21st century, every clinician who is involved in movement science, be it a therapist or a podiatrist or an orthopedic surgeon, any professional or a biomechanist, or even a sports, sports science engineers. So a lot of people are getting an increasing interest in this exciting new and developing field. So athletes and sports persons, we can do 3D running analysis for them to diagnose their injuries. I just want to give you an example of a 10-year-old girl, GMFCS level 2 diplegic CP. She's a community walker and came to us with a history of frequent falls and awkward gait. So this is a video. I hope everyone can see that she has some movement at the pelvis. You can see that there is some abnormal movement at the knee and the ankle. So based on physical examination, we recommended that she requires 9 separate surgeries in order to correct all the gait problems. And then we did a 3D gait analysis and found that she had problems only at 6 levels. So we were effectively able to save this girl 3 operations that would otherwise that would be unnecessary. So gait analysis really helps us to refine our surgical decision making and do appropriate surgery for children with cerebral palsy. And this is 1 year after the gait analysis. You can see she's walking after the surgery. She's walking with more confidence, better speed, and less or fewer abnormal movements. Her falls have reduced, and she's also much more confident because the awkwardness in her gait is gone. And this is the post-op gait analysis, and you can see that a lot of the gait parameters have returned to normal values. So 3D gait analysis helps us to decrease the surgical dose and modify the surgical plan. It is also of immense use to therapists in determining what is the best post-op physiotherapy protocol, which muscles are weak, which muscles are tight, what needs flexibility, what needs better strength, etc. So it's really a very advanced and useful technology. The other system that I will be covering in my talk today is 3D running analysis, and we have a 3D running analysis system from Canada. This is based on a lot of research by very eminent researcher from Canada called Dr. Reid Faber. So I'll just talk to you about our running system. It's called 3D Gate. I think we are the only center in India who have this particular system. So running injuries are very common. I'm sure as therapists, you're very aware of all these various problems, starting from the lower back all the way down to the foot, which frequently interfere with the athlete's ability to participate freely in their chosen sport. So if you analyze the causes of running injuries, they fall under 4 major categories, namely biomechanics, strength, alignment, and flexibility. So all of these 4 factors together, they kind of interact together in order to ultimately result in an injury. So when we do a running analysis, obviously we take a very detailed injury history. We also look at how much they are running, how frequently they are running, what speed, etc. And then we do a fitness evaluation, looking at things like flexibility, strength, balance, and endurance. We perform specialized functional tests. And we also record the runner's movement pattern through the 3D motion capture cameras. So the rationale is that running is a dynamic, interlinked movement of the foot and ankle, the knee, the hip, and the pelvis. And all of these joints are interacting together in order to produce the running pattern. So symptoms that occur at the foot may be due to problems that are occurring at a completely different level. All of you will be familiar with common scenarios like lower back pain being due to poor alignment of the foot, and vice versa, and foot problems happening because of problems at the knee or hip. So it's important to know what movements are happening and also the timing of these movements at each joint at various parts of the running cycle. So we look at range of motion, which is objectively assessed at every joint in all planes. We look at anatomical alignment, Q angle, etc. Also thigh foot angle, and what is the amount of heel valgus, neutral, or varus. We measure the limb lengths, both true and apparent. And then we do these functional tests, navicular drop test, for instance, to assess midfoot stability. We do the ankle dorsiflexion lunge test to look at calf flexibility, and also hamstring and lumbar spine flexibility with the sit and reach test. Pelvic bridging test helps us to look at core and gluteus strength, which gives us a measure of pelvic stability. And then we place 30 plus markers, and these are called cluster markers, which is useful for running analysis. And then the system automatically produces this 3D virtual image of the lower limbs. And this virtual image dynamically changes as the person runs. So we have a television in front of the subject, and as they are running, they can actually see how their body is moving, and it helps them to dynamically make corrections to their pattern of walking or running. So that's a subject actually undergoing a running trial. So one may ask that running on a treadmill is different to running on a track or running on the in the community. It's very difficult for us to capture movement in running in the community, though I'll talk to you about a more a recent technology that's come in, which will help us to do that as well. But what we do is to tell the runner, ask the runner at what normal speed they run, and we try to recreate their normal running conditions using a treadmill. So this is a typical output that we get from our 3D gate system. We look at various parameters at in the ankle complex, peak pronation, pronation velocity, time to peak pronation, etc. And we have normal values which are captured from 800 healthy athletes to tell us whether these values are within ideal limits, excessive or reduced. And then we have a clinical algorithm that helps us to interpret this data. So you can see, for instance, time to peak pronation, if it is late, it can be because of foot and ankle factors, but it can also be because of increased hip and knee collapse. So it's important for us to understand that problems that manifest in the foot and ankle may not have their origins in the foot complex and ankle complex, but they may have their origin or etiology at a completely different level. And advanced technology like gait analysis is very important for us to understand these complex interactions. Similarly, at the hip, at the knee, and then we have various functional measurements. So what do we get out of it? We get various patterns. So we have side-to-side asymmetry, which can mean that there is an antalgic gait. We have something called frontal plane pattern, transverse plane pattern, and muscle weakness patterns. So by analyzing and interpreting the various parameters, we have 25 parameters. What we try to do is to see which pattern the particular subject fits into, and that allows us to summarize their overall biomechanical pattern and give them a targeted exercise program that will address their underlying issue and also improve their overall pattern of running. We can also make detailed footwear recommendations based on the individual foot mechanics of the runner. All this helps to ensure that the runner has an easier run. It increases their efficiency and reduces their risk of injury. So the future of gait analysis is this. These are called inertial measurement units, or IMUs. We don't need a lab for this. We can do it on field with no fixed location. The data is captured in real time and at high speed. And this really is the future. And IMU technology, thankfully, is a lot less expensive compared to the traditional gait analysis software and hardware. So you can see how this person is doing rowing. This is an elite athlete who is training at the Center for Sports Sciences, which is an institution in Bangalore. It's at Kantirva Stadium. And this is an institution that's using movement analysis in their day-to-day practice to improve the efficiency of elite athletes and sports persons. So this is that was a product from the Netherlands. This is an Indian product. It's a startup started by a group of IIT engineers. Gunjan is working with us to validate the Indian technology, and I think as clinicians we should support homegrown talent. He has been working on this for the last 5 years, and it's almost nearing a stage where it can be used in clinical practice. So I think all of us should support these startups and up and coming engineers who are trying to bring all these technologies into our daily lives. So this is the final frontier, as it were, which is markerless movement analysis. This, I think, with AI and all their complex algorithms, I think this is very much something that will be feasible in the next few years. At the moment, the technology is not advanced enough for us to be able to use it because the data lacks accuracy. But I think it's only a matter of time before we get into a situation where just using our mobile phones, we will be able to do quite good quality 3D movement analysis. So there's a lot of scientific evidence supporting the use of 3D gait analysis. These are some papers from the CP literature that shows that the amount of surgery that was carried out was less when 3D gait analysis was used, and also more appropriate surgery was done and fewer mistakes happened. So again, some more papers that showed that when pre-op gait analysis is used, it had a substantial effect on orthopedic decision making. There's also a lot of literature from patients undergoing joint replacements, patients having anterior cruciate ligament injuries, problems in the spine, and also there's a lot of gait analysis literature on flat foot. It showed that symptomatic flat foot has lower efficiency of walking, and gait analysis can be used to distinguish even within flat foot, because not all children with flexible flat foot have gait problems. So it helps you to distinguish within flexible flat foot which children have a efficient gait, they're able to compensate, and which children are unable to compensate. So in summary, 3D gait analysis is no longer a research tool that is used only in universities. It is an essential part of clinical decision making prior to any intervention, however minor. The time has come for us to learn about, adopt, and use this valuable technology for the benefit of our patients. And in due course, I think this kind of technology will become as common as a MRI. So I just want to inform everyone present in this session that Dayanand Sagar University, along with our institution, Bangalore Institute of Movement Research and Analysis, BIMRA, we are starting a 3-month program, a certificate course in movement analysis. This will be the first time in India that an effort like this has been started. So it will have 60 credit hours, including 12 credit hours, which will be hands-on experience in our 3D gate lab. We have online lectures and coursework, and we have 20 distinguished faculty with a huge wealth of experience in movement analysis from Asia, Europe, and the United States. So I encourage all of you to sign up for the certificate course and learn more about this valuable new advance. Thank you so much. So Swimindra is a member, integral part of our team. He's part of the panel today. And this is our email address. If you have any queries, you're welcome to mail either of us. Thank you so much.
Thank you, sir, for sharing your insight on 3D gate analysis. We are truly motivated by the impact of your contribution to the community. I would also like to thank our chairpersons for the session, Dr. Nandini and Dr. Rakesh. I would like to request them if they would like to discuss on this particular topic. Meanwhile, I request the delegates, if you have any questions, please put up your questions in the chat box.
So regarding the details of the course and fee structure, I would request everybody to contact Dr. Srihari Sharma from Dayanand Sagar University for further details. I'm sure the university will send out, College of Physiotherapy at DSU will send out flyers to everyone. So it is the first time we are doing something like this in India. And I think particularly therapists who are interested in sports science, in movement analysis, biomechanics will really benefit from this. Similar courses are available abroad, but they are quite expensive and difficult to access. And one has to actually travel to Australia or Europe or to the United States to get the same amount, to get similar content. So we are trying to make this available in a user-friendly format for the benefit of clinicians in India.
Morning, sir. Am I audible, ma'am? This is
Yes.
Rakesh.
Hi.
Am I audible, sir?
Yes, you're audible.
Yes, sir. So many thanks for a wonderful presentation, sir. And most of the details related to sports and as well as conditions specifically into cerebral palsy has been covered in your presentation. And one of the unique setup, and you have definitely a good team based on your presentation, and it's a tremendous job for the society, even for the cerebral palsy population. Sir, I have one query, sir. I would like to ask with your permission. If a child is walking with a handheld mobility device, in pediatric rehabilitation setup, when I see the children, level 1 and 2 in GMFCS, we will get after a lot of hard work. So, but they will be mostly in the level 3. So there is very less literature on level 3 GMFCS into 3D gate analysis. So can anything can be done with a handheld mobility device with GMFCS level 3 in CP population?
Sure. I mean, we do use even our gate lab to assess children who are GMFCS level 3. So the walker interferes sometimes with being able to capture the markers. So what we do is to have the parents hold the child's hand on either side, and we try and reproduce the child's movement pattern. It is not 100% accurate in the strictest scientific sense of the word, but we do get a lot of useful information that is otherwise not available to us with observational gait analysis, particularly in the transverse plane. So, and particularly at the pelvis, which is very important in GMFC's level 3, because operations like hamstring release, which is frequently done in this particular patient population, it is very dependent, the success of a hamstring surgery or even calf surgery, a lot of it is dependent on what is the position of the pelvis. And the position of the pelvis frequently cannot be seen properly with just visual or observational gait analysis. So the 3D data gives us additional information regarding the pelvis position in the sagittal plane, and it gives us additional data regarding the transverse plane, which is very important for us in our orthopedic surgical decision making. So I would certainly encourage, even in the level 3s, to go ahead and use gait analysis, because some additional information will be available to you, which will help you make a more appropriate treatment plan for the child. It also helps to monitor their overall progress. So even a child who's not having surgery, having a gait analysis every 1 or 2 years gives you some objective data as to how the child is doing. Is the child improving? Are they the same? Is there any deterioration? And it makes you ask important questions about why. And what the 3D gait analysis does is to prompt your thinking process in the right direction, so that you're asking the right questions.
Thank you so much, sir. Sir, one more small thing, like when you are performing 3D gait analysis, whether utility of Botox, whether you will be considering them, or you will be asking them, like if you have taken Botox, then analysis should be done only after around 6 months?
Yes. So typically we don't, if there has been any intervention, typically we avoid doing gait analysis for at least 12 months. So because we want to know the effect of the intervention, which will take around 12 months for the final impact to be known, or we don't want any confounding, we don't want the intervention to be a confounding factor. So obviously we wait for a period of time, if surgery or casting or Botox, anything has been done, we typically tend to wait for at least 6 months, if not a year, before doing an analysis.
Thank you so much, sir. Thank you.
A very good morning to everyone, to Dr. Jayant and all the delegates of DSU Symposium Conference. So here, Dr. Jayant, I just want to thank you for an amazing presentation. It was very engaging and also it was very factful. What I exceptionally liked about the presentation was the practical examples. So being a physiotherapist and working in this field since a very long time, what we go through is a lot of subjective and objective assessment that we also take for the gait. But 3D gait analysis is something that will allow us for a comprehensive and a more accurate diagnosis for the patient. And there's one question, sir, that I wanted to ask significantly was, you gave us one example of a diplegic CP patient, where you said that after the assessment, there were 9 surgeries that was needed, 3, and after the accurate diagnosis, 3 were ruled out and 6 were still done on the patient. So was there a possibility that if a thorough physiotherapy assessment or a thorough physiotherapy protocol pre and post the surgery would have been applied, so there could have been any better outcome for the patient?
Absolutely. I mean, physiotherapy is, I say that I do 20% of the work with the operation and the physiotherapist does 80% of the work post-op, and the parents. So, there's absolutely no doubt. We work as a team. We have 3 therapists in our department. Swamindra doubles as a biomechanist, and he is the manager of the gait lab. Plus, he's also a practicing therapist. So when you have a therapist like Swamindra, who have one foot in both he's a practicing clinician who is treating patients. Plus, he has knowledge of gait analysis. It really enhances his thought process, his decisions, and his treatment when he's a clinician. So what gait analysis does, it gives you better data, but it also makes you a better clinician because it makes you think in a completely different way. That is what we are hoping to achieve with improving awareness amongst therapists, is that gait analysis is not just a tool which will just give you some data. It will actually change the way you think. And that, I think, is a significant additional benefit of gait analysis. Any comments, Swimindra?
Yeah, absolutely, yes, sir. Like the understanding of the patient without the gait analysis and with the gait analysis absolutely differs. So it will add much more information, in-depth information for you to understand how the person is doing. That's really helpful.
Thank you so much, sir. Your explanations were extremely insightful, and the practical examples of how the things are done, how the markers are placed, and how does the graph shows, it is very, very factful today. And also, I would really like to wish you all the best and congratulate you for the course that you are coming up with, which is very, very, very important for all the physiotherapists, to be very honest, the gait analysis. And you're bringing that here in this education system. I feel it is something that should be mandated at every college, because we are not just someone who is associated with movement science, but we are someone who makes things better. And gait is one of the very important aspects to improve the quality of life. So I hope the course and everything goes really better. Thank you so much, sir.
So, and as an aside, anyone listening to this is welcome to contact myself, Swimindra, and you're welcome to visit the lab. So we would like gait analysis not just to be something that you read about in a textbook and you don't really understand how it can be implemented in your daily clinical practice. It is a very simple, practical technology that you can come and learn. We are very happy to teach you. Please email us or contact us, and we'd be very happy to, if you could come and spend at least a day or two in the lab. So it will completely demystify the whole process, and you'll see how simple, easy, and accessible it is. So we are open to welcoming visitors at any time, and we'd be happy to take you through how gait analysis is actually done. We'll show you case examples. So we are very open to discussion. If there are no more questions, I would like to thank on behalf of Swimindra and myself to Dr. Srihari, all the faculty members of School of Physiotherapy at Dayanand Sagar University. It was a real pleasure to have joined you today for the symposium, and thank you for the invitation.
Thank you, Dr. Jayant, and thank you, Dr. Nandini and Rakesh, for their expertise and guidance, which enriched our understanding and sparked a meaningful discussion. Thank you, sir. Now we'll be moving on towards our next session, which is the innovative talks. Innovative physiotherapy is not just about treating pain. It's about unlocking the body's innate potential to heal, adapt, and thrive. But by integrating advanced techniques and holistic approaches, we empower individuals to reclaim their movement, rediscover their strengths, and redefine their limits. Innovation in physiotherapy is crucial for advancing physiotherapy care and enhancing recovery outcomes. By integrating cutting edge technology and evidence based practices, we can develop more effective treatment strategies, personalize rehabilitation programs, and ultimately improve the quality of life for the individuals. Embracing innovation not only pushes the boundaries of what's possible, but also ensures we stay at the forefront of medical advancement, delivering the best care to those who need it the most. Now, moving on towards the innovative talks beyond boundaries, treatment ideas in science and technology, I would like to start the session with a quote. Innovative physiotherapy is not just about pain, it's about unlocking the body's innate potential to heal, adapt, and thrive by integrating advanced technology and holistic approach. We empower individuals to rediscover their strength and thus redefine their limits. I request the delegates to prepare to be enlightened and motivate as we dwell into this thought-provoking talks, passing the way for new advancements. Our first innovative talk is by Dr. Reshwat on the topic Developing and Validation of Smart Footwear for Early Screening and Prediction of Diabetic Foot Syndrome. Dr. Reshwat is founder and director of Footrix Private Limited and co-founder at Libya, Hyderabad. Sir is a visionary in his field and has numerous innovative research projects to his credits. Sir has achieved significant milestones and garnered various accolades for his groundbreaking work. Now, I would also like to welcome the chairpersons for this session, Dr. Anil T. John, Professor and HOD at College of Physiotherapy, PES University, and Dr. Vinod Babu, Principal and Professor, Gotham College of Physiotherapy.
Hello. And screen visible to hello. Am I audible?
Good morning, this is Jashwant. You are audible.
Yeah.
And your slides are also visible on the screen.
Yes. Can I start, sir?
Dr. Anil, sir, are you here? Dr. Anil? Yeah, Mr. Jashwant, you can start the session.
Okay, sir. So, good morning to everyone. I am here presenting about the development and validation of smart footwear for early screening and prediction of diabetic foot syndrome. So, we are a team of 2 members. We have established our company in the year 2023. The name is Footrix Healthcare Private Limited. So, I partnered with the Dr. Rishikesh Yadav, sir, who is a PhD in diabetic foot syndrome. At the same time, he is a physiotherapist. And coming to the overall, when we started this journey, I want to have a quick past about how we started this journey so far. So it's a program known as Center for Healthcare Entrepreneurship, where we met different professionals like doctors, business expertise, and the engineers come into a platform where we have gone into through serious 1 year program where we have assigned to different ecosystems in the healthcare, like focusing on unmet needs. Basically, we have exposed it to different hospitals, and we have been reporting every day-to-day task with with our CFHE Foundation team, where it consists of Professor Renu John and many of the beloved expertise. So we, in the months of August to September, we have exposed to different healthcare ecosystem and developing clinical thinking and creative skills where we are less awareness. Because I'm an engineer, I have less awareness in healthcare ecosystem. So this creates an impact to know more about the healthcare, how it is performing, and how we are able to implement an innovative program. At the same time, so all unmet needs cannot be made into a business. So we have to be going into the bio design thinking process, where this program is designed by the Stanford University. There we have the nearly about 30 to 40 unmet needs, and we have been ranking this so far like the top priorities, and with the different panelists and different doctors involvements, we are making it into a ranking system of about 1 to 30, and about the top 3 will be our top priority. Then when we got the top 3 of our program, we will be enhancing into the more deeper clinical immersion, followed by the incubation of the company. So this is the journey which we had done in the so far in the year 22 to 23. This is a 1-year fellowship program. And coming to the basic entrepreneurship, according to my view, entrepreneur is nothing but risk-taking capability. Whether it is success or failure, he has a gut feeling to make it successful and to make it helpful for the ecosystem. So, and simply, if I want to end up with the entrepreneur, what it means is a process of designing, launching, and running a new business. So it creates an ecosystem where it creates jobs and stimulates economic activity, and it drives the technological advancements and improves efficiency. Like if you take in the healthcare right now, AI is much more advancing in the different ecosystems. At the same time, the entrepreneurs are also creating more impacts with the help of collaborations of different doctors. So coming to the small view about the prevalence of the diabetes. So we have seen that by the IDF Diabetes Atlas 10th edition 2021, we have seen that there is a prevalence of market 9.6% in the year 2021. Among them, 10.6 are end up with diabetic peripheral neuropathy, and 25% of end up with foot ulcers, and every 11 amputations are happening per hour. This creates a lot of economic burden. So this are the summary where we do the market research and the so far whether there is a requirement. Before doing, we need to create a business, right? So far, we created the market survey and market research on entire diabetic, what we are taking the problem. So our preliminary research done by our co-founder, Dr. Rishikesh Yadav. So he found out that higher plantar pressure in diabetic neuropathy patients is usually than normal people. And there is an altered foot biomechanic patients in ulcer patients, and reduced sensory and motor and vascular supply in diabetic peripheral neuropathy than normal cases. So to sum up it, we came up with a good problem statement where we can say that foot complications are increasing diabetic population. So most of them are end up with amputations, and there are no effective screening and prediction devices that can predict the risk of future health risks. So in a summary, there are individual devices for this. So we are planning to integrate this entire device in a simple footwear where we can have an effective screening, and affordability also matters in this, right? So we are making into a footwear kind of device, which has a unique design in both diagnostic and prediction, and which is designed for functioning in all activity conditions, and which is very comprehensive, integrating multiple parameters, and it has to be durable, right, for longer duration and tension, and it is a customizable according to the footwear of the patient. So it's just like a simple walk test happening with this device. So coming to the team, Dr. Rishikesh Yadav sir, he is also co-founder and director. He is a PhD in diabetic foot syndrome. He has 17 scientific publications and 11 years of clinical expertise. And he is also PI and co-PI for many clinical trials in the field of physiotherapy and rehabilitation. His expertise is like clinical collaborations and sensors inputs as well. So myself, I am Reshwant. I am a mechanical engineer developing in this kind of device for the healthcare ecosystem, especially for the diabetic peripheral neuropathy patients. I'm also involved in many kind of business development and marketing strategies of the companies. I also did the fellowship from IIT Hyderabad. I'm expertise in CAD and sensors development and integrations. So coming to our below team members, Mr. Anirudh sir, He's an assistant professor from BRIT Institute of Technology. His expertise in embedded programming, AI computing, and Internet of Things, which creates a lot of impact in our project. I'll giving the insights like what is the current trend, how we can implement effectively through our devices. And another is Dr. Santosh Murthy sir, who is a podiatric surgeon at Advanced Food Clinic Center, Hyderabad. His expertise in diabetic foot neuropathy and offloading surgeries. And we had one more person who is a mentor, Dr. Rakesh Krishna Kovella. He is also associate professor in NITE Institute of Physiotherapy, Mangalore. His expertise in gait rehab and postural analysis. So we had a diversified team in such a we can develop a good ecosystem in the product and getting the best out of it. So coming to our collaborations, we have started since 1 year back, but we had a good collaboration, which is CFHA, Center for Healthcare Entrepreneurship. Where we had an incubation partner with them, and CIE IIIT Hyderabad, which everyone knows it is institute, and IKP Innovation Knowledge Park, and Yashoda Hospitals, NITE Institute for the clinical trials purposes, and Advanced Tool Clinic Center for getting the better output and better live patients data. So coming to our grants raised so far, we got a grant of BIRAP as a biotechnology ignition grant of about nearly 47 lakhs in the year 2023. And from our incubation partner, we have received about 25 lakhs from CFHA IIT Hyderabad. And from IIIT Hyderabad, we have raised about 5 lakhs of the Nidhi Prayas grant. So overall, we end up with currently 77 lakhs. And some of it, so we have found out that this is really a good market to focus on. At the same time, there is a need for the patients to, and the doctors basically, to get an effective screening device. Coming to the market size provided by in the diabetic peripheral neuropathy market, we found out that entire total available market is around 1,24,000 crores, which creates and building an addressable market. So service availability market is currently very less. I think we can see about 50,000 crores only, because it requires some kind of investment so far. And we had also some competitors like OHM series, Pseudoscan, and 3D swimming modulation, but they are doing differently. But we are planning to integrate in a system which is effective screening and prediction of the things, which is they had addressed about 90 crores in the market. But we are capturing about the market share. We had demographics in such a way that we are planning to focus only on the specified regions where we can go so far and we can enhance our product, and then we will expand. But this 3 CR market, we are planning to capture within the 3 years duration of time. So finally, I came up with our vision is to enrich foot care and prevent amputation. Our mission, building a smart devices for foot-related screening prediction to be effective, affordable, and trackable. So finally, I conclude it's just like a conclusion with Footrix, we save foot at risk. So this is a small intro of what we are doing so far. It's a very short journey, but we are giving our best and making the up to the code. Thank you.
I request the delegates, if you have any queries, to please put up the questions in the chat box. Meanwhile, I would request the chairpersons to continue the discussion on the following innovation. So you're not unmute, sir.
Yeah, good morning. Can you hear me?
Yeah.
Yeah.
Yeah. Yes, sir.
I think Vinod, you can start.
Yeah. Thank you, Mr. Yashwant, for the innovative footwear analysis which you're bringing in with the mission of enrich foot care and prevent amputation. Your team is doing a really great job, because nowadays we have seen that the rate of amputation is increasing. I hope I'm audible to everyone.
Yes, yes.
Yeah. So now we are seeing recently there are a lot of startups are coming up utilizing the government facilities to develop the equipments, and we hope that the upcoming generations also will come up with the new innovative methods to bring into the health systems, preventing a lot of life-threatening conditions like amputations, even many surgeries. I really appreciate for your whole team for bringing such a footwear system to evaluate the food risk, because nowadays we are seeing that diabetic food, even though if there is a diabetes one side is affecting, the diabetic food is other side is affecting the quality of life of many patients, and they are ending up with taking too many medications, which is resulting in a lot of side effects. And I hope your team will bring up this into the public and help them in early diagnosis and preventing the further complications and retain their quality of life. And it's a wonderful short session from your side, and really it's a great presentation. I would like to open up to the audience if they have any questions towards regarding this topic, where Mr. Ishwant has presented about the diabetic foot syndrome. Can our audience please, you can open up your questions?
Can I come in and ask a question, please? Yes, sir. Yeah. When once you've done this device, now how does it really help a diabetic patient? Does it send signals to the brain to say that what is the position in the feet and etc. What is this? Or how does it really benefit them in such a manner?
Sir, actually, I don't know the clinical terms, but I'll tell you what we had done so far. It's just like a 2 minutes walk test or 3 minutes walk test, which the patient has to wear. So we'll get a set of data where the data is sufficient enough for a clinician to get the result out of it. Like if you say the previous session about gait analysis, like how the data is there, how they are visualizing, like that also here also some parameters. In such a way, the clinicians like diabetic doctors or podiatry doctors, they can easily evaluate with that results.
So then how different is it from gait analysis? Because that's the same thing that they also do in gait analysis, right? With
Yes,
movement sensors and all that.
but as per my knowledge concern in the team, so including the gait analysis, sir, there are 4 more parameters which has to be considered, whether it is consist of EMG data like muscle activity, and if you take the temperature, there are 2 more parameters as well. So these all 5 parameters are crucial in the diabetic foot syndrome patient to evaluate the better evaluation, sir.
Okay.
Yeah.
Yeah.
Sir, your voice is breaking.
Anil sir, you're not audible.
Just adding on, do you actually perception with this? Can you be able to measure all that? And will you be able to measure the kinesthetic sense and the joint position sense, the perception, etc. with your evaluation?
Sir, if you take the gait analysis, which is done by the cameras, I think so, which has been presented in the previous session, which consumes a lot of setup, and the amount is also very high. I think nearly it's about 80 lakhs for setting the entire cameras and all the things. So we are giving the basic gait analysis lab, which is effective in this kind of setup. It's just like an sensors available in the market as well. We are giving basic analysis, sir, which is easily effective because here the affordability also matters, sir. So we are planning it is easily accessible in the open market for the doctors and for the hospitals. We are not focusing on the high-end devices because we know right now, sir, it is less awareness in the market. So we want to create with the very small kind of investment. Our device maximum price is around 1.5 lakhs, sir. Hello. So,
Yeah. Okay. I was also trying to find out, because the stuffs are already available. So you're only looking at the cost factor to say that it will be more affordable to our patients.
Yes.
Okay. Wishing you the very best. Are you planning to add on anything further into this rather than just give the basics?
So I have 2 more questions to you. Anil sir, do you have any more questions to ask?
No. Fine. I'm done with it. It's okay. Thank you. Thank you, Vinod. You can take over.
I have 2 more questions to ask you.
Yes.
The first question is, see, that your mission of enrich foot care and prevent amputation, and as we know that many times the cause for the amputation may be due to the complication of ulcers that develop secondary to the diabetic foot. But your device, does it helps in anything detecting specifically with respect to the neuropathic symptoms like changes in the sensation, temperature, cold, or anything, or anything with respect to the muscle weakness? Because these are the one of the early detection which we are supposed to be conducted in respect to the diabetic care. So any specific features in your device that you are looking in, or it's already developed?
Sir, actually, that's a very good question so far. And we are into I already told you, no, sir, we are into 5 parameters considering for making this device. One is the temperature, and one is the galvanic skin response to check the skin conductivity of the skin, and EMG for checking the muscle activity of the leg and the foot. At the same time, pressure. It's also a crucial parameter in the diabetic ulcers generation. So we are integrating this all things into a simple device where we had the data because my co-founder is a Dr. Rishikesh sir. He already done his PhD in this since 5 years, and we had a very good data. So it creates very easily to implement in our footwear. So we are just calibrating those things on to checking the efficiency so far. And we have achieved, we can say that we have started since 1 year back only. I think this month, July 20, we are completing 1 year. So among that 5 parameters, we have achieved 3 parameters accurately. So we are working currently on 2 more parameters to get the effective result. Once it is done, we are planning to launch into the market. So.
Okay, thank you. And my second question is, suppose if you found something is abnormal with respect to the foot, do you have anything protocol that established to suggest any preventive measures or treatment methods to such subjects?
Sir, usually we are not at the stage of to integrate those things, but it's up to the doctor to check the report. So,
okay.
Yeah.
So after that, it is a decision by them.
Yes.
Okay.
Right now, we are not focusing on that much because it requires some AI tools.
Now we are seeing a lot of startups coming up with new devices, right? They will even tell the results of the test as well as they will even give the recommendations of the treatment to be considered. So that's why I just asked you. And maybe in future you may also look into this.
So
Okay.
maybe in the future, but not at this stage.
Okay, fine.
Vinod, I have 2 questions. Can I come in, Vinod, if you're done with?
Yeah, please, sir, please. Mine is done.
Yeah. See, I just want to know how early were we able to identify? That means from the time of inception or from the time of diagnosis of diabetes, to what level, to how many years did these people really start? It's really started affecting the feet.
Sir, actually, according to the reports which I know so far in the research purposes, I think they have to go to the foot test at least 3 months. I mean, every 3 months. But currently, there is no awareness, right? No one is caring about the diabetic people. So my suggestion is if they take the test from our device, if it is showing any complication, depending on that, the doctor will recommend you have to take one more test.
That's the exact question. Now, how early? In the sense, the post onset, was it within 1 year or within 3 years or within 4 years?
We can predict up to 3 years, sir. 3 to 2 years. Depends on the complexity of the patient.
From the data that you?
Yeah, that we had already done in the with the existing ones in the market. Actually, we had the cutoff regions, sir, so that we can easily able to analyze. That is also published in details so far. Yeah, so that we can.
No, why I'm asking this is you can say that you can convey to the patient, you got to be careful within 1 year or 2 years or something like that. Did you get any data regarding that?
Sir, actually, we had the data for pressure mapping and so far. And if you take the temperature, it is 2 degrees with respect to the hand and with respect to the leg. So we had all the cutoffs in our hand. We just have to implement in that device. That's it, sir. With that, the doctor can easily able to analyze so that within 1 year or within 6 months or within 2 years, the patient might generate. So they have to go for one more test if required within this duration.
So what was the common age group that you found which was most commonly affected?
Sir, it's between which we had done research so far, it's between 30 to 45 in between.
Oh, you're getting so early. Okay, so that's, I mean to say that, because India has become the diabetic capital of the world, so I think we need to be careful now.
And Hyderabad, it's the most important answer currently.
No, not like that. Everywhere, even in Bangalore, many patients are there.
Probably, I think you've done your study more in Hyderabad. That's why you're getting more data is from Hyderabad.
Yes.
That is right. So we can't just queue it up and say, that it's only Hyderabad, because Hyderabad is not India.
But
Okay, anyway,
yes.
thanks for providing us with the insight. Wishing you the very best, so you develop into a good product.
Yes. Thank you.
Okay.
Yeah.
Thank you. Nothing
Thank
more
you.
from my side. Yeah.
Thank you, Mr. Ishwan. All the best and very good luck for your whole team to come with many more developments. All the best for your entire team.
Thank you, sir.
Organizers, can you take a?
Thank you so much. Thank you, Dr. Reshwar. Thank you so much for taking time and explaining about your innovative smart footwear, which can screen early diagnosis for diabetic foot. And I would also like to thank the chairperson, Dr. Anil and John and Dr. Vinod Babu for lovely discussion. And I would also request all the delegates to please put up questions in the chat box. I request delegates, if you have any questions, you can please put up in the chat box. Thank you, Dr. Reshwar. So now moving on towards the next innovative talk, we have Dr. Nandini from Amity Institute of Physiotherapy, Amity University, Rajasthan. Ma'am will be taking her topic on Foot Revive Integrative Platform, Plantar Fasciitis Bone. Ma'am is presently working as assistant professor at Amity University, Jaipur. Ma'am has various national and international publications, and her contribution continues to inspire and push the boundaries for her knowledge and practice. I would also like to welcome the chairperson for the session, Dr. Vinod Babu, Principal and Professor, Gotham College of Physiotherapy, and Dr. Anil T, Principal and Professor, Pest College of Physiotherapy, University.
Taking over. A very good morning to everyone once again. I want to first of all congratulate the entire team of DSU National Symposium for organizing such a informative symposium where all the expertise at a one platform, and particularly the theme that is soul to soul, that is what goes very much in along with the very small innovation that I am going to discuss about. So before I move forward, I want to significantly thanks Dr. Satya and Dr. Kanchan Shah and the entire team for giving me the role of chairperson and giving me a slot to talk about my little innovation and discuss it on this platform. And so far the symposium is really good. I have gained a lot of knowledge about a lot of things, and I'm very sure that it is going to be very successful. Best wishes to the entire team. Now moving forward, before I move forward, let me share the screen. All right. So before starting with to talk about the plantar fasciitis board, so the main theme of the National Symposium by DSU is soul to soul, and it very much aligns with the innovation that I'm going to talk about, that is Foot Revive Integrative Platform, and it is a plantar
అదే
fasciitis board.
మీకు అడిగాను కదా ఆ రోజు ఇది రెగ్యులర్ మనము
So it is a comprehensive approach for heel pain relief. So giving a small introduction, I'm Dr. Nandini Kushwaha. I'm the course coordinator and assistant professor working at Amity Institute of Physiotherapy in Amity University, Rajasthan. So before going towards the innovation, I would like to introduce about the plantar fasciitis a bit. So plantar fasciitis is a very common orthopedic condition which is characterized by inflammation of the plantar fascia. And now plantar fascia is what it is, a thick band of tissue that runs across the bottom of the foot till the metatarsals. So it starts with a thin, what should I say, a thin filament which goes and gets broad in the center, and again it gets split into the 5 bands which get inserted into 5 metatarsal, and it actually gets very much aligned with the fascia structure, with the tendoachilles and the subcutaneous tissues of the sole. Now, moving forward, the main prevalence I am unable to move the slide. Yes. So main prevalence of the plantar fasciitis is it affects merely 28% of the people at some point of their lives. So this is the research statistic that 28% of the people at some point of their lives are being affected by plantar fasciitis. So what it does it tell you that while the patient is walking at that point of time, just in a normal gait, in a normal walk, 110% of the body weight or the shock is absorbed by the plantar fascia. And when the patient is actually jumping or doing any kind of high impact activities, at that first time, 250% is being, it is being absorbed by the plantar fascia. So it is a very, very important anatomical structure where the inflammation occurs, and there are there is a defect at the micro level, and that is why it leads to fasciitis. Now, where the prevalence is, it is mainly prevalent in athletes and active individuals. In the occupational groups where the standing and the walking are for prolonged hours, and for the other risk factors are the patient who are overweight, obesity, and the one who are prone to pathological foot mechanics such as flat feet or high arches, and even wrong footwear, which is one of the most common reason of plantar fasciitis. These are all the prevalence and the risk factors of plantar fasciitis. Now, what exactly plantar fasciitis leads to? Now, plantar fasciitis leads to pain and discomfort. Usually the patient reports that there is very stabbing, dull, aching kind of pain when they actually get up and take the initial steps to start their day. And eventually, the second complaint is that with the continuity of the activity, the pain is there. There is limited mobility, the range of motion gets affected. There is an altered gait pattern, and the gait pattern, when the gait pattern is altered at the ankle, so it leads to secondary complication, that is the alteration at the knee joint, at the hip joint, and the pelvis. So it further leads to secondary complication. It affects the quality of life, and of course it affects the economic impact. The economic impact is that it leads to medical expenses, it leads to surgical expenses at times. There are times patient has to miss their working days, and there is definitely decrease in the productivity. So what is the common treatment that is significantly given by the physiotherapist and this day that we have been seeing is there is stretching, strengthening. The physiotherapist recommends is a proper footwear where there is a good arch and support, and maximum they go for is the orthotic devices. Now the thing is that these are the conventional physiotherapy techniques that has been used, and the method to do these things, stretching exercises, strengthening exercises, the footwear modification or the orthotic devices, they use very different what should I say, the equipments or the things to prescribe exercises. Just as if I discussed with you, so at times they tell to do the toe curls. Either they ask the object like sharpener or the eraser to pick it up and drop it at the another block. Either they say that they can use TheraBand or the towels in where the patient has been asked to curl the toes and to make it in a form that the wrinkles occur. At times they are advised to take the arches. So the companies like Credo and all, they are giving the arches or the gel foot gaskets to place it in the what should I say, the shoes, and the ergonomic or the angle gets better. So these are the aspects which are different things that are being incorporated for the common treatment that has been followed out for the case of plantar fasciitis. Now, the thing is, what could be that one solution for all the problems? So while we were working in the OPD here in Amity University, so the main target patients that we received was the professors. Being an academician, they have to be on toes, and the minimum working hours that is given by the UGC is 18 to 22 hours per week for a assistant professor. So that combines roughly to 3 to 4 classes in a day. And if it is 3 to 4 classes in a day, so it is 3 to 4 hours of what should I say, standing. And also, as we all know that the universities are pretty big, and I have seen the pictures of DSU. I'm very impressed. It's a very beautiful campus. So definitely there is a lot of walking. And if the footwear is not fine and there are other risk factors associated, so the patients or the professors getting prone to the plantar fasciitis is very common. So that is where this came into the picture, that what can be the one solution, and we came up with Foot Revive integrative platform. So let me show and discuss that in detail. So before going that, what was the need of this invention? The need for this invention was that this is one platform that gives you a comprehensive treatment. So all you have to do, it is roughly a wooden board of 1 to 1.5 meter, which would include everything. It has 5 key features, which I will be discussing. And the patient, even after taking a guided physiotherapy session, can do a lot of treatment and exercises on his own. So it's a very good, what should I say, a platform that we have actually came up with, and we have taken a design, we have been granted a design patent on it. So this invention comprises of a plantar fasciitis wooden board. And this is the picture that you can see on the right side. It has multiple therapeutic elements and it is combined in one board. So it provides you stretching, strengthening, massage, and support functionalities. Moving forward, if you see, so here the main aim is to reduce the symptoms and increase the user experience, so that the means what you said, the regularness, the regularity of a patient for the treatment gets better, the program adherence gets better. So that is one of the reason that this board is what that we designed, and the idea came into it. It has a approach that would not only decrease the symptom of plantar fasciitis, but it also can at one point of time stop the symptoms to get more aggravated. So the key features that includes is, the first one that you can see is calf flex board. Second one is arc flex pro. Third is spherical therapy hub. Fourth is sure grip fascia is, and fifth is arch insole craft. So it is a comprehensive approach. How it is a comprehensive approach, I'll discuss in detail. So as you see, this is a calf flex board. So here the wooden slant board is adjustable. So this will, according to the patient's tightness level, the physiotherapist can customize the degree through the screws, and there it enables the stretching of the calf muscle. So the stretching of calf muscle indirectly reduces the tension of the plantar fascia, and it relieves the pain and discomfort. So at the end of the day, what it would do is it will provide the stretching and it would improve the mobility of the patient. The next is Arch Flex Pro. It is significantly important for promoting the flexibility and reducing the pain. So here what the patient has to do, it is like a 3D structure. This is like a wooden plank. A patient has to put the foot above it, and then there is a lever kind of structure that is T in shape. So here the patient has to grab it with the great toe and the finger, and then they have to do it like this. They have to curl up. And here in the beneath, the string has been attached to provide the resistance. So what the patient can do is, when they are at the time of the exercise, they are trying to curl their foot. So they have to do it against the resistance. So which would lead to the strengthening of the fascia, and it would obviously decrease the pain, and it is significantly responsible to improve the support of the arch and to make the foot mechanics more better. The next is the spherical hub. Now, spherical therapy hub is something that is embedded. So it is a ball, it is a sphere like of structure that is going to be half partially embedded inside the board and half it is going to be like this semicircle above the board. Now it is significantly for the targeted foot massage. Now foot is not a plain structure. So it has some kind of arch. So at times the patient, they complain of the pain at separate regions of the sole. So this spherical hub is the one where it is going to provide the relief where it is needed the most. So patient can place the foot and it can rotate the foot according to the part where it is most affected. So this spherical hub, it allows the dynamic stretching. And by providing the dynamic stretching, it enhances the flexibility in the foot muscles and tendons. And also it releases, it provides a soothing effect. So it releases the tension in the foot. So this is spherical therapy hub. The next key feature is the sure grip fascia ease. Now, sure grip fascia ease is actually in a way that it is a little slant. It is a little inclination that we have given. So every time, so one of the treatments for plantar fascia is the stretching of plantar fascia itself. Now, because the foot is something that is smaller in size and have a different contour, so there is always the physiotherapists face a problem in holding it and giving a proper stretch. So the one where we face a little limitation, so we have designed the sure grip fascia ease, where the patient has to actually place their foot and they have to do is what? Go in the downward direction, put the body force in the downward direction, and it has a non-skid surface. So the boundaries have a little edge which would keep the foot supported. And once they go towards the downward side, the inclination would lead to the stretch of plantar fascia alone. So it ensures the safety and stability during the stretching exercises. It reduces the discomfort and it helps in regaining mobility and provides comfort in the daily activities. Moving to the last key feature, that is arch insole. So this is a insole that is being, as I said, that the various companies and various startups provided to fit it inside the shoes. We have placed it on our plantar fasciitis board. So where it gives a continuous arch support. Well, it actually promotes the proper foot alignment and reduces the strain on the plantar fascia. So here we want our patients to understand that what is actually the foot's natural alignment during the daily activities. So because as we know that there are multiple kind of footwear that a patient prefers, and for the multiple examples, for work there must be different, for the functions there must be different, for jogging there must be different. So this plantar insole, it will give a biofeedback, or it would register in the mind of the patient that how the actually normal foot alignment should be. So it is tailored to the contour of the foot, and it actually promotes the proper biomechanics of the foot. So this was the 5 key features of the plantar fasciitis board. So, and this is the different view that all the delegates can see, that it is one is side view, one is front view, one is the view from the topmost. So we have taken a design patent on it, and right now we are working to formulate it in the real life. We are designing it there. We do have some kind of what should we say challenges to provide the best the best quality of material in this, but for the cheaper rate. So we have been trying to bring this into the real, to make this into the actual form. The benefits of this plantar fasciitis board is it is a comprehensive treatment. So this board, the person has to just keep it under the desk and they can do all the exercises. So it is a comprehensive treatment which provides you massage, which provides you stretching, which provides you strengthening, which also corrects your foot biomechanics. It is convenient, it is cost effective, it is user friendly, it enhances the compliance, and it is versatile as well. So moving forward, these are the benefits, and what are the future work that can be done on this is research and development. This more better advanced materials and smart technology that could be actually brought into the picture for the personalized treatment, and it can be made more better, as it is a plantar fasciitis. It is designed very user friendly, so it would definitely attract a wide range of customers, from athletic to the individual, for all the age groups, to make their plantar fascia recover as soon as possible. And the expansion can be just like we have targeted the significant pathology, that is plantar fascia, which is more than a pathology. It is a degenerative kind of condition. So the same thing in a board can be designed for other foot conditions, and it would be definitely important for it would be definitely important and helpful for the broader audience with wide range of foot health issues. So here I would like to conclude my this innovative talk by the thing: a well-nurtured idea can bring immense relief and serve many. So once again, thank you so much to the entire team, Dr. Satya and Dr. Kanchan, for giving me an opportunity. Here I would conclude my talk.
Thank you, Dr. Nandini. It's a wonderful, innovative idea you brought in, and it's something which is totally a new, innovative idea you all brought in the method of treatment for plantar fasciitis, and it's a knowledgeable session. I first open up any questions to audience or delegates. Delegates, do you have any questions to Dr. Nandini with respect to this topic? I hope no delegate is responding. As there is one question in Q&A section, they're asking that Mr. Suraksha. The question is, may I know of any art support you would recommend? Dr. Nandini, I would like to share this question to you.
Actually, art support that I would recommend is means I would not ever recommend any kind of company or someone, because I have not, until I have personally used it. And according to everyone's foot, the anatomical arch, the degree of arch is different for everyone. So it should be ideally customized, made.
Any other delegates? Do you have any questions to Dr. Nandini? Okay, Dr. Anil, sir. Dr. Anil?
Thank you, Dr. Nandini. I mean, it was really a good talk. I just want to know that, if you could integrate your analysis also, you could probably get an analysis of the foot and then integrate this and custom make it. I think it would be make it even more meaningful and even more. I think you would get better results also, including the art, the size of the foot, and all that. That is what I feel.
Sure, sir.
Okay. And how many patients have you treated so far on this?
Sir, actually, we are still in the process. We have been just granted patent few days back. And now we are now in the process of making it. So we have been talking to the carpenter and a lot of people associated with it and the engineering department, that what kind of things that we can use, what would be the spring, what would be the diameter of the spring, what kind of locks that we could use, so that it does not get very heavy also, and it is actually at least accommodated to the normal size of the foot.
Okay, so I mean, I was just so you're still in the design stage, it's still not implemented, right?
Yes, sir.
Okay. Wishing you the very best. Hope it becomes as a good tool where people can use it. And I think you should also look into the mechanics, not only
the foot as such. I think the whole mechanics of the feet. Plus, also, I think you all need to look into medications, which is causing a massive amount of plantar fasciitis right now. So there's a lot of role that medications has, and a lot of side effects that is there.
Sure, sir. We will definitely take up your
Yeah.
recommendation.
Okay.
Thank you so
Yeah.
much, Dr. Anil.
Yeah. Thank you.
Dr.
Thank you.
Thank you, Dr. Anil. Dr.
Thank you.
Anil, I have two questions to you.
Yes, sir.
One is in this food revive, what you developed on plantar fasciitis board, are you planning to implement conventional method of treatment along with this, or just it's an isolated method of usage you are planning?
Sir, at this point of time, as I initially discussed about that, what is the conventional physiotherapy treatment? But then I also discussed about the future direction. So I'll just give you one basic example is that later on, we just got into the idea that if something, the spherical hub that I talked about, that was the third key feature of the board, if something that could be incorporated, which can actually, what should I say, regulate the temperature of the ball. So if we want to get it towards the heater side, then we can use that as well. And if we want to get towards the colder side, then it would be a plus of massage plus a cryotherapy.
Okay.
So it is something that we want our patient to be more compliant. And at times, what we have faced is that they come to us, they feel the difference, and then they go back to their own lifestyle. So there at times there is work life balance that is getting altered. That is what is stopping them. Second, and other times it is sometimes the economic part. So at least this plantar fasciitis board, which I feel once we take it into the actual form and we would know the basic price of it, it should not be that much expensive for a minimum, at least middle class population. So they can actually bring it, keep it under their desk and keep doing it, which would improve their overall foot biomechanics.
Okay. And also, as we know that this plantar fasciitis ends up with different presentation depending on the stage of healing. I mean, maybe acute, subacute, chronic, or maybe sometimes there may be injury of plantar fascia itself with the tear or maybe adhesions formation. So, in that case, like, how you is that anything any specific stage does it helps and does not it helps in specific stage? And as I told you, like our routine, there's a lot of protocols, programs has been developed. So, in association with that method of treatments, this board can be utilized, or you're looking isolatedly use this board for specific to the stage.
Sir, now being a physiotherapist, I would never rely on a board isolatedly.
Okay.
So I'll never cut our bread and butter. So it would always be something that is obviously a added thing to our advantage.
Okay.
And secondary, as I mentioned, that we are on a designing state because we just got the patent and we're still designing. After that, we have planned off a pilot study, sir. And according to that, we will do 2-3 pilot studies, and then we will see that what is the actual effect and where are we actually helpful in acute or subacute stage. And that is where we will be able to actually give that till what age, till what extent is this helpful. But that is for sure that it is never exceeding physiotherapist. The personal touch is always priority.
Okay. Really, I wish all the best for this development of this method, because we see that when we suggest some home exercise program, really they may not adherent to that. Maybe they may be doing very wrong methods or some other reasons they keep explaining. But this board really in future, it really helps with many patients. I hope very soon if you bring it to the utilization of all the physiotherapists, it will be really helpful to treat the patients. Okay.
Sure.
Dr.
Thank
Vinod,
you
can
Thank
I
for
you
your
so
come in
much,
for
Dr.
one
wonderful.
question?
Vinod.
Vinod, can I
Yeah,
come in for
somebody.
one?
And
Yeah.
yeah,
No, yeah, I think you can just go in for innovation of putting some sensors into it, so it gives you more data rather than just placing your feet out over there. And when the patient does it probably, you can capture even more data as the amount of force, what's happening, where is your pressure points. I think that could help you with that, something like that.
Sure, sir, we can actually do the same, but I really don't mind, or my team would really not mind bringing it making it more top-notch level, but then what is going to be the difference between the IITians and us? So what we want it is to be a user-friendly product and which is actually pocket-friendly. So as soon as we place the sensors, it would increase the rate and it would lead to less compliance and less usability of the product. So whatever
I'm thinking in the long run, when you think in the long run, you
no,
sell this
sure, sir,
product
sure.
somewhere.
We can
You
actually
sell this
develop
product
it.
somewhere, going by IoT, you sell this product somewhere at home, wherever your office, you get the data.
So
Sure,
you
sir.
You don't
can,
have to rely. You don't have to rely on IIT.
so maybe one method of instruments without sensitives for that can be used for patient. Another one which
Correct.
can be with the sensors that can be used for
Correct.
physiotherapist. So
Yeah,
two groups of
that's right.
instruments can be made.
Yeah. I mean, you got to think ahead. We just can't think of only today. You got to think about tomorrow. Today is over.
Sure, sir. We will definitely work it up.
Yeah.
Sure,
Yeah.
sir.
Yeah.
No, really,
Thank you.
something new you brought now, so we are very happy for that. That's why.
Yeah.
I hope that
Oh.
so if we have the right blessings and I'm very sure that this actually can be useful, sir.
Yeah.
Yeah.
Okay. Thank you. Thank you so much.
Thank you.
Thank you,
Thank you.
Dr. Anil. Thank you, Dr. Vinod.
Thank you, ma'am. Thank you, sir. Ma'am, we have two more questions in the chat
Yeah.
box. The
Yes.
first question is, would every board be customized for the patient as degree of arch is different for each patient?
As I initially mentioned, Chandini, that every board, so we are working on the two designs. One is if we can actually have something that could be a little common for the foot size for all the Indian population, and another one would be customizable. So it is going to be both the ways. And once our design actually becomes a product, and then we are going to do pilot study on it, as Dr. Vinod mentioned, that if we have actually fixed upon that what kind of severity it can treat. So it is going to be a two-way thing. And as it is, we are working for an Indian population. So for average size of foot, that is altogether a very different thing that we have to actually look into the picture. So we are going to work both the ways and see that what is going to be the effect for it.
Question by Suraksha. What are the associated common problems in proximal chain in knee and pelvis?
All right. So this goes towards the biomechanics. So as we say that when the biomechanics of the foot get altered, so there is always a compensatory changes at the level of knee and at a level of hip. So if we go back towards our Cynthia Norkins and we talk about it at that point, then pes cavus and pes planus, these are the two things which leads to alteration. So whatever there is, I'll just give you one drop hint is whatever is there at the ankle will happen at the hip, and it would go an opposite direction for the knee. So all these three things will come into the picture and it would definitely lead to gait abnormalities.
Okay,
Can I
ma'am.
add on to this? Can I add on to this?
Yes, sir. Yes.
Yeah, that Suraksha question, what she asks is, see, the chain not only ends at knee or pelvis, it even up to goes to the scalp, because the posterior superficial long chain, which is related to the plantar fascia, starts from the toes and it ends at the scalp. So we may not, when the person who is having plantar fascia facilities may not be seen only problem in the knee, hip and knee or pelvis. Even they may have back, neck, also to the headache level. So again a separate subject and separate concepts that. So we may not end up only seeing the problems only at these three levels. I'm saying that you may have problems seeing even at the spinal, even at the up to the head level, whoever the patients coming with plantar fasciitis.
So like if Suraksha wants something that is like very much common, if she's looking for the condition, then there's no specific answer to it. But still, if I can just tell you that pelvis and hip will have, it can have anything, hip flexor strain, it can have piriformis syndrome, it can have SI joint dysfunction,
Right.
as Dr. Vinod mentioned. Over the knee, patient can develop knee osteoarthritis. There could be a compression at the medial side of the knee joint even more. It can go in genu valgum or geru varum. then it could go for patella tendinitis, it could go for IT band contract tightness, and which could lead to contracture. So there are a lot of problems which could actually happen because of the excessive pronation of the supination of the foot.
Good.
So, but these are the secondary complications. So for as we have attended one of the plenary session about the 3D gait analysis. So that actually said that for gait, we need to take every joint into the accordance. And what my innovation is going to speak about is just for the foot. But then at the end of the day, we are trying to improve the biomechanics of the entire gait and the entire body. So that is what actually stands in alignment of this conference's, what should I say, theme, that is soul to soul, moving towards a better health. I hope that the doubts are resolved.
Yeah.
Thank you, Dr. Nandini. I want to extend my gratitude for taking your time to explain your innovative plantar fasciitis board, which is user-friendly, cost-effective, and would help the patient suffering from plantar fasciitis. I would also like to thank the chairperson, Dr. Vinod and Dr. Anil, for giving us an insightful discussion on the following topic. Thank you, sir. Thank you, ma'am. Now, moving on towards our third innovative talk by Dr. Amit Burande on the topic cost-effective method for charcot foot reconstruction. Sir is Director and Chief at Orthopedic and Surgical Services, Surya Hospital, Kolhapur. With extensive teaching and clinical experience, Dr. Burande has been invited to numerous talks and public awareness programs after completing his basic training in diabetic foot care at South Arizona Limb Salvage Alliance. Under the esteemed guidance of Dr. David Armstrong and Dr. Joseph, Dr. Burande has established his own first diabetic foot clinic in his region in 2010, which was flourished into 60-bed hospitals offering comprehensive services in diabetic foot management. Now, I would also like to welcome the chairperson for the session, Dr. Girish, HOD, Department of Physiotherapy, Sagar Hospital, Bangalore, and Dr. Sai Mahendra, General Secretary, Karnataka State Physiotherapy Federation, Director and Business Head, Nova Health Private.
Dr. Jimshed is the Chief Physio at Canada Medical College. So they want to guide you through what things are. So I actually thank the principal for giving us an opportunity to tell you all about what is there after your thing. Yeah.
Hello, am I audible? Hello. Hello.
Yes, Dr. Amit, you can go on.
Can I start, sir?
I hope so, Dr. Girish. I mean, he is ready.
Is my screen seen?
Yes, Dr. Amit.
Yeah, please, go ahead.
Yes. So what's a Charcot foot? It's named after a French neurologist, Jean-Martin Charcot, who was a neurologist. It's a progressive denervation-induced destruction of the foot and ankle joints, and rarely knees and the hands also might be involved. It's a end-stage clinical manifestation of the neuropathic foot, and it passes through the various stages of inflammation, hyperdynamic circulation, fragmentation of the bones, and coalescence and remodeling and the formation. It depends on what stage we are looking at the Charcot, and we may appreciate it as a part of the solute problem. So the causes which may lead to the Charcot neuropathy are multiple. In early days, the infective, that is the leprosy, was the commonest cause, and nowadays there is a metabolic and hormonal, that is the diabetes-induced neuropathies are very common. Very rarely we can see the drug-induced and the hereditary and compressive neuropathies as well. The basic neuropathy, superadded trivial trauma, that may be a repetitive microtrauma which usually happens in the midfoot, or there can be a gross trauma which happens at the ankle. It will lead to the inflammatory cascade. Autonomic dysfunction leads to hypervascularity and AV malformation and the shunts. And there is a bone demineralization, soft tissue weakening, and ultimately resulting into the bone fractures and subluxations and dislocations. In a recent study in the Amrita Institute, they are working focused role of different inflammatory markers, and interleukin-6 has supposed to have some early role in the pathophysiology of this disease. If we see on the left, this is a synovial tissue or the soft tissue surrounding the joint of the Charcot, which is grossly the lymphocytic infiltration you can appreciate. And on the right side, you can see the bone which I have taken from my own Charcot case. And the histology is suggestive of it is more looking like a cartilage. So it's a de-differentiation or organized tissue is going towards the bone. Hello?
Hello.
Hello. Am I audible?
Please go ahead.
Yeah. The classifications are depending on the stage of the disease. That is the Shibatas and Eisenholz.
Salary bones ಆಗಿಲ್ಲ ಇನ್ನೊಂದು 35000 ಚೆಕ್ ಕೊಟ್ಟಿದ್ರಲ್ಲ ಅದು bones ಆಗಿದೆ.
There is some disturbance depending upon the site in the foot and ankle. That can be a Brodsky or Sanders-Pisberg classification. And depending upon the stability
and present ಮಾಡಿದೆ ಯಾವ ಬ್ಯಾಂಕ್ ಅಂತ ನೋಡಿಲ್ಲ ಬಟ್ ಬೌನ್ಸ್ ಆಗಿದೆ ಬ್ಯಾಂಕ್ ಇಂದ ಇನ್ಸಫಿಷಿಯಂಟ್ ಫಂಡ್ಸ್ ಅಂತ ಬಂದಿದೆ ಅಂತ.
Hello, Dr. Girish, there is some gross disturbance. Somebody is talking, some personal issues going on.
Hello.
Okay. So depending on
ಮಾಡ್ಬಿಟ್ನಲ್ಲ ನಾನು ಸಾಮಾನ್ಯವಾಗಿ ಕೊಡೋದು ಯಾವ್ದು ಬೌನ್ಸ್ ಆಗಿಲ್ಲ ಇಷ್ಟು ವರ್ಷಗಳಲ್ಲಿ. ನಾನು ಅದನ್ನ
depending on the site in the foot and ankle, there can be a Brodsky and Sanders-Pisberg. Depending upon the stability and complications, there's a Monsura classification. So you can see in Shibata
I think somebody can mute the doctor who's speaking.
Deformity. In stage 1, there's a destruction. When the foot starts falling the fractures. In the stage 2, the bone started sclerosis and they get adjusted in the abnormal positions. And in the stage 3, there is the complete sclerosis and the deformed foot is in front of us. Brodsky classification is depending on the location. Type 1 is the midfoot. Type 2 is in the talar joints and the subtalar joints. Type 3 is talus and ankle, and type 3B is at the calcaneum. Any combination is taken as a type 4, and in the forefoot there is a type 5. A similar type of classification is supposed by the Sanders and Friedberg classification, where the stage 1 is 1, then 2 is the midfoot, 3 is beginning of the hindfoot, 4 is the ankle, and 5th is the calcaneum. That's 2, 3, and combination of the 2, 3 are the most common deformities what we see in case of the Charcot foot. There is one more classification, which is the University of Monsura classification, and it depends on how many regions are involved and whether there is a presence of the stabilities, deformities, and mechanical ulcers. The more you go towards the more instability, more regions the foot is at the risk. Diagnosis of Charcot foot is more or less clinical. It's a hot swollen foot. local temperature more than 2 degrees Celsius than the other parts of the body. Infection markers like CRP and leukocytes may be normal. No systemic manifestations of the infection, like there may not be involvement of the liver or kidney or the lungs. And usually no visible wounds or ulcers of the skin are seen when it's the early stage of the disease. MRI, bone scan, and the weight-bearing X-rays are the diagnostic. So these 6 views of the X-rays, where the AP standing, internal rotation and external rotation views, and ankle AP, ankle lateral, and the calcaneal axial, these are the views which we need in the X-rays. In the MRI, you can appreciate in the acute stages that these changes in the T1 signals, which are suggestive of alteration of the bone density. And there are certain guidelines and discussions which are going on worldwide, because this is one of the disease which is very amenable to the treatment and very difficult to give the results. And Indian team, Dr. Arun Bal, who was the part of the international working group of the diabetic complications, they have suggested some guidelines. From these guidelines, what we have learned so far from the review of literature and IWGDF guidelines, in the acute Charcot management, that is the Shibata stage 0 and Shibata-Eisenholt stage 1, the treatment remains is the total contact cast. So total contact cast, TCC and TCC, that's the only solution in the early stages, because 90 to 95% of the patients who are picked up early and treated with the total contact cast and followed by the air walker or the crow walkers, they are likely to have good results. But unfortunately, there is a saying that if you have not seen a Charcot in your foot, probably Charcot has seen you. It means unnoticeably you have missed the Charcot diagnosis. And nowadays, number of Charcot patients are increasing significantly, and complications and the deformed foots are coming more and more. And there are significant gray areas, ambiguity, confusion in the guidelines, and understanding of the failed conservatively treated Charcots and role of surgery. So we'll try to understand some principles and philosophies, whether we can reconstruct the Charcot and we can save the foot. So we'll go case-wise discussion. A 47-year-old man, type 2 diabetes since 8 years, neuropathic symptoms since 2 years, deformity in the both feet since 1 year, no history of rememberable gross trauma or acute swollen hot limb in the last 1 year. He developed wound on the medial side of the right and intermittent serosanguinous discharge as well. So this is the clinical scenario. You can easily appreciate the deformed foot and the wound. X-rays are showing the midfoot destruction and the navicular medial cuneiform, the middle cuneiforms, they all have been displaced and the forefoot has gone in abduction. In the lateral view, we can appreciate the foot has started sinking down. And what is the treatment target in this patient? So understanding the treatment target is very important. So I have taken one random X-ray of a normal person and did the templating. So in the template, what I have found is the axis of the talus and the axis of the first ray is 12-degree varus. So in my patient, there was a 20-degree valgus. So plan is to design the osteotomy for 32-degree of varus. So this crossing of the joint was at 3 centimeter distal to the apex of deformity and the translation as well. So plan was to cut 3 centimeter proximal to the apex of deformity, which I planned on the paper, executed on the paper, and after executing, this is what I resulted in the paper. And only Ramin job is to execute on the operation theater. So we started with the medial approach. The bumpectomy was done. Tendo achilis was lengthened because tendo achilis shortening is the key in or the main basic problem in most of the Charcots. These are the osteotomy markings in the primary, I would say, the OT table. And at the end, so what all we have did is we corrected the deformity, fix it with the beam wire, then put some bone grafts, also put the antibiotic coated cement here on the medial side. On the lateral side, I opened up and put the bone grafts and put the external fixator for additional support and stimulant on either side with the vancogenta for the local antibiotic bugs. The implant cost is hardly 2,500 rupees in these patients, and stimulant was a little costly, but as compared to the Western counterparts like the UK and Europe, what they are using, that goes in the thousands of euros.
So as compared, this is also a reasonably cheap option in infected Charcos. We don't need it in the non-infected Charcos. So the follow-up going on, post-operative plan strictly not very varying for 5 to 6 months. That is the key of success of most of the patients where I operated. Early weight bearing is very detrimental and it can result into the fibrous union or collapse of the bones. This was the fusion which was achieved. Deformity is completely corrected. And at this stage, you can see the 19 weeks follow-up. And this was the clinical scenario. Wound is completely healed. There was a small wound on the great toe, but that also eventually healed. That was because of the wires. And then we cannot leave these patients like this. We have to do a definitive fixation. And most important principle in fixation of Charcot is talus has to be fixed with the forefoot. Forefoot has to be fixed with the calcaneum, and calcaneus has to. So this triangle formation is very important, and this all joints has to work as a single joint. And the ankle only, there will be the movement in the ankle, and all subtalar movement you have to abolish. This time implant cost is hardly 800 rupees, but still there was some deformity, so I corrected it with the help of the peroneus brevis shortening. So no stone was kept unturned in this patient. These are the serial follow-ups. This is the same patient with the opposite limb is also showing the problems. And in the same time frame, he has developed he had the development of the deformity on the opposite side also. But as the deformity was stable and there was no gross subluxation or arch collapse, I decided to conserve, and still the patient is on the conservative mode on the opposite side. And again, at the end of a couple of months, 9 months, we can see that some midfoot bones have secondarily collapsed. These things do happen in the Charcot. And you can appreciate this bump of the bone which was on the plantar side. If I would have kept it as it is, it would have again caused the plantar ulcers. The medial ulcer would have shifted on the medial plantar side. So I went ahead, did the bumpectomy, and this is the final picture. And you can see patient is walking. You can appreciate his right leg is absolutely straight foot and left side is a little deformed, but as it is a stable, we are not operating it on right now. And in the shoes also, you can appreciate they are just the simple shoes and not the crow or the rocker bottom or any fancy shoe is needed for this patient. If you fix them stably in normal anatomical position and give a plantigrade foot, we may be able to go with the normal shoes. Case 2, patient is having the non-healing wound on the right foot almost for 18 months, grossly deformed foot. X-ray is showing the midfoot abduction and arch of the collapse, the collapse of the arch. This is for a comparison of a normal arch, and you can see it how the arch is collapsed here. So we went ahead with a very minimum cost of implants and did the abduction correction. At the same time, you can very well appreciate that all deformity is correct. Arch is almost restored. Wound has started healing in just 35 days, 18 months non-healing wound. But at the 48 days, the thing has happened is the calcaneal screws gave away and there was an infection, which we tackled with the implant removal and local debridement. By the time that wound settled, the lateral side of the foot started breaking and the screw started coming out. We removed that plate and the screw also. So at the end of around 150 days, this is the clinical picture. So is it time to celebrate our success? Because wounds have healed, foot is stable, arches, though not completely restoration of the arch, little bit loss of arch, but still it is not a rocker bottom foot. But there is something now I noticed here. Please focus on the medial side of the medial malleolus, and you can appreciate there is a fresh fracture. So in a case of a Charcot, patient is immobilized, there are adequate implants, there is adequate plaster, still there is a fracture. It means the Charcot process has been reactivated, it has shifted proximal. So this is the most important thing a Charcot surgeon or a diabetic foot surgeon has to remember, that there is a possibility of proximal or distal migration or change of zone of the Charcot, and you have to be very vigilant in this patient. So what is to be done? When Charcot has become aggressive, we should not become aggressive. When there is a new fracture, it has gone to Eisenholt stage 1, and the principle states that at the Eisenholt stage 1, go back to the TCC. So I just applied the TCC. TCC continued. Looks like medial malleus is little deformed. This reduction will not be accepted in an ankle fresh trauma patient. This patient will be operated, but in Charcot, things are not like that. If you try to put screws or wires in this situation, it's like a molten or very soft pultaceous tissue. nothing will hold, everything will come out with the additional infection in that. So we kept the patients and everything has united and patient has resolved them. So see 225 days, we give a best fight. And after that, this is the follow-up in the May and patient is doing well, walking on the both the feet. Case 3, patient is a lady with 15-16 months non-healing wound on the calcaneum. You can appreciate the ulcer. You can appreciate the rocker bottoming has happened. And here, as the infection was deep, we approached with a different approach. We did the debridement from the plantar side, minimal internal fixation as there was active and gross infection, and put the ring fixator. Ring fixator is a very salvage situation for an orthopedic surgeon when you are suspecting infection anywhere. And eventually we removed the fixator, put her in the slabs and the cast, and just implant cost of 1600 rupees, we could reconstruct this foot. Just remember that a Charcot reconstruction will never look like as absolutely a normal foot, because most of the bones have reabsorbed or they have become small or the foot have become small. And sometimes we have to use the bone grafts. So please don't compare a reconstructed Charcot foot with a normal X-ray. Our aim is that it should be a plantigrade foot and pressure bearing area should be only on the calcaneum and the metatarsal heads. And especially midfoot should not come to the ground. That is our primary target, and midfoot and hindfoot talus should not come to the ground. In the same time frame, patient on the opposite side had the wound on the ankle, and his X-ray is showing fragmentation of calcaneum, complete fragmentation, and as well as the talus. So it is a type 3B Brodsky classification, we can say, very rare presentation. But I was fortunate enough, and patient was unfortunate, but we dealt it very well, that all types of Charcot we have seen and operated. But we didn't go for anything fancy here, just debridement. There was an aggressive infection. And whatever the bony stumps were there, we fixed into the tibia and we try to retain this posterior soft tissue. This soft tissue itself can act as a fulcrum. What function calcaneum is going to do, that is being done by this soft tissue. The wound started healing gradually. Implant cost is 100 rupees. And over 7-8 months, both the feet have healed simultaneously, and lady is very happy using a simple pink shoes, what a lady deserves, and enjoying her granddaughter's marriage. After this marriage, in 9 months, the lady died with the sudden cardiac death. Remember that Charcot is an autonomic dysfunction neuropathy, and autonomic dysfunction affects the peripheral nerves as well as it affects the heart. So there is something called as sudden cardiac death. Patient found dead in the bed is the dictum in this kind of patients, and this patient was not exception for that. One more patient, my first patient of Charcot, which I operated 8 years back, 10 years back maybe. And you can appreciate non-healing wound, 15 to 18 months old. Calcaneum, the talus, calcaneum is broken, talus has touching the ground. We just went ahead with the talectomy, calcaneotibial fusion. This is the 8 years follow-up. Patient is very happy. Little bit of break in the midfoot, but that is helping him for the resilient function of the foot, because otherwise everything would have become a solid rod. And patient is walking on the same side. 8 years after the same patient, by the time he has developed chronic kidney disease, he was on the dialysis. He came with this non-healing wound on the foot. You can appreciate the midfoot is broken and the talus is coming down and there is the plantar bump. But this time, within 8 years, I also have learned very many new techniques in reconstruction of the Charcot on my own. And we went ahead with this is a complete reconstruction. I would say this is a complete reconstruction where we have done the principles of the interbone screws, that is called as the, then there is the beams are done, there are the plates are done. So long segment fixation we have done. We have, even though disease looks only in the midfoot or the hindfoot junction, we have involved all the foot in the fixation, and this is called as the super constructs, and super constructs are the latest new concepts and they are the most salvageable things offering for the Charcot patients. One more patient who had this kind of a swelling, and you can appreciate that there is a gross subtalar shadow, which is the destructive shadow. And I was involved outside my parent city, and when we just took an incision, there was a aggressive pus which was coming out. We did the under microscopic examination immediately, followed by we send it for the pus culture and sensitivity. But I was convinced it's a gross infection, so we did not play much here. We just debrided, put antibiotic coated cement, double dose, put an external fixator and just waited. And after a couple of months, we got these results where the talus has fused with the calcaneum. There is no signs of infection. Everything is fused. And there's a little instability, but patient is walking with ankle foot orthosis. I have given him an option of fixation with CTT, that is the calcaneo talotibial nail, but patient said, I don't need a surgery. I'm happy with whatever I'm having. So this is also, when you find very aggressive infection, there is no point of being hero. You just follow the basic principles of orthopedics and infection control and you can get through the things. One more patient where there is a severe ankle deformity, almost 8 to 9 months, and it has progressed in last 2 months. The X-ray you will appreciate here better that everything is destructed. Talus has come down, the calcaneum, I don't know where the cuboid has gone and where the cuneiforms have gone. And in additionally, there is the infective discharging sinus with the active pus, which has shown the Klebsiella. So very dangerous situation. These kind of foods are, see, this looks very simple, but they behave very, very bad if you choose the wrong surgical methods or wrong implants, or you try to fix them very aggressively at these stages. So we took a safe approach. We did a very good debridement, just do minimal stabilization. Such a huge bone void was there. So we took artificial or the allograft of the bone. In addition to that, some autograft, and just put multiple K wires. Nobody will imagine this kind of fixation in waist, where they will be trying to putting multiple implants, super constructs, and they may be putting some high cost string implants and depth fixators. But we just got through with 5 pins, which are costing hardly 300 to 400 rupees. And at the end of 2 months follow-up, everything was looking stable. So as far as the things are stable, we decided to wait. At 6 months, all the wounds have healed, foot in reasonably stable position. Here we opened up again because you can appreciate here that some gaps, new gaps were appearing because part of the bone graft was dissolved. So we reopened and we put the definitive fixation with the principles of the super construct and the bone graft. And this is the end result. Again, the implant cost is hardly 3,000 rupees. Please remember that costs somewhere in thousands of euros and dollars when you are operating these patients in the Western world, and still they are trying to cut short how they can give a cost-effective treatments for these Charcot patients. This is a case 9, very interesting patient, ankle swelling you can appreciate. And there was a very trivial trauma. He never noticed anything for the first 2 months, but in the 3rd month, he started feeling that he is having little instability in the foot and ankle, and swelling has started gradually increasing. And this is what the X-ray shown. You can appreciate tibia has dislocated on the talus. You can say it's a type 3A kind of a Charcot in the Brodsky. And I have told you that I will show you every classified type of the Charcot in this discussion. And tibia has gone over the talus. Then again was the challenge. Everybody has advised him, don't do anything or just put TCC, or maybe you try to fuse the things in situ, because most important thing, the posterior tibial artery is here, and this dislocated tibia may damage if you are trying to correct this. But we decided to go ahead to do a proper fixation, and we reduced it absolutely in the anatomical position, put bone grafts, and this is called as the CTT nail, where the calcaneo talotibial nail was fixed, and additional stabilizing 2 screws and as well as 1 derotating plate. So this is the, we will not do it for a simple ankle arthritis or a subtalar arthritis where we are doing the triple fusion or the ankle fusion. But definitely in case of the Charcots, where I have to augment my fixation with multiple implants, but still implant cost is hardly 9,500, good stainless steel quality, and ISO mark implants are used in all the patients. No compromise has been done in the quality, but fortunately we are able to choose the low range of the economy, and still we can get away with the results. The most important thing in all these patients is I have chosen post-operative very meticulous protocol, good antibiotic protocols, and strictly non-med bearing for 5 to 6 months, followed by the total contact cast. So these are the 9 representative patients. From these cases, I have crossed this patient where the right foot is showing just beginning of minimal deformity, and the left foot has shown a significant deformity. So what was the situation clinically here? on the right side, there is nothing much, but the left side, you can appreciate there is the calcaneal, the midfoot callosity has started coming. Whenever you see the midfoot callosity or midfoot ulcer in case of a diabetic foot patient or a neuropathic patient, suspect Charcot as the first diagnosis unless and until proved otherwise. But whether to operate or not, both the things. So I did a little different exercise here. So on the left side, you can appreciate that there is a, when we are trying to dorsiflex the leg, I mean the foot and ankle, there is a gross instability in the midfoot and the hindfoot, while at the same time, on right side, there is no much gross instability. So this is one more armamentarium which I have added in my diagnosis and decision making is the dynamic X-rays under the C-arm image intensifier. And if there is such a gross instability, this patient should undergo surgery. I have advised him, but patient is still waiting for this. So this is the same thing. So in short, we have got these multiple kind of the implants. These are the ring fixators. These are the plates. Then these are the K wires. These are the cannulated cancellous screws. These are the CTT nails. These are the beam screws, which is the going with the beaming or the principles. Always a question is asked to me that which implant is the best, or many of the times I see the discussions or read the literature, and always a debate is going on that which is the best implant for the Charcot. So you cannot answer this question in one line. The simple answer is if you have these 4 cars at your disposal, which can be a best car. So it depends on what kind of journey you are planning. This is if you are planning to cross the roads of Bengaluru traffic, whether you want to go for the ride with your wife and listen light music, whether you want to go for the terrains on off-roading, and whether you want to go for a long distance journey with the family in the luxurious modes. So depending on the traffic situation and the needs, you will choose the car. Similarly, you will have to choose your own implants. And everybody must be remembering this very famous movie of James Bond, that's the Skyfall, where Silva has shown him the all technology, all new things with which he can just blow up the world or the economies or the small nations with just a click. And James Bond catches him with just a small radar signal, radio signal, and at the end kills with just a small knife. So old methods work many of the times, and you should not give up them. Only thing, orthopedics, and see at the end, Charcot foot is nothing but a complicated fracture of the foot. And fracture fixation goes with orthopedic principles of good alignment, stable fixation, early mobilization, and good physiotherapy. So it's a time, location, and that will be the bar to catch a prey or to reconstruct the Charcot. The Charcot foot are coming in different phases. They will be coming with the different villains of different segments. They can come as the Terminators, they can be the White Walkers, they can be the Bahubali villains. And you don't choose the same hero to fight with the same or different kind of the villains. So every villain has a different counterpart on our side. And we do have our Indian heroes, and they are equally spirited and equally fightful with our Western counterparts. So in one line, I would just like to say that never advise a Charcot just to go ampute recklessly or very with the callous attitude. It's a callous attitude of the doctor, patient, and the society, which leads to negligence of diabetic foods, especially neuropathic food, that leads to callus, that leads to ulcer, that leads to Charcot. So let's change our callous attitude and prevent the callus in the foot. Thank you very much. I heartfully give my thanks to the organizing team and the university for giving me opportunity to present this work. Thank you.
Thank you, Dr. Amit.
Thank you for
this. Go on, sir, Dr. Girish.
No, any questions on this? Because this topic is little, I know most of the audience is from the physiotherapy departments or the people involved in the physiotherapy consultants. But I will again tell you that if you feel you might be the first persons many of the times, if one patient will have some mild pain and trauma, he may go to an orthopedic surgeon, he will say in the X-ray there is nothing, this is just a simple ankle sprain, and you go to physiotherapist and they are the right person. So as a physiotherapist, especially if you get a diabetic patients or the neuropathic patients, please keep very close watch on these patients. And the moment you start finding there is a abnormal swelling, abnormal redness, abnormal temperatures, and X-ray is showing the fragmentations or abnormalities, we can do the early simple intervention of the total contact cast. And even if you find some deformed foots which are coming to you, because many of the times ankle foot orthosis may be given, recommended, or the crow walkers or some additional supplementing or the arches, they may be recommended for these patients. But if these patients are having dynamic deformities, just giving some arthrosis is not going to help the situation. There is a definitive role of the arthrosis and the specialized shoes and the insoles, what you all physiotherapy people are doing. But before that, unstable foot has to be converted into a stable foot. And then we have to give the ankle foot orthosis or the insoles for these patients.
So thank you for the excellent contents. You have given more than a case of 10 presentations of different cases. Just wanted to know what is the risk of premature death in case of a Charcot foot amputation due to diabetic and neuropathic foot, sir?
Sir, very good question, because Charcot is the most dangerous complication and the end stage complication of the neuropathy. And as I already told you that the neuropathy is not limited only to the foot nerves, it is limited to the autonomic neuropathy. And most importantly, it involves the autonomic neuropathy of the heart. So there is the autonomic cardiopathy. And the patient which I told you, that patient was found dead in the bed, she had 25% of ejection fraction, and she underwent post-operative turmoil. Twice she went into failures. Once she underwent arrhythmias. So all these things have to be definitely taken care while we are treating the patients. And these all patients should be treated in the multidisciplinary team, because my personal team has a in-house physician, cardiologist, radiologist, intensive care unit. But as you rightly said, these patients have, especially Charcot patient, most second important thing is they go on prolonged time for the bedriddenness. So in that scenario, deep vein thrombosis and the stasis related pneumonias, they also can be an issue. But as I'm aware, I do very aggressive management protocols on all these fronts, that unfortunately lady died at home only because her heart was 25% ejection fraction. I was actually surprised when they give consent for such a 2 major surgeries in a 3 days distance, because surgery takes 4 to 6 hours.
So as we observe, so mostly in the foot, unstable, midfoot will be there in the Charcot. So what will be the minimal surgical reconstructions do we, you do, sir? What kind of a minimal surgical?
Yeah, I would tell you, sir, what happens in a TP. Should I go back to the screen and show you a case so discussion will be a little easy?
Yes, sir.
Just a minute. Just a minute. I will go to the case and I will show you what actually happens. Yes, then this is a not still this. Yes. So when we see these kind of scenarios, what we feel is only it is the mid, especially in the midfoot, typical there is an abduction deformity, and the medial cuneiform and the navicle, they are dislocated, they are just coming out of the situation. But please remember that this is not the only deformity. How it starts all, there is usually a lateral cuneiform which sinks down. When the lateral cuneiform sinks down, the cuboid loses his support. Cuboid also starts falling, because you remember that in foot longitudinal arches, we have two arches. There is a medial and there is a lateral. And the lateral arch is made up of the lateral two metatarsals and the cuboid and just part of the lateral cuneiform. And lateral arch is always on the ground. So first arch to collapse in most of the cases is on the lateral side. So bones come vertically downwards on the lateral side. They go on the plantar side. Once those bones are gone, the lateral support is gone, the midfoot start abducting, and as a result, the medial side of the cuneiforms of the medial tarsus, they start coming on the medial side. There is one concept of beaming where they will just put a long beam screw from the metatarsal into the first ray and into the talus. But that will not be sufficient because unless and until we address to this portion, because these bones have come down. If we do a 3D reconstruction, we can definitely understand that lateral cuneiform and cuboid are usually coming down. And once you find out, you do a medial reconstruction and you go on the lateral side, you will not see bone most of the times. And in early cases, I used to get confused. Where are the bones? So bones have gone down. They have migrated medially. They are forming the bump in the plantar side. So you have to remove all that bump and you have to reconstruct the calcaneum, cuboid, and the first metatarsal ray also. Both the columns, that is the medial column and lateral column, has to be completely rigidly restored. We cannot get away with just something minimal, screwing, putting 1 or 2 wires, or just removing a bone and bumpectomy. I personally feel that if you do that, you get a temporary result, because once you do a surgery, patient is offloaded in the form of non-weight bearing for maybe 4 to 6 weeks. As it is offloaded, the wound heals. The moment he keeps the foot down, there is a dynamic deformity which is remaining and which has more progress. As you have removed some bones, there is going to be what I should say is the instability, and that progress instability will cause more damage. And then when patient gets the second time ulcers or deformities, they usually don't come to us. So we feel that we have done justice to Charcot, but they keep on roaming and one day they land up in below-knee amputation with some third or the fourth surgeon. So in one go, midfoot is, when you are dealing with the midfoot, principles are tendo-Achilles lengthening, medial bumpectomy, excise all the dead necrotic bone till you get the fresh oozing good quality bone. Go from the lateral side, check the medial side, do all the what we call as the midfoot joints reconstruction, put adequate bone grafts. You don't have adequate bone graft, take the help of the allografts, and then do long segment fixations, and do as far as possible try to use the plates, use the screws, use the K-wires, use the beaming, whatever is possible. But those beam screws which are recommended in the Western literature, they are very large size and they do not fit well in the Indian bones. I have made my own small size beams, but the beams work well only in the first and second, because if you go fifth and fourth of the time, they are likely to go out of the mid-tarsal bones. They will not go into the hindfoot. So that is one more problem. But complete reconstruction is the solution and we can definitely achieve it, sir. Even in the CKD patients, even in the complicated patients, I have shown you that even in grossly infected scenario, we have been able to save many of the limbs.
So just 2 more questions, because lots of interesting, information you are giving. Just wanted to know, when do you decide super reconstruction procedure? That in
no, super reconstruction means going beyond the zone of injury. You might have seen where I have done the internal implants. I have not just, most of the deformities were in the midfoot, but I didn't restrict myself. Now in this patient, deformity is in the midfoot, but if you see the fixation, it is in the forefoot, it is in the midfoot, it is in the hindfoot. You can see it here. This calcaneum is fixed with the talus, talus is fixed with the, or the calcaneum is fixed with the forefoot. So if you see the design of implants, calcaneum is fixed here, talus is fixed anteriorly, this forefoot is fixed to the hindfoot. So in one line, this structure becomes like an hanger. You imagine a hanger which has an anterior limb, which is a posterior limb, and which is a horizontal limb. And hanger, as it will just move like this at the upper end on the bar. Rest of the things, they will always maintain the relationship. If this limb is going up, this limb has to come down. If this limb is going up, this limb has to come down. It is only possible when all segments of the foot, that is this, if you have fused this triangle, 1, 2, and 3. If this triangle is fused and you have left the ankle, it should not give a big problems. Only in case when you have a 3A type of injuries where the ankle is involved. I have shown you the case, last case, 9th case, in which there is an involvement of the tibio-talar joint. There you have to fix the calcaneo-tibial fusion. There is no point in fusing in that much because that's a very restricted Charcot to the hindfoot. but still there we have crossed the zone. This joint is involved, but we have crossed 2 more joints in that case also. So super construct is the principle of going beyond the zone of injury and stabilizing the normal bones in an anticipation that in future they are likely to collapse or their collapse may affect our reconstruction.
Thank you very much, sir, for your wonderful presentation.
Yeah. There is nothing like a concept of a super construct implant. Super construct is a principle where different implants are used in such a way that you might be using intramedullary beaming, you may be using extramedullary rafting, you may be using locking plates, you may be using non-locking plates. In some of the patients, after doing all these patients, I have done external Elizaro ring fixator also. So that gives the complete stability and complete immobilization. So that is the principle, sir.
Thank you, sir. Thanks a lot for your wonderful presentation with so many cases and with lots of patients for months to years together. You have been waited to see a patient walking. A wonderful presentation, sir. Thank you very much, sir.
Thank you, everybody. Thank you so much.
Thank you, Dr. Amit. It was a very wonderful insight on the subject, and we would wish to see early diagnosis in most of the patients so that you can, treat them better.
Yes, sir.
Thank you.
Thank you.
Thank you, Amit sir. I want to extend my sincere gratitude for explaining cost-effective and method for charcot foot reconstruction. Your contribution are truly helpful for the society. I appreciate how clearly you explain the operation aspects. I also would like to thank Dr. Girish and Dr. Sai Mahendra to be the part of this session. Now we'll be proceeding towards the next innovative talk session by Professor Pradeep Kumar.
Hello, ma'am. Is it audible?
Professor Pradeep Kumar is presently working as an assistant professor at Computer Sciences and Engineering Department, College of Engineering, Dayanand Sagar University. Sir has served 11 years of teaching experience and 1 year of industrial experience. He has made a significant contribution to the field. He has been distinguished speaker at numerous conferences and workshops, and his expertise spans a wide range of areas. I would also like to welcome the chairperson for the session, Dr. Esha Arora, lecturer at Asian Institute of Medical Sciences, Malaysia, and Dr. Suman Yashoda from Yashoda Hospital, Department of Physiotherapy, Hyderabad. Proceed with your session.
Okay, thank you, ma'am. Is it audible, sir?
Yeah.
Yeah, good afternoon, everyone. So let me share my screen. At the utmost, I just thank Vishwarupa ma'am, like to a warm welcome for this particular session. So, and here is my particular share screen. Hope so the screen is visible. Okay. So basically, I belong to electronics department, and it's been my keen interest to add the concepts of artificial intelligence to the healthcare concepts. Okay, so I'm like working as an assistant professor in the department of AI and ML, Dayanand Sagar University School of Engineering. The content what I just wanted to discuss for today is like a kind of brief introduction, like how the AI will be helping for medical healthcare and how the content creations will be done in the age of generative AI. What will be the content generation pipeline, the content revision, how the quantization will be done when we have a huge set of data, and then a brief conclusion. So here I'm not expertise towards the medical field so that I can showcase of any case studies. I can only explain you like how the AI will be helping to the concepts of medical healthcare. So like first and foremost, so we will be having a few introduction about what you mean by this AI and ML, and what you mean by healthcare, how it has been effective, how it's been like helping towards this, towards the major scenarios. Like first and foremost thing, like adding AI with the healthcare or adding AI and ML with the healthcare, it will be a kind of cost effective, and it will be a more efficient and accurate healthcare. So in the next part of the session, like there are much of the tools which will be working on the AI devices like medical diagnosis, personalized medicines, drug development, clinical trials, medical imaging, and then patient care. So these are the there are major maybe kind of equipments or maybe a kind of apps which are being developed in order to take care of the health of a person with respect to some of the tools, which will be considered with the help of the AI and ML. These tools, like the mentioned tools, which have been helping to improve the patient engagement and overall patients experiencing by providing personalized care plans and facilitating communication between patients and healthcare providers. Like it's a kind of communication between the cloud and as well as a patient. So this is what the NML has been helping to improve the health sector towards the patient. And lastly, we can able to potentially provide a significant benefits for the patients, even for the healthcare providers, and also for the society as a whole. Like any new kind of diseases, it will come by observing to the patients. Even the healthcare providers also can learn about it, and even the patients needs a remote assistance. Then the AI concepts, it will be helping for him to benefit to the patient's health. So this is what the introductions, what brief points what I can add it for the AI healthcare. The next, when it comes to the importance of AI and ML in the healthcare, so like we can able to put an importance like to detect early detection of the disease. Like instead of going to the patients, like we can give the inputs of a patient, what kind of problems he's been faced, what kind of problem he's been facing, so that there will be early detection of disease, and there will be a personalized treatment, like a kind of remote treatment also it can be produced, and there will be a personalized treatment. There will be a reduced in the medical errors because all the information, it will be stored, it will be available, it can be retrieved at any instant of time. Like say for example, if I go to the hospital and if I say what kind of disease I am having, then might be I will be losing some of the points what I want to explain, or the doctor can be forget 1 or 2 points what it can be means explained by the patient. So those kind of errors, it can be errored by giving the complete inputs with the help of the textual images. Like with the help of the improved textual developments, we can have the improved drug development, like the accurate drug we can able to give it, and it is a completely cost effective. So these are the few important points of having NML in the healthcare. So like when it comes to the how accurate the data can be recognized, not only the AI will be acting in a play role. So there are many much more concepts related to the AI. So where I can say that artificial intelligence is one sector which will helping the healthcare. Machine learning is again a second sector where the inputs given by the artificial sector, the machines will learn on its own to give more and more predicted decisions. And we have a predictive analysis, and majorly nowadays even the patients are being lacking enough to type some things. They are more familiar with talking to the apps or talking to the devices. So we will be adding a kind of natural language processing, that is NLP concepts to the healthcare. And there's a computer vision, like so far recently in the previous sessions I was been saying that there are a lot of case studies have been displayed. So those case studies, again, we can give it to the machines where the image processing can be done with the help of the computer vision, and the actual records can be maintained, that is electronic health record can be maintained. And based on all the scenarios what it has been circulated here in a circular shape, so there will be one decision support that's called as CDS. So using that CDS, the proper diagnosis and the proper medications can be done. So not only the AI and ML, along with the NML, we'll be adding with other concepts like NLP, computer vision, electronic health records, maintenance of those records. Based on all these scenarios, we can able to give the decision for a predicted devices. This is how, and all these scenarios will happen very faster, and it will be more accurate during the diagnosis. So we can say that AI powered medical imaging or AI powered medical assistance will be more faster enough, and it will be more accurate. So next, in order to have this particular concepts in the medical trend, that is adding the AI with the healthcare. So we will be adding with the two major concepts. One is called as Gen AI, which is a recent trend nowadays in the generative platform, and the usage of the LLMs, which will be a major trend like nowadays. Since from past 1 or 2 years, this LLM trend has been started, which will be called as a huge amount of data set. So based on the available of huge amount of data sets, we can able to train the patient. So we can able to test the patient, and we can able to give the predictive things for the particular patient. So let me just discuss with a brief thing about what is Gen AI it has been doing. Like Gen AI, it is a new possibilities in the domain, in each and every domain. where it accelerates the innovations. As the machine said, that machine learning, the concept is that the machine itself will learn based on the inputs which it will be seeking. So number of inputs, the number of machine will be expertise. So when it comes to the expertising machine, the Gen AI will accelerate new innovations. Like every time the persons talk to the device, the persons talk to the apps, the person talks with the concepts of NLP, that input will be fed and the proper solution for that input will be it will be tracked, and that tracking of the information can also be stored. So it will be accelerating the new innovations again and again, and it increases efficiencies, like how much ever I'm going to train the model, how much ever I'm going to use that particular model or the user concepts, so that much there will be increase in the efficiency. It improves outcome. Obviously, when there is a lot of inputs and when it works with a lot of efficiency, then there will be an improved outcomes we can able to expect, and generates the new therapeutic candidates, better matching patients with the right clinical trials, powering patient engagements and then applications. So there is a one examples which it will be worked on the generative AI, which is already into the platform, that is supposed to be called as Amazon Bedrock. So the Amazon Bedrock, a few information about the Amazon Bedrock, how it will be working, how it will be helping the patient have been added in the slides. So let's go through with the next important concept which has been helping for the AI, that is supposed to be called as LLM. A brief introduction about what LLM is. Actually, LLMs are trained on massive amounts of textual data, which generates coherent and fluent text. So basically, the LLM, it basically works on the text data, like what inputs. Like when we go to the hospital, doctors will be asking that what is a problem, so on. So instead of asking and orally explaining, like it will be in a form of textual communication. So that textual communications will help us to create the data. So that where the LLM stands here. So LLM mainly performs well on various natural language processing tasks also. Even like some days, like persons who have not been able to use the system or use the typing concepts very much speed, like they were able to talk to the device, able to talk to the doctor, and the doctor can able to turn on the recording machine. So from the recording, we can able to convert that voice to textual format. So there where the natural language processing task will also be added to this one. And we will be having a GPT, that's a chat GPT is one of the example of the large language model. Like nowadays, more than the Google Assistant, what it will be giving, we are completely like dependent on the chat GPT. So chat GPT is one of the example of the large language model, which I can explain it in brief over there. These models are called as large because they have billions of parameters that shape their response. So because of having the wonderful data sets, we can able to add this LLM. So how much ever the data is been available, that much good the system will be entirely working. So now, as I said that including this Gen AI and the LLM, so they have already been, the Amazon have already been one of the concepts called as Amazon Bedrock, which will be working on this particular scenario. So where else we will be calling it as a training, on-demand analytics, project management, people operations, coding, performance report, strategical and ideation, and then customer support. So including all these scenarios where each stakeholders will be involved here. Like in order to train, we need a doctor. In order to go for on-demand analytics, we need to have a marketing survey. Like say, for example, if I'm getting a fever, then it is better for me to go for Dolo 650 or any kind of other medicine. By even having the confusion within these two, I will be going to the market analysis, like which patient has preferred Dolo 650 and which patient has preferred another one. So depending upon the market strategy also, I can able to choose. So whatever it's been mentioned at the right hand side in the image, everything is found to be important for the Amazon Bedrock. So what is this Amazon Bedrock? Basically, it's an AI assistant for the medical content generation. So it is one which is able to generate the medical content, like what and all prescriptions doctor will be giving, what and all case studies the doctor will be reporting, and what and all like kind of papers what the doctors will be feeding with respect to their journals, with respect to their conference, and with respect to their thesis, what they're uploading to one of the cloud. So from that cloud, the AI assistant will be working, and the sectors which will work on this inputs, they're supposed to be called as an Amazon Bedrock. So basically, again, as I said, it's a combination of Gen AI and LLM. So it is an effectively reduces the overall generation time from week to hours while having the subject matter experts. So in order to give the large amount of inputs, obviously we need to have one good subject experts. So what inputs that the SMEs will be giving, so based on that, the Amazon Bedrock will be working over here. So next, when it comes to the assistant and its different components, like we can have medical references, content brief, rules and regulations as a kind of input, what each and every hospitals will be having, what each and every doctors will be giving to the patients. And we have got the main models like called as content generation, fact checking, content revision, and then rules compliances, like say what and all rules, the doctors will be informing the patient to follow up. So everything, including the inputs and including the main modules, this Amazon Bedrock, it will be all, it's been already implemented. It's been already available in the Play Store in order to implement and in order to use the cases for the patients. Like as I said, this Amazon Bedrock has got a few classifications in it. It is not only the one which includes only Gen AI and LLM. So based on that, as mentioned in the previous slide, we have got something called as ideation, keyword research, writing and editing, and then publishing. So this is what the content creations, what the Amazon Bedrock has got. Whereas Streamlit, which is one of the open source app development, which is used to manage the Elastic Container Services. This will be used as an user interface, where UI is supposed to be called as user interface, which will be interacting between the patient and the cloud, which will be interacting between the patients and the cloud, where the cloud will be having the data which is being fed by the SMEs. And we have got something called as Amazon Lambda, which will be a backend code which encompasses the generative logic. So where without logic, the data cannot be fetched from the cloud. And we have the Textract, which is a text and layout extraction feature in the Amazon, and Amazon Bedrock, which will be interacted with the support of LLM and then enabling models, and Amazon translators, which the patient can usually prefer with their own mother tongue. So we can have the Amazon translator also, which is an added code in order to explain the concepts of the diagnosis, concepts of the disease to the patient in their own mother tongue languages. And then Amazon Simple Storage Service. So we have a very good cloud nowadays where each and every information can be stored. So in order to go for this entire scenario, the Amazon Bedrock has got this basic block diagram in order to store the data and in order to fetch the data for any kind of diseases. So it will be referring the Amazon Bedrock. It will be referring the PDFs generated by the doctors, generated by the medical agencies, websites. There are many websites in order to give the information about each and every medical diagnosis, each and every medical process, images, tables. From that, it will be extracting the Amazon Bedrock. It will be extracting with the help of Textract, and it's going to use a summarization model, right? So there are many concepts like after generating the text, after storing it into the cloud, like we can able to see that Amazon S3, which is nothing but a cloud, using that particular cloud, and in order to fetch the actual predicted outputs, again we will be having a concepts of prompt engineering, where the prompt engineering will be working. Hence we need to prove that the machines which we are being framed, it should be prompt enough to answer to the questions. So we will be having a concept of prompt engineering over there. So we will be having a concepts of ethics in AI, that is without proper ethics, we can't able to give the complete system as a working device. So there should be an ethics in the flow, what the machines will be working and on what data it will be working, and there will be a prompt engineering concept. So using this basic block diagram, the Amazon Bedrock, it is going to helpful over there. When it comes to the content generation, like as I said, Amazon Bedrock, in the right side of the screen, you can able to see that just by only typing the disease name or just by only typing what I wanted to expect, so everything it is been generated automatically. So it even no need of typing any extra cases, just by only selecting the pop-up windows, just by only selecting the buttons which is been related to that particular disease or that particular medical content, every information can be read out over there. And there's a concept of NLP also, there's a concept of language translation also. So the user can able to generate that information in his own mother tongue. So I can say that content generation, it's been done with many of the things which has been explained in the previous slide. Based on that content, the patient or even the doctor, sometimes the doctor also might be confused with what kind of precautions I can able to give it. So based on this kind of apps or based on this kind of platforms, the doctors and even the patients can be helpful over there. So when it comes to not only the content generation, always there is a revision in the content generation. So basically, like what the data doctor will be providing or what the patient will be providing. Like say sometimes I say that yes, I have got a headache. When I go to the doctor, I will say that yes, I have got a headache. Then the device will be recording that the patient has got headache, and slightly the next question will be, no, it is not severe, it might be a light kind of headache. So based on that, the second input will be taken from the patient and the revision will happen. So whether the patient is been ill, whether he has got completely the headache or he has got a slight headache, or what is the severity of the headache. So based on this, again and again the content revision will happen. So after having each and every information, even though, for example, 10% of headache, 20% of headache, or might be 90% of headache, there might be a different scenario of treating that particular patient. So based on the content, what the patients will be giving, so the doctor will able to provide the prescription. So in order to refer these inputs, we will be creating an Amazon Bedrock. So the content revision is also one of a key role player, which will be helping in the AI part, right? So AI part. And along with this, as I said, that when we have a kind of huge data, we are telling that one doctor will be giving one data, another data will be giving another data for the same disease, how the machine can able to recall that data, how the machine can able to give the accurate data. I was even talking about the prompt engineering and the actual predicted solution for that particular disease. So along with the LLM, along with the Gen AI, along with all the scenarios what I explained so far, so we will be adding a concept called as quantization. So already we are in the process of having the quantum systems in the hospital also, which is a huge system which can able to predict the X-rays image recognition easily, which can able to go for MRI scanning and give the actual situation where the problem has been arised. Sorry with that, I don't know much of the terms with related to the medical, but I can say that if I go for MRI scanning, then automatically along with the image, the report has to be given that this part of the brain has got some malfunctioning. So that is what the quantization it will be helping. So this quantization, it is like a kind of mathematical approach in the input data set what they will be having over there. So for this particular quantization, there are a lot of Python codes have been learning. For that quantization, we need again the LLM backup. And here is what one scenario we can able to create the machine or the device without quantization or also, and with quantization also. But with quantization, it will be a kind of saving the data and then saving the cloud where the data can be stored. So one simple example I can give you over there with the help of mathematical, as it's related to the complete quantization, I can say that if the actual data it is of size 32 GB, say for example any of the image which has been taken for the patient the diagnosis, if it is found to be of X MB of data, then processing that X MB of data might be some of the devices might take large amount of time. So that is a usual process with respect to the meta lamps, which will be having a base model having a 32 GB of storage. It will be like a tough enough for a machine to go for the processing. When after adding the quantization to the same processing, we can again reduce that image, means we can process that image or process the data or process the textual information to a very low size of 8 GB and then 4 GB. When the size of the, means when the feature of the image remains same, and when the size of that particular image get reduced, I'm just taking an example of X1 and X2. If the size get reduces, then the machines will start approaching the solution too early. Means say that instead of working on with the 32 GB data, it will be better for an machine to work on the 8 GB data, and even it is still more better for an machine to work for the 4 GB data. So this reducing from the high size of the data to the low size of the data, this quantization it will be helping. So right, so having the Gen AI, LLM and quantization, it makes a complete platform for an AI and ML to take care of the complete health related sectors. So this is what a simple way what I just wanted to give you some brief information about how the AI and ML will be helping towards healthcare. So we can have, with the recent improvements in the quality of LLM, generated text, generative AI, which has become a transformative technology with a potential to streamline and optimize a wide range of process and businesses. And then content generation for the disease awareness is a key illustrations of how LLMs can be leveraged to the generated, curated and high quality marketing contents in a hour instead of a weeks. So instead of waiting for a long amount of time, so basically I can able to go for a direct approach to the with the help of many of the medical apps, many of the medical devices, so that I can able, means the patient can able to get the automated solutions and the accurate solutions at the end of the approach. So hence, these are the few references what I took for the developing of this particular slides and collecting of some information towards AI and healthcare. And without of ending my solutions with much more apps which are already available, which are more popular nowadays, which AI has been trained over there in order to predict the disease and the outcome of that particular disease. This was my particular presentation in brief. Thank you. Any questions?
Thank you, Professor Pradeep, for taking time to explain the various applications of AI in healthcare and its importance in advancing the field. I request The delegates, if you have any questions, to please put up your questions in the chat box. To thank our chairpersons for this session, Dr. Isha Arora and Dr. Suman, for joining us. I request them to please comment on the continue with the discussion.
Sir, I think you are on mute. Sumant, sir, I think you are on mute.
You're not audible. Dr. Sumant, you're not audible, sir.
Yeah. Pradeep, now you are audible?
Yes, sir. Yes,
Yes,
sir. It's
sir.
audible
Yes,
now.
Yeah, Pradeep sir, it's quite interesting. It's quite impressive too, the way you are understanding headaches. So I have a question, not a question, it's a request. So most of your talk went towards the medical system. When it comes to physiotherapy,
yes.
So the most of the time, our sports medicine is evolving, and most of our surgeons, they have been operating on shoulder. I'm taking an example of shoulder. They are operating on a shoulder, and they're doing a quite number of surgeries. And for each and every surgeries, the rehabilitation protocols are different.
Okay.
The biggest challenge what we face is after patient getting operated from a hospital, they'll be moving towards the remote areas.
Correct.
It is why it is a very quite difficult for us to understand what's going on with the patient at remote area. So it's very difficult to communicate with the patient as well with the patient as well with the physiotherapist who is available over there.
Okay.
So because they need to perform a criteria based rehabilitations, is that possible to develop certain algorithms based on the surgery done? For example, there is a Rampisar surgery and Latarjet surgeries. For each and every surgery, there is certain rehab criteria.
Okay.
So we need to develop certain algorithms for each and every surgeries.
Correct.
So that if the patient is not reaching the criteria, so the patient should get in some alarm sign, and the therapist, the doctor who got operated, and the prime physiotherapist.
Yes.
All three should get some alarm sign so that we talk to the patient, and we need to develop certain algorithms so that the patient can correct. So is that will be possible?
Yes, sir. Like it will be possible. Basically, as it's been said that AI means it is like kind of involving the algorithms, involving the computer. Basically, I will be depending upon the computer and the data. These are the two things. When I say about an app, like say for example, you have been operated for a shoulder, which you are taking as an example as a shoulder injury, and you will be operating. So before you send a patient to the doctor, like we will be having a kind of one more electrical device attached to the shoulder. Like say for example, you can inform the patient without means if you treat that patient is well enough and he's been listening to you, you can inform that this is a strip which you have to put it on your shoulder at least once in a week. If you treat that patient is not listening to you and you want to continuously monitor the patient even if you go to his native or something remote place also, you can make a note that we can minute that strip and we can able to place that strip inside the body itself, and that strip it will be working with respect to the Bluetooth especially. And anyhow now a scenario is that everyone are into the field of smartphones, and the app what it will be using, that app will be always communicating with the strip which is being implemented on the body, inside the body or maybe outside the body. And we should be suggesting to the patient that if the patient is well enough, well educated enough, then obviously he will not cross the information of a doctor and he will use it on the body. If the patient is been missing the information of a doctor, it is a work of a doctor that at least put one small strip inside the body itself while operating. So that will be completely communicating with the mobile, and that information, whatever the sensing, it will be done by the strip which has been placed on the body or inside the body, that will be communicated with the app. And whatever the changes happens, whatever the malfunction happens in the shoulder, that will be recorded in the app and directly it will be sent to the doctor. Even there is no option for a patient to send this data or not send this data. The app has been created such a way that if there is a malfunction in the regular flow, automatically it will be recorded and it will be sent to the doctor immediately. So these features we can able to create it very easily with the help of mobile application development, sir. And that mobile application development again can be fetched with a cloud base and it can be able to. It is a kind of easy task for an any kind of developer who can able to develop that app, sir. It is possible.
Okay, thank you so much, Pradeep. This is the need of the hour.
Yes,
and because with this we can prevent a lot of resurgeries, and we can make many remote patients happy.
Correct,
thank
sir.
you.
But there is a problem that the patient has to be in a position to give the information, all information to the doctor without hiding anything.
Yeah,
That's
yeah.
Yes.
So we need to tell them in counseling
Correct,
sessions.
correct, sir. Correct.
Yeah.
Yes.
Thank you, Pradeep.
Thank you, sir. Thank you so much.
Good afternoon, sir. This is Isha here. Am I audible?
Yes, ma'am. Yes, ma'am.
Sir, actually, maybe he has given more of the clinical aspect. I just wanted to ask, like, now every day on the website there are new links coming up, which are actually some may be genuine, some may not be genuine. So, how the systems, like when you were talking about your this Amazon Bedrock, you said that in the Amazon text tract they will extract all the data from the websites and
Yes,
the
ma'am.
PDF.
There is from the beginning of the AI, the first challenge towards any development of the AI is the security issues, ma'am. And we need to put lot of protocols towards security issues. That even like one example I can give you, how much ever the technology goes good, how much ever I can secure the technology, I can make it out, ma'am. But irrespective of the human intervention in that one, like say for example, I will give my particular hard disk which is completely protected with a password and which has got complete data, and instead of me going directly giving to the person to whom I need to submit, if I give it to some X person and tell him to deliver over there, then I don't trust with that X person. So obviously there is each and every challenging aspects to the first and foremost to the security concepts. Whatever technology is there, we can develop high-end technologies, but security, there is lot of challenges at every instant of time, ma'am. And we have got certain protocols also to put some complete security, like kind of one-time password, two-time password, or maybe multiple time of password also we can able to create it, and we can make sure that the data cannot be leaked over there, ma'am. So that is a challenging way. Every technology has got its own drawback, and security is one of our issue here.
So how
But we
much
can overcome.
actually rely on such things when it comes? Because if you see like Wikipedia, Physiopedia, there are so many things coming up. So is there how much can we actually rely on such things?
Ma'am, like instead of Wikipedia and maybe another side of this thing, like why can't we have an SMS itself? Where the means SMS means, as I explained, that it's an subject matter experts. Instead of relying to the Wikipedia or instead of relying to some other websites, why can't an experienced doctor, only the machine? As I said, it's a machine, and I want to create it. For example, in Danan Saga CD Simar itself, if I want to install a device, and I will be sitting with a doctor, I'll be creating a particular machine or an app, and I'll be seeking help of only the experienced doctor what inputs he will be giving. I'm not referring with any of the other sites like Wikipedia and all. So I can avoid much of the additional inputs over there, and I can only make a machine to work on the inputs what I'll be receiving from the SMS. And if that SM is a Wikipedia, then no issues. Whatever inputs you get it from the Wikipedia, you can train your model on that one.
Okay.
Yes.
And exactly when it comes to the apps, like if we talk about the walking apps,
Yes.
there are multiple apps which are coming up on like if we have Google, Apple Store and Google.
Yes.
Actually, when they're making up, they keep on updating and all those things are done. But how much can we actually rely on such components?
Yes, ma'am. Like usually, like as we have even this antivirus in our software, even though right now I've seen that in the mobile also every monthly once, my mobile has been set to scan its all apps monthly once. So automatically the apps will be scanned with the help of the Google Play Store, and we have only two sectors as of now. One is Android and the other is Apple. One is like a kind of Google Play Store and the another is kind of Apple Play Store. So they themselves have released an software which will be scanning the entire apps in the mobile. mobile. So that usually my phone will be doing it once in a month, and it will check all the apps which have been installed, which have been used. If that app it is been not been under the concepts of Google Play Store or maybe the Apple iPhone Play Store, that app will be removed automatically, or that app will be means it will be projected as a suspicious app. So immediately the patient should be, or even the doctor should be in a position to uninstall that app. So that is what the scenario we can able to do. So without the proper applications or without the proper authentication from the Google Play Store, if it's an Android phone, or from the Apple iStore, if it's an Apple phone, so none of the apps can be released, ma'am. And whatever we are going to install it from the Google Play Store or maybe from the Apple iStore, they are much genuine itself. We will treat that as a genuine app itself.
Yeah, I think it's
And the updates, yes, updates and all immediately, like as we know that whenever we open our WhatsApp, maybe after 2 months once, automatically it will ask for updates. We will click on that and automatically updates will be done, and the features which have been updated in the recent version, that can be fetched to the same app itself without installing or without again changing the data and all. We can able to do it out.
and sir, one last question. Is there anything right now you're working on with the medicals for any app right now?
Yes, ma'am. Right now, like recently, we have talked with the physiotherapy department in the CDSIMR. Like we are working on the gait analysis. That is the physiotherapy work. We have started it. Like within 1 or 2 months, we have already written a proposal also, and we are starting for that one. That is the walking movement, like the malicious function in the walking steps of a physiotherapy. That is for gait analysis. We are working on it, ma'am. Yes, ma'am.
Okay.
Yes.
Thank you for the information, sir. Thank you so
Thank you
much.
so much. Any other questions?
Thank you, Professor Pradeep, and thank you,
so much.
Dr. Isha and Dr. Sumat, for your discussion on the following topic, that is AI in healthcare. Now we'll be proceeding for the next session, which is the 5th innovative talk by Dr. Rajesh Bharathan on the topic Empowering Clinicians with Technology, VibraSense and its Impact on Screening Diabetic Neuropathy. Sir is currently leading clinical development at Ayati Devices, a Bangalore-based medtech startup dedicated to addressing diabetic foot complications. With over 15 years of experience in diverse roles, including clinical research and medical marketing, digital health, and edtech domains, Dr. Bharathan brings a wealth of knowledge and expertise. The session will be chaired by Dr. Vikrant, Dean and Director, Hosmer College of Physiotherapy, and Dr. Ravi, Professor, SDM College of Physiotherapy, Dharwad. Session. Sir, you may start your session.
Can you hear me?
Yeah, we can hear you,
my
sir.
Screen started sharing?
Yes, sir.
Yes. Greetings, everyone. Greetings to the esteemed chairs for this session, Dr. Vikrant and Dr. Ravi. Thanks to the College of Physiotherapy and to the organizing committee of this conference for giving me an opportunity to talk. So in this session, I'll be shedding light on one of the significant issues that face diabetes patients, which is diabetic neuropathy, and how we have leveraged technology to address that issue. So before I go to the actual talk, just a brief introduction about our company. Ayati Devices is a medtech company based out of Bangalore. So today there are many students here in attendance. So our company actually was started by a student, Nishant Katpal, who is the CEO and founder. When he was doing his MTech course in IIT Bombay, in his collaborative engineering course, one of the problem statements that was placed in front of him was diabetic neuropathy and how technology can be used to kind of diagnose the condition. And while his first device that he was developed as a prototype did not become a commercial product, but he understood that there is a big problem to be solved. And that's how our next device came into existence. And he incorporated a company. And today we are here working on more products, actually. So let me just start with the problem statement. So diabetes, as you know, the latest estimates from the International Diabetes Federation is that 540 million diabetes subjects are there in the world. And in India, the last data from ICMR INDIAB study says that 100 million plus diabetic patients are there in India. And every 30 seconds, there's an amputation happening and a limb lost due to diabetes. If you take away the traumatic amputations, among the non-traumatic amputations, almost 70 to 80% is happening because of diabetes. And it is a multi-pronged issue. But if you look at the major problems that is causing amputation and diabetes, one would be neuropathy, and the second would be peripheral artery disease. So neuropathy, if you look at almost like the prevalence varies, like in some studies say around 18%, some say around 60%, but the thumb rule is around 50% of the diabetic patients will develop neuropathy during their lifetime. And because of this, basically they lose the sensations in the peripheries. Mostly it affects the glove and stocking area, and small injuries, they kind of go unnoticed. These get infected. And because of peripheral artery disease, again, like 15% develop peripheral artery disease, which is a macrovascular complication within 10 years. And by 20 years, almost half of them are having some form of arterial compromise. And that will kind of reduce the wound healing. And foot ulcers, again, around 19 to 34% of diabetics will develop a foot ulcer in their lifetime. Half of these will get infected, and around 20% of that will go into amputations. And if you look at the cost of all this, this is the data from US, where from the insurance data, when they check of all the $100 that is spent on diabetes, almost 1/3 of it goes to managing diabetic foot ulcers and complications such as amputations. So the good news here is like 85% of these amputations are preventable with timely intervention, proper diagnosis, and effective care. And one of the cornerstones of prevention is screening. So the American Diabetes Association says that every type 2 diabetic patient should be kind of screened for diabetic foot conditions at diagnosis and annually thereafter. In type 1, like 5 years after diagnosis and annually thereafter. And these recommendations of annual screening is like followed almost everywhere, including ICMR recommendations also says that every year you need to screen the diabetic patients for neuropathy, basically. What are the basic tools that we have currently? We have the 10-gram monofilament. Basically, it's a small nylon thread. It bends at 10-gram pressure. So basically, you apply the monofilament at different points in the foot and see whether they're feeling the sensation or not. And then you can like monitor for vibration perception using a tuning fork. So these two, you are basically looking at the large fiber function. And then for the small fiber function, you have thermal discrimination. Previously, we used to use test tubes. Now there are like specialized pens with metallic and plastic ends, which have different thermal properties and therefore help you discriminate hot and cold. If you want to check the patient can discriminate hot and cold, you can use these kind of pens. And pinprick basically for pain sensation. Again, these temperature and pinprick we are using for small fiber neuropathy. But these tools are essentially qualitative tools, which means that by the time patients are detected with these tools, they would have been in a progressed stage or an advanced stage where you can't do much, basically. So there are also quantitative testing methods where you quantify at what level patient feels vibration, not what level patient feels his temperature loss and all that. So those are known as QST tools or quantitative sensory tools. And we have leveraged one of those QST methods for our VibraSense. So essentially, VibraSense is a quantitative sensory testing tool for vibration perception. Now, there were tools previously also, they were known as biothiometers, but these used to be like big machines like the old VCR boxes that we used to have in our houses. And they required space, and to generate report, you needed a PC or a laptop. And therefore, only specialized settings and endocrinologists and specialized diabetologists used to use those kind of devices. But essentially what we have done is like miniaturize the technology, made it very portable and pocket-sized. And the device, we have made it like a mobile phone, which is rechargeable. And once you charge it, you can do around 70 tests with a single charge, which means that you can take it, once you charge, you can take it around the facility. If you have a diabetic camp, you can take it there. And also the reports, you need not have a laptop to generate a report. There's a companion mobile app. You can pair it with your mobile device and generate a color report, basically. And also like the entire testing procedure, which used to take 30 minutes with the biothiometers, we have simplified so that you can do it within 5 to 10 minutes for both the feet. The other thing that we have done is we kind of give color reports. For like mild, like normal is usually given as blue, and then as there is impairment of vibration sensation, we kind of classify it with different colors, mild in green, moderate in yellow, and severe impairment in red. So essentially, this kind of serves as an educational tool for the doctors to show the patients that, okay, you're losing your sensations in your foot, and kind of you need to like have a stricter sugar control, and you need to like follow foot care precautions that like even in your house, you need to wear slippers, and those kind of educational interventions can be done. And the other thing we have built in is longitudinal tracking, where like you can kind of, once the patient comes back after 6 months, after 1 year, you can kind of track it and see like how they are progressing, whether they're maintaining their vibration perception thresholds or it is worsening. So this is again another motivation that you can use for tighter sugar controls, basically. So in terms of clinical validation, this is where we partnered with the College of Physiotherapy, Dr. Srihari, who was one of the investigators. And it was a joint study that was conducted with C.D. Zymer, Dr. Anil Kumar from the medicine department. And kind of we validated the device to an existing biothesiometer and a nerve conduction study. And this was published in Journal Foot Ankle Research. In terms of regulatory, medical devices in India are like tightly regulated now. And we got the CDSU approval, like the same body that controls drugs is now in charge of giving approvals to devices. So we have approval from the Indian Regulatory Authority. Also, we have CE mark, which allows us to kind of export the device to Europe. And we are US FDA listed, which helps us sell the device in the US. So in terms of like how we have done business-wise, we have from the last 2 years, we have deployed more than 3,000 devices across India. And from last year onwards, we started importing these devices. And roughly till now, we have started to import to around 15 plus countries. In terms of our product portfolio as a company, now I told you like VibraSense is a quantitative sensory testing device for vibration. The next device, VibraSense Plus T, we are also building in the capabilities to do QST for temperature, which is cold perception threshold and hot perception threshold. So that's one device that is in the pipeline, and it will be released this year. And the other device that we have in research is a laser-based imaging system known as AngioCam. So I told you, like in peripheral artery disease, the blood supply is reduced to the kind of peripheries. So this is basically a device for imaging and quantifying the flow in the blood flow in the skin, and with potential applications in chronic wounds like diabetic foot ulcers. And also it will be useful for plastic surgeons for depth of burn wound, assessment of depth of burn wounds, and to evaluate the vascularity in flaps, basically. So we as a company have won multiple accolades in different, not only in India, but also abroad in different competitions and different events. So the last was this year, like we won the award in Qualcomm Design in India Challenge 2024. We were the winners. To end with, this is our vision and mission as a company. So we want to become a world leader in providing the first level of innovative and affordable healthcare monitoring solutions for the masses. And our mission is again focused on diabetes foot and how do we combat diabetic foot related amputations, and how do we equip healthcare providers with cutting edge screening devices enabling early detection. To summarize, like diabetic foot, neuropathy and diabetic foot problems are going to be a major burden on the healthcare infrastructure, and technology can play a great role in kind of addressing that. Like the case, one example in case being VibraSense. I think the previous speaker spoke about, talked about AI and ML. So I think technology is going to play a bigger role, not only in diagnosis, but also in management in the coming future. So that's it from my side. Happy to take any questions.
Dr. Bajesh, can you hear me? Is it audible?
Yes, sir. Yeah, I can hear you.
Dr. Bajesh, it was a wonderful presentation. I can see the technology going forward from qualitative devices to quantifiable devices right now.
Right.
My question is, or my query is this the same thing as that of a vibrometer changed into a handheld device, or?
Correct. So the technology has been there always, in the sense like from the last 20 years. But those devices, as I said, used to be tabletop machines, right? You required a space, and you had, like, if you had to generate a report, you had to like either write it manually down on a paper, or you had to like pair it with a laptop. So this we have kind of miniaturized, and that's the technology piece where we were able to build in the same kind of technology into a smaller device, which fits in your pocket basically. So it is just a handheld device. It weighs roughly 300 grams, and it goes into a doctor's coat pocket.
And wow, these biotissue meters, they have values that they give out, as in
Correct.
if it is less than 10, it is
Correct,
normal,
correct.
and then if it is
Correct.
more than 11 or
Correct, correct.
they give out minimal, mild, or moderate, or severe diabetic neuropathies.
Right.
Does this device also give out such
Yeah, we also
values?
give the same data in terms of like we give out a table that says that how many points are in normal, how many are in mild impairment, moderate impairment, and severe impairment. And also a color report that I showed you, basically showing that which are the points that are affected basically. So it gives out the same information.
Okay. And is it self-administrable, or
No,
you
actually,
have to...
so this is a doctor-based devices. So we are basically selling it to doctors, and the end customers are doctors. It is not for self-administration.
Thank you, Dr. Bajesh. It was a wonderful presentation, and we look forward to usage of such devices in the future. Thank you so much.
Thank you.
Thank you, Dr. Vikrant. Dr. Ravi?
Yes. Am I audible? Am I audible?
Yes, go ahead.
Yes, you're audible.
Yes. So it was a nice information, and also I have few queries that I thought I'll just put forth. What will be the cost factor of this machine?
So as I said, we sell it to the doctors. So we sell it around 25,000, which is around the same price as the biophysiometers that are there. And the doctor, but what happens is, but the doctors then kind of charge for the annual foot examination to the patients. So there's a range. Usually in the second tier cities, they charge around 150, 200 rupees per test. And then bigger corporate hospitals charge 500 to 750. So like if you do around 100 screenings, you kind of the ROA for the, like you kind of whatever you have invested for the device, it's returned, and the device can be used for almost 3 years. So basically, the end user doesn't have to bear that much. He like pays around 200 to 250, which is like an okay cost that you for your annual neuropathy screening, because it's done once in a year.
Okay, and does this machine require frequent calibration or something, or software updates, etc.?
So we calibrate and send it. So if you're using it for research purposes, like what we have seen is even after 2 years of use, 3 years of use, the values are still there. But if you're using it for some research project and you want to like kind of recalibrate it after 1 year, we kind of pick it back from the from the investigator or from the doctor and like kind of calibrate and send it back. But otherwise, like the device is holding the values even after 2 years and 3 years. And some of the institutions, like even ISC, is using it for some neurological research projects.
And what is the storage capacity of the device?
So the data is stored on the cloud, so there's no limit as such. But every time, like you need to kind of sync the device whenever you're connected to the Wi-Fi, you need to upload the content or the data into the cloud server, and that we are currently giving free. So there's no kind of limit to the amount of data that can be stored.
Okay, so but are there any chances of data breach as well, because since it's been connected to the internet?
No, basically the system is like we have followed, even though we are not because we are selling in the US also, we have followed HIPAA compliant systems here, and the data is encrypted, so only there's no chance of any data breach happening. And for like hospitals, some of the hospitals are what they do is they also kind of integrate it with their database, and they just we provide the APK so that only the front end is ours, and then the data is like sitting on their servers.
And how about in case if there's a virus attack or something like that?
So far there is no such issues because we have kind of taken care of that in terms of the technology piece. So far we have not faced any such issues. We have like taken precautions against those issues.
All right.
Thank you, Dr.
That,
Badi,
that
for giving us a detailed information on vibressence and its impact on screening diabetic neuropathy. I would also like to thank Dr. Vikrant and Dr. Ravi for joining us in the discussion. Now we would
Thank you
like
so
to
much.
proceed.
Thank you, everyone. Thanks,
Thank
everyone.
you, sir. Thank you, sir. Now we would like to proceed for a sixth innovative talk by Mr. Subramania Muramalai on the topic motor unit, sensors and musculoskeletal modeling. Sir is a dynamic professional with a unique blend of expertise in both arts and science. With over decades of experience in automotive sector, he has honored his skills in system testing, coding, algorithm development, and system engineering. He has spent approximately 4 years managing product and productive initiatives from concept to exclusive, focusing primarily on sensor-based machine health management. Transitional from automotive industry, Subramania Sir has pursued his passion for sports and movement, founding Next Q Private Limited in December 2021. At Next Q, he champions the belief that movement is humanity's sixth sense, striving to reconnect people with their innate physical capabilities. Now, I would also like to welcome the chairperson for this session, Dr. Ravi, Professor, SDM College of Physiotherapy, and Professor Dr. Tushar Palekar, Principal and Professor, Dr. D.Y. Patil, College of Physiotherapy, and Dean of Faculty of Allied Health Sciences, Dr. D.Y. Patil, Vidyapet, Pune. We can start with the session.
Thank you. Thank you for this opportunity, and huge thanks to Dr. Srihari Sharma, particularly for talking about this opportunity and inviting us to showcase our technology. And without the cooperation from Dayanand Sagar, I would say we might not have come so far the way we have come up so far. And to talk about the technology, I would like to present few slides. You have to let me know if you can view it. So can you view the slides, please?
Yes, sir, we can see.
Perfect. All right. So mine is a story of being super fascinated by sport and movement in general. I've been kind of an amateur athlete by myself, getting into long distance running, into even learning tennis during the 2015, 16, 17 times. And I was quite fascinated by the joy I get out of movement, out of sport, and also being enthralled by the movement of some elite sports people as well. And along the way, during the pandemic time, I got introduced to these particular sensors called IMU sensors, and also bumped into a particular concept called musculoskeletal models. So what you see on the slide towards the right-hand side are called musculoskeletal models. I mean, reducing down to a simple definition, they are mathematical equations representing the different segments of our body, the joints, the muscle groups, and it can get very specific to an individual. That's the journey the world is engaged in right now, at the cutting edge of things. And putting these two things together, I and few of my colleagues started doing few experiments, started making prototypes, and which somehow garnered some immediate attention and appreciation of physiotherapists and few orthopedicians, of which Dr. Jayan Sampath is one who addressed the gathering today morning. And going forward, I think it is unfortunate, the situation, and it can be said by 2050, a good number of us might be uh, might be in bed due to one or the other pain, and particularly the low back pain. And such is the uh, size of the problem, where I thought, okay, I want to make sports champions, elite athletes, and all that. But bumping into physiotherapists, orthopedicians, I understood that the problems are much more fundamental. People are having productivity issues, social participation issues, early retirement. So that has become a common phenomena. And to that extent, WHO has declared that in about 160 countries, low back pain and neck pain are leading cause of disability. And there are further more papers which talk about how any screening slash diagnosis slash assessment must be subject specific. If it is not subject specific, then the treatment or the treatment plan, rehabilitation plan might not be effective. So that is also the reason why we see many people visit a physiotherapy center. They get a generic advice sometimes, and they kind of give up even in the middle. So, and if you see this particular iceberg model of picturizing the problem, at the topmost level are the events, which is like early retirement. I spoke about economic burden, which is running into anywhere between hundreds of billions to the economy, and especially for locomotor challenged communities and people, it is a matter of compromised dignity and independence, and they just live their life bluntly, just waiting for the end. And in the elite sports, people who are dependent on their body, on their performance for their survival and livelihood, there is this continuous scare of sponsorship withdrawal due to injuries. And this is at the event level. And going to the middle layer, if we see the symptoms, signs, which are disabilities, paralysis, stroke, Parkinson, accidents, injury, pain, falls, even in an extreme condition, cerebral palsy. And even much diving down deeper at the very fundamental, at the perception layer, there we see a lack of awareness, a lack of, uh, a continuous image of our body, of how active it is, where it is disabled, and we are on our work without actually knowing the asymmetries, limitations of our body, which in the long run is showing up as one or the other disability or disorder. And the current systems, as presented in the morning, the 3D gait analysis is the best solution, but it is not practical a solution, though it is gold standard. It will remain gold standard for many more years to come, but it is not practical because of the cost. Like doctor has mentioned in the morning, it requires a very specialized skill set to operate, maintain, manage, analyze, diagnose, and then even take action at the end based on the report. It gets really skillful and difficult. And this is where the combination of technologies we are working on, which I will play as a small clipping. I'll share the computer sound so that it is much more immersive as an experience. Thank you. So that simply comprises the core parts of our technology. One is the IMU sensors, the orange ones you have seen in one slide, and the skeletal models. You might have observed that the skeleton doesn't have hands. It is exclusively lower body skeletal model, and representing an American male, 6 feet height, 85 kilo weight, and such parameters. So it is based upon those anthropometry, I would say. And however, the current situation is that uh, there are solutions in the market. For example, doctor has mentioned in the morning that a simple foot model is represented as a line, but that is not enough, because if you consider the Oxford foot model, it gets complex and complex, but it is the best thing to have, let's say. And other technologies are so specific in their application. For example, fall detection, weight bearing, static posture analysis. So I mean, it is good to have those many technologies, but it's just that we have taken a route that we want to be a platform technology. And what I mean by platform technology is that we want to develop a lower body skeletal model, improve it to a musculoskeletal model, further progress towards neuromusculoskeletal model. And then again, within the same lower body model, we have other categories of a lower body model for women, men, and within those categories, again, we will have, let's say, a northeast population lower body skeletal model, a south, specific for Karnataka or Andhra. And within that, you will have further more categories depending upon the activity, whether it is walking, running, jumping, skiing. So every activity requires a further fine-tuning of the skeletal model, of the definitions of the joints, the joint centers, and further more details. It gets even more complex, and this is exactly where we are taking support from the College of Physiotherapy, Dayanand Sagar, to validate two main research questions, I would say. One is, like Dr. Jain mentioned today morning, technology is cutting edge, but there is still some way uh, to kind of reach a stable solution, and that is where we are aggressively progressing towards validating the application of sensor in gait analysis. This is one research question we are working with the College of Physiotherapy, Dayanand Sagar. And the other question is validating the skeletal model, because this is a generic model for Indian context. It has to be customized. And this is a skill up and coming in our country. There are, I would say, less than 50 professionals who are doing this cutting edge work, and we are in close touch with them. So that's the size and complexity of the activity we have taken up. And this is a simple representation of the parameters one needs in gait analysis. As you can see on the left hand side, range of motion related parameters like the pelvic tilt, pelvic twist, pelvis rotation, hip flexion. Of course, we get the knee flexion, knee rotation, hip adduction, and other parameters also, but I'm just giving this as a snapshot. As you see in the columns, the graphs are close to each other, but they're also slightly different from each other, which means the purpose of the activity defines the definition of the skeletal model. So that way, we eventually want to become such a massive library of skeletal models, which you can use IMU simple inertial motion units along with it and get the metrics that you want, to the extent of being a credible alternative for a 3D gait analysis laboratory, to the extent of becoming a credible alternative for a force plates, to the extent of becoming a credible alternative for even EMG as well, electromyography. So that's what we are moving towards. And this anybody who's associated with us gets an access to this particular dashboard, into which is embedded facility to register subjects, conduct trials, collect data, analyze data, and right now the range of applications start from using this as a teaching and training tool to the point of publishing your own research for the specific research questions that you are working on. And also one repeated concern, I would say, not a complaint, but a concern that we used to receive was, hey, I mean, if you see thermodynamics laboratory, thermodynamics engineering guys have their own laboratories, electrical guys have their own laboratories. We in biomechanics, we don't have our own laboratory. And if we want to have our own, we have to procure a 3D motion capture system, and then a force plate system, and then EMG system, all of which put together can actually skyrocket up to 5 crores even. Including, I mean, installation is further more expensive, and getting on skilled people is further more expensive, and it only goes on the list. So this is where we found our system to be such a credible alternative in the up and coming months, to be able to give you a very low cost alternative, which is credible, which is believable, and as and when we collect more and more data with your support, we will even become a usable, actionable alternative to the current 3D analysis systems. And these are snapshots from the Harorli campus of Dayanand Sagar, wherein we presented it to the BPT and MPT student community and research scholars as well. And we got some great appreciation, and we would like to only double down upon it and intensify this collaboration we have ongoing. And on the side, we have taken up running as a preliminary use case, I would say, because running is quite a linear activity, and we have access to massive number of runners, and our technology will be used by physiotherapists and sports scientists specifically to be able to judge the performance versus the training plan that these guys receive. The cohort that we are organizing right now, it has about 10 people, and who are ranging anywhere between somebody who wants to run faster for their 10-kilometer, and most people are into half marathon, full marathon, sorry, and even more number of people, at least 5 people, are into ultra running, which is anywhere beyond 50 kilometers, and mostly these guys are into 100 and 160 kilometers running for the border ultra marathon. So this is the first use case we have picked up, and our system would be a great learning opportunity for people who are trying to be in the field of sports physiotherapy, people who are trying to be biomechanists, sports biomechanists, clinical biomechanists, and also sports scientists as well. And there are further more prospects that we have triggered in the case of running movement analysis, in the case of cycling, bike fit, cycling movement analysis, because cycling is also used as rehabilitation, modality in certain cases. And also we are seen as uh, a supplier of valuable data for extreme customization of the prosthetic and orthotic devices. So this is the massive opportunity that we are sitting on when we scouted out for the number of colleges slash departments slash organizations requiring such a kind of gait analysis system. It's quite a massive opportunity, and also I want to say at this point that it cannot be achieved without your support, and your support is very much required, and serving your interest, your research questions is fundamental to the progress of our system. And yeah, I mean, like I mentioned, going forward, it is going to be a platform technology, and I'll fast move towards the support we have received so far. Derby, the associated organization with the Anand Sagar group of institutions, has supported us with 2 grants so far, central government grants, and we're looking into one more right now. And we have won the Karnataka Elevate Award a couple of months ago. It was a good sum of amount supporting our activity. a timely support from Government of Karnataka. And also wanted to say that our activity, our technology is quite aligned to the Sustainable Development Goals SDG 3, universal health, and SDG 8, employment and involvement in technology. And this is our team right now. So again, big thanks to Dr. Srihari for introducing the students that he came to know about from medical electronics and engineering departments from Dayanand Sagar College, and who have been actively working with us and now have become full-time employees with us. So we constitute, I am the product manager. Like in the introduction, I'm into too many fields, but a master of none. I have conversational knowledge about many topics on the technology side and on the biomechanics, physiotherapy side. I do have that conversational knowledge. That's why I'm able to communicate with multiple stakeholders, understanding strategy, understanding technology, understanding the biology, physiology, and kinesiology sciences, and coordinating it with the engineers who are working mainly on the calibration. But this is exactly where, with the Anand Sagar group of institutions, especially COEP, we are trying to further our interest by validating the sensor application and also validating the fire of musculoskeletal models. It's a very heavy fire to handle, but we are quite stubborn and quite intent about it. I would say. Thank you, and we'll open up for questions if any. I'll stop the presentation.
Thank you, Dr. Am I audible? This is Ravi here.
Yes, Dr. Ravi. Yeah.
Yeah. You said that this machine is quite good in analyzing the running movement and cycling as well. So I had few questions on that.
Sure.
Will it calculate the speed of the movement as in case of running or say speed walking? Does it give us that information?
Right away, we are mostly into range of motion related
Okay.
parameters. Cadence is one thing we offer. Step length, stride length is we are fast working towards, and speed is something. It's our long-term plan. It could take some time. It's quite complex mathematics. I would say it could take some time, not more than 9 months, I would say, but it is definitely a parameter that runners, the coaches are asking for.
Yes, yes. In fact, I would like to suggest that along with the speed, the reaction time, and if you can get out with the data of power as well, maybe it might help in the training the sports individuals. So that was one of the thing. And second thing I want to ask is how much is the normal area requirement to install this device?
I mean, I'll just continue on from the previous point. Like you mentioned, running economy is a big deal for these long distance runners because it fundamentally depends upon fatigue management, faster recovery, and being able to maintain good running economy through good running form. I think this is a great point. I just want to acknowledge, number one. And regarding installation, today morning at 5 a.m., we did a trial. I just went on my cycling with a backpack, and that's the system. That's it.
Oh, that's good. Okay.
Yeah. So that the runner she invited, she mentioned a particular place. Okay, this is my start point of run. I said, okay, I'm coming there. And then all she is supposed to do is wear this shorts, as if you can see. And into these shorts go these miniature sensors, and we have a data collection device. We trigger data collection, and that's it. Right now, our team is doing the analysis part. And
Oh, nice.
yeah, that's it, Doctor. Yeah.
And then the storage is again a cloud-based storage, isn't it?
Storage, a sensor has inbuilt memory. It can store up to 6 hours of data. However, the processing, the skeletal model which takes this data as input and processes the range of motion metrics, that is deployed on cloud.
Okay. And when are we expected to have a validation of this device?
A validation, actually, we validated ourselves last year at Dr. Jayan's clinic. We were 5-degree accurate 45% of time, 8-degree accurate 71% of the time. But however, to be able to kind of make a credible statement, it requires 3 degrees accuracy, and it could take about between 4 to 6 months, doctor.
Oh, okay, okay. I'll be looking forward to that.
Very kind. Thank you. Great to hear.
Anyway, that's all from my end. Thank you so much.
Thank you, Doctor.
Thank you, sir. Delegates, if you have any questions, you can put your queries in the inbox. Thank you, Subramania sir, for enlightening us with your knowledge on motor unit sensors and musculoskeletal modeling. I would also like to thank the chairperson, Dr. Ravi, and Dr. Tushar Palekar for joining us for this discussion. Thank you, sir.
Thank you. Thank you. Have a good day.
Thank you so much.
Bye.
Now we'll be proceeding with our second last innovative talk session for today by Dr. Balakrishnan. The next session is by Dr. Balakrishnan on the topic Fundamentals of Various Stages of Rehabilitation in Sports Injury. Sir is a chief physiotherapist at Vesoma Padakun Dravide Center, Sports Excellence, Bangalore. With over 15 years of experience specialized in sports and musculoskeletal physiotherapy, he had the privilege of working with elites across the various sports disciplines and accompanied them in various international and national sports events. The session will be chaired by Dr. Sumant, HOD Yashoda Hospital, Hyderabad, and Dr. Esha, lecturer at Asia Institute of Medical Sciences, Malaysia. Sir, I would request you to start with the session.
Hi, good afternoon, everyone. Thanks for the introduction. So I would like to share my page. 1 minute. Yes, it's here. Is it visible?
Sir, can you please adjust your camera, sir?
Hi, is visible? Okay. Am I audible? Anybody?
Can you please adjust your camera properly, sir? It's near to you.
Hi, am I audible?
Yes, sir, you are audible, sir.
Okay, thank you. Thank you. First of all, I would express my thanks to the Sagar University team and Dean ma'am, Principal ma'am, and a special thanks to Vinod sir for a grateful opportunity. My topic is various stage of rehabilitation sports injuries. I'm going to share my experience, which I had with players, especially for the last 15 years. That's what I choose this topic. 1 minute. So the rehabilitation, I just split into two topics. One is stages and the other one is a team. Stages, especially the evaluation criteria to progress, rehab tools, and return to the sports assessment. And team, that's a sports science team, I would say. Coaches, SNC, sports psychologist, and nutritionist, and surgeon. How we have to work together and give the better performance for player. So that's a two topic I'm going to share my perception. So evaluation and program design, especially when you start with either general client or athlete, first thing we must have to do our proper evaluation, the assessment, musculoskeletal assessment or injury assessment. It is very important. So here we have to make sure or all the regular things as a physio, we are aware about that postures, that condition issues, flexibility, movements, and all kind of things. I would say we have to add certain questionnaires also. For example, like knee injuries, we have that KOOS questionnaires, and same like that SPADI for the shoulder. These kind of things before start our rehabilitation, it helps to understand the condition. Then when we are taking the return to sport assessment, it will be very helpful for them to give how much progression we made it. So that's why we must have to do the proper detailed assessment. That is very, very important. And we need to do the proper diagnosis. Then based on the diagnosis only, we can plan our protocol. Especially when it comes to the protocol, plan our protocol is very important. What type of exercise we are going to do, and what type of medium we are going to use. Those things we have to keep in our mind, and duration of the protocol. So the duration of the protocol, it might change. See, for example, like a post-operative cases, we have the proper periods every 2 weeks or three weeks, 4 weeks. Same like a conservative management also, we have to keep certain criteria in our mind, and we have to fix the duration. That's very important. So next one, criteria to progress. So most of the time, what we have to do, what I'm feeling, we have to fix certain goal before we move to the exercises, because we should not randomly, increase the repetition or increase the intensity or volume. I feel we are not supposed to do that. We have a certain goal or improvement. Once we can keep it by ourselves for our better performance, it will be really good. In terms of, for example, reduce the swelling, maybe we can keep it some 3 to 5 days. Once reduce swelling, we can, we can progress to the next level. We can keep the other parameter like a pain scale. What is the pain scale? It's a below less than 5, and it is getting better or not. Like that, we can keep in our mind. Same like a functional movements. That also, for example, for general clients, I'm not able to do this kind of activity. Now I able to do activity. So throughout the period, this criteria we have to keep it. It helps to, improve our rehabilitation pattern, including the strength training and sports related activity also. We have to keep in our mind. Yes, this is an important stage, I would say. When you're coming, the proper evaluation, we have to make sure once we diagnose based on the differential diagnosis, we have to design the protocol, and as well duration I told you. So next one, which kind of medium we are going to use. Sometimes what we are doing, rehabilitation means we have to keep it on our clinical side. So based on the therabands or weight curves, or sometimes we are going a little more of own body weight exercise. So I would recommend we can explore our rehabilitation. It will be really helpful. In terms of, for example, like a hydrotherapy, it's one of the best medium to improve the gait patterns, balance, and coordination for everything. This medium, we can start little at early time of the injury. If you take ACL, suppose if it's a non-weight bearing, you have to start either toe touch or flat foot. On the ground, you have to go with a crutch or walker, and you have to walk very, you have to put more, you can do the proper walking, you can more of limping kind of things happen. But inside the water, you're able to do the proper walking. So literally, normal walking will be very easy. The reason is we know hydrotherapy has a buoyancy or special gravity, and against the water resistance we are doing, and especially if you can get into the pool up to the hip level, about 50% of the body weight, go out of your body. So if you go chest level, it's about 30%. Neck levels, only 10% of the body weight fall on your weight bearing joints. So in that situation, if you make them to do some kind of walking inside the pool, it helps to improve the gait pattern. So we can keep it that one as a medium in our rehabilitation. Yes, you would ask, because most of the time we don't have a pool, but most of the athletes, most of the clients, they are staying in apartment or they are access to the club. So definitely we can refer them to go and do those hydrotherapy exercises inside their apartment pool. It will be really helpful. It is also part of our program. And second one, once they come to the good stage, they are improved, they're able to do a lot of exercises by themselves. We can explore to the fitness center, like a gym or a fitness center, be really helpful. The reason is that we have the various type of machines. It helps to enhance the muscles and improve the load intensity for other benefits. So we can keep that also in our mind, and especially the barbell workout and dumbbells workout, even TRX, the multiple type of machines and equipments we have in the gym. It helps to improve the progressive weight bearing. It helps to get back to the sport as quickly as possible. The third medium, I would say, biomechanical lab. The few example I would say, like isokinetic machines. The isokinetic machines, through that be able to quantify their affected and non-affected leg, and including the quadriceps and hamstring also. So it will give the virtual feedback. So we able to quantify their strength as well. We can give training also. So because of the virtual feedback, the athlete can able to push more, and the kind of confidence also he will get. So that also we can keep in mind. And the same like a force plate. Suppose if you want to give, you want to know the power of the lower body, we can make them to do some kind of CMJ, like a counter movement jump and a drop jump, single leg hopping. So those kind of activity, it helps to quantify as well. It gives a virtual feedback, so you're able to do some better performance. So especially when you're dealing with the athletes, the documentations are very, very important. The reason we have to submit to the various federation academies, and we have to show the good progression as well. So that's the reason these kind of lab we can use, especially for the elite or athletes, we can use these kind of things. It'll be really helpful. Same like proking. The proking is mainly for the balance. Again, it gives a lot of virtual feedback. Are you compensating with trunk, or how long are you able to stand on your right leg, or like affected leg or non-affected leg? So those kind of things we able to see that. So these kind of medium, if we can use for the elite player, will be really helpful. And track and field or functional training. So this is also the other medium. Our ultimate goal of rehabilitation, we have to put the athlete back to their activity, or back to on the court, back to on field. So that is very, very important. In that situation, we have to go and train the players on field and on court. That is very important. So it's most probably kind of agility training we can give, and a lot of dribbling, lot of ball throwing activities, and you can do some side other things. Mostly, which is related to the sports, we can use. And if general clients, for example, they told we are not able to do the squat, I am not able to drive. So we can keep it as a goal, and then we can work towards that. It will be really helpful. So the stage wise, when you're talking about the evaluation criteria, and this one, the rehab tools, it's very important. We can, as a physio, we can explore our rehabilitation medium to the multiple places. We can see the very good improvement. And return to sports assessments. So it is one of the important things. After we done some assessment, basic one, the same kind of things we have to repeat at the end of the rehabilitation. Either it's a post-operative or it is a conservative method. We have to make sure return to sport assessment. If it is more than 90% compared to the non-affected side, we can give the clearance to the sport, whatever the sports, we can do that. 90 plus, it has to be there. That is the ideal things they're saying. So certain metrics, we can use it like a flexibility, strength, muscular endurance, cardiovascular endurance, and agility. The others means something related to the sports. So kind of biomotor abilities. Suppose if he's a fast bowler having some issue in the shoulder, so we can give some kind of ball throwing training, how long they're able to do, how many overs they're able to do, how far they're able to throw. So those kind of things we can keep in our mind, and we can do those kind of sports related assessment also. This is helps to put the player completely on back to track. The same like a general client also, we can keep certain kind of goal. It will be really good. So that's one thing I wanted to explain over here. In my next topic, it is a rehabilitation tip. Sometimes we are working with a rehabilitation within our team. Sometimes only the individual self or with the team, as a physio team, we are discussing. So that somehow, whether we are able to, especially for the elite player or even the amateur player, we able to provide the better environment and better performance, it's a question mark. The terms of only be focusing on the rehabilitation, we are missing the other things. So I would say we have to work as a team. It's a sports science team. We have to work together for the better performance. For example, like a coach. Coach is the main person for all the sports. But when the player injured, he can't do anything. But as a physio, we have to go and discuss with the coach. In this condition, I'll take some knee injury. So we can recommend to the coach, suppose he's a goalkeeper. Okay, let him go and throw some balls or something. We can modify the program. Same like if he's a swimmer, we can use some pull buoy and he can do some kind of stroke by this hand. Suppose he's a tennis player, we can make him to sit and we can do some kind of training. It helps athletes to keep in the sport. So he won't come out of the track. So that is very, very important. So the coach, we have to work with a coach. The second one, SNC, strength and conditioning coach, who is mainly keep the athletes physically strong. So suppose if it is a right knee injured, so we can definitely ask the SNC to focus on their upper body strength, core strength, and including the non-affected leg. So that is really, we can focus on that. So in that time, so he is maintaining his strength and conditioning for longer time till he completely come out of the rehabilitation. And the same sports psychologist, I have to give a great example also here. Most of the time we don't think about this profession. The reason is, okay, so only we are focusing on the rehabilitation. But I have to give one example. One badminton player who came with some shoulder issues, we have diagnosed labral tear. And we sent to some famous doctor. He got it in the corticosteroid injection. Then we have been doing our rehabilitation for about 3 months. He's getting better, but he doesn't have a confidence to do this movement. Later we tried everything, all our special tests and everything we performed, everything is negative. He has a good amount of strength also, but still he's not able to come out. Later on we come to know, so he's having kind of some emotional issues because of once he had an injury, immediately that academy told, okay, you no need to be here. You have to vacate the room and go back, whatever you want to do. Same like the family also told, you have to focus on this one. And peer group, they told, no, you are not playing, we are playing. Something and all happened. Mentally, he's slightly disturbed. So then he take this as a reason and he's keep complaining, I have pain, I have pain. So then we put him with a sports psychologist and we had a lot of counseling for him. And we took him to the court and we make him to play. We really build up the confidence. So after that, he's really playing good now. So the sports psychologist, it's very important, especially in the athlete life. And we have to keep in our mind, they are very important team people for us. So maintain their mental health. And the sports nutritionist, yes, we know that nutritionists work. But what happened when injury happened for athletes? For example, one swimmer who had again labral tear. He's now, doctor clearly told 6 months he's not supposed to swim. Minimum 6 to 9 months he's not supposed to swim. In that situation, he's at home. He was, when the surgery happened, he was 75. We had a consultation day before yesterday. He said 101 kg. So because these guys used to have food or whatever things, because the body because had a lot of training, they're not able to control the appetite, or sometimes they don't have a proper guidance. So by the time he put on weight, so now what happened? Even though in another 3 months he's going to get back to his swimming, but if he's not able to reduce his weight, what about his situation? Okay, so we have to work for his weight reduction for another 3 to 4 months of time. So the sports nutritionists, we have to keep in our mind and we have to work. Yes, at the last, it's a surgeon. Surgeon, as per the advice, we have to do that because especially post-operative cases, we have to keep the surgeon advice also, because we have to use a long brace, a hinge brace, or how many days of or weeks non-weight bearing. Those kind of things we have to keep in our mind. So what I would like to say, one is our ultimate goal of rehabilitation. We have to, it is not simply treating the player or client, we have to put them back to their regular activity. So by the time only, as a physio, our work is completely get fulfilled. That is one thing we have to keep in our mind. And the second one, especially when you're working with the players, we have to work as a team. So by the time only, we able to see the better performance. Okay, so this is my topic. Just I want to give my a small information about this. And this kind of rehabilitation, especially now we have a lot of students coming from the various college. Like even we have a tie-up with the Dansagar also. On a monthly basis, the students are coming and visiting, and they're getting a lot of knowledge in this kind of work. So we have been working closely with their students. The reason is the rehabilitation, the team building. It is very, very important. So we are more focusing on that aspect. Thank you. Thank you for the opportunity.
Thank you, sir. Thank you, sir.
Thank you, ma'am. Yeah.
Yeah. Now moving on to the next session, which is our last session by Dr. Alakananda Banerjee on the topic, the role of physiotherapist in health literacy. Ma'am is a founder and chairperson of Dhamma Foundation. Ma'am has 36 years of experience in corporate hospital industries. She was honored faculty at IIT Delhi. She is expertise in WHO guidelines of ICF. I would also like to welcome the chairperson for the event, Dr. Shweta, Principal, Prudence College of Physiotherapy, Bangalore, and Dr. Sri Raghunath, Professor and Principal, Vaidehi College of Physiotherapy. Ma'am, you may start your session.
Thank you so much. Thank you so much. And for this opportunity, first to the Dean ma'am, Satya ma'am, and the chairpersons, and of course, my dear friends. Yeah, so a little bit, I don't have any presentation, so I'm going to just give an informal talk because this is a very new area for our physiotherapists. So Dharma Foundation of India was formed in 2010, and the primary objective of Dharma Foundation was empowerment of the people in the grassroots level regarding their health issues, right? So in 2010, we had followed the WHO guidelines of active aging, and we had done this work at Gurgaon and a place called Chhatarpur in New Delhi. And basically, in that particular starting point, we had utilized the resources of elders to be able to be empowered regarding their health issues. Okay. The second point, that why did we do it? I'll just come down to the point that we all know about healthcare in India. Like you just heard that I've been long years working in corporate hospitals, and I had built 3 corporate hospitals in New Delhi: Apollo, Fortis, and Max. And I really realized when I was director rehabilitation at Max, I really realized that rehabilitation is not the only purpose in a hospital-based care, because most of the people are there for acute or subacute care. So definitely the vision was community, based rehab. And right then in 2009-10, I had started the work of taking care of patients who were discharged from the hospital, and how they would be, what would be their goals and what would be their physiotherapy therapeutic treatments. Okay, so the third point that I would like to share about technology, right? So technology is playing a huge role 20 years down the line. I'm talking about right from 2007, 8 to 2024, almost 1.5 decade. And we can see the technology and its usage, especially after the COVID, and how important it has become in the life of each and every person. So understanding Dharma Foundation of India, the objectives of health literacy, understanding the objectives of WHO guidelines, we shifted our focus from elderly, into healthy aging, which was also a shift in the paradigm of WHO. Over the period of time, technology became a very integral part of our, the way we were communicating and sharing about healthcare right to the remote people. So healthcare, as you know, like whether we see the urban part, the way the urban hospitals have proliferated in the urban areas, even the smaller towns like Muffassals, they are all having, maybe that hub and spoke model, and they are also having, a good amount of the major hospitals like Apollo, Nara Nidralaya, and like all that. I won't go into the details, but we can see that the people in the rural backdrop still have the gaps of health requirement or the health facilities, where the government plays a very, very important role. Okay, so the government role in the healthcare in the rural backdrop is definitely through primary healthcare centers and the district hospitals, right? So we were also now shifting our base into the rural sites, where we believe, because of the proliferation of technology, in India, which was really a great movement that had really happened in the past 5-6 years, where WhatsApp and Google and everything was giving information of health, right, to people. There was so much, or there is so much of information that we really don't know. It may be allopathic, it can be the alternate medicine, whatever. Everybody, right from Facebook to Instagram to WhatsApp to whatever you can talk about, was carrying forward a lot of health information. And where the even and that was a dangerous trend. Yeah, that is a dangerous trend, because people have started believing in them, whether it's on YouTube, that this is there on YouTube, so it must be true. So there came to a point where, we all understand about data privacy and, health privacy is definitely a challenge in India, right? So let me come to the point of what physiotherapists can do. Okay, so we know that we are building up a community-based rehab as our master master syllabus, and that has been one of the things that I had really envisioned right from 2007, that the CBR will come up in a very super specialized way, and that is what has really come forward. And the CBR team has to understand the healthcare, because they are in the community. And I will take the example of DSU, where I was there last month, thanks to Satya ma'am and Dean ma'am. I was there, and where I visited villages, and where the CBR team of DSU was doing a wonderful work, in their centers, right? Where physiotherapists were playing such an important role in the PHCs and in, even for special children's. So that was really, really, really encouraging, for us. Yeah. So physiotherapists, as we know, in the graduation level itself, they have got the subjects of medicine and surgery, pharmacology, pathology, So we are geared up to take care of a person, of a patient or a person, independently, provided we know what is really happening to them, right? And that was my focus. I went to DSU, which I really loved. The focus was on, on holistic understanding of the person's social environment, psychological and physical issues, yeah, which are all part of the physiotherapy curriculum in their undergraduate. Yeah. So as CBR, as it is getting into a post-graduation specialization of CBR, I met physiotherapists in the centers at Kanakapura, and I was really, really impressed by their, by their inputs and their understanding of patient care. So here we have academics, which is going on. We have, the CBR team, which is now flourishing or doing very well in almost many universities all over India. Yeah. So what can we understand? The primary healthcare centers of a government is equipped for a medical doctor and nurses. Yeah. In India, we have a dearth of doctors as well as nurses. Yeah. And with the population size of India, and the economic factors of India, we have to understand that physiotherapists should play an important role in the PHCs of our country. That is where, that is what the focus of Dharma Foundation of India is, to take physiotherapists forward, which will generate more employment and more, openings in the grassroots level. So the next point is, of course, how can health literacy help? So health literacy is something that we will be doing because we have done it as undergraduates, right? So we have all know about the health conditions, right? And we can definitely find out from a village what is the prevalent problems that they face. In one of my work in West Bengal, I really, was taking care of it myself because I'm staying in Kolkata, and they had a lot of problem with the girls who were attaining puberty, and how they would really use pads and that sort of a sanitary stuff during their periods, and also the apprehension of their parents regarding if they miss their periods, what is, they used to get really, really apprehension because why is it not happening? Yeah. So we started really telling them about the do's and don'ts in very, very simple words to this place which is called as Kharda, in the district of Bakura, which really didn't have any hospital. Or so now what my experience has been, that the doctors are going to the villages maybe once a week, or they must be going to some chemist shops, but the health of the people in the villages are not really monitored. Yeah. So monitoring of health is going to be an integral part of India. Why? Because the government, the central government, the last 5 years, we have seen that they are coming up with policies, which is at par with Europe and US, but the theory is there, but there is no application as of yet. So health literacy will not only make awareness, of the social, the cultural, and the economic conditions, plus the environment of that village, and and to capture that information can be done easily by the CBR team. Okay, so the state council, where we are talking about Karnataka, has come up with, a lot of programs like, health information. I'm not remembering that word, which Karnataka state government has come up with, where, literacy on health can be imparted to the people who don't have, the health, healthcare facility. So coming down to the central government, so I spoke about the state government of Karnataka, where they already have the state policy. Now I'm going to talk about the central government, where Ayushman Bharat plays a big role. Of course, it's all in papers, and we really don't know what's really happening and how many people are really helped by it. Yeah. So we are in a very nascent stage. Yeah. At this nascent stage, what we do is really setting up a system where a hospital, let's take in this case DSU, and which is already in a rural backdrop, and creating a system through the physiotherapist of capturing information of the villages, so where it is really going to into them understanding their well-being, into understanding what is most important today is early detection. Yeah. So if they can understand and early detect their issues, the people, through this health literacy program, it will make a lot of sense to the central government, which will be able to save a lot of money. Yeah. So insurance is going to play a very important role, yeah, in this, especially to the people in the grassroots level. And so where we can actually gather that information from this village. Okay. So what is the methodology that we follow? We do a survey of a village, and we find out, we just stick to the non-communicable diseases. Yeah, we are not going into infectious diseases right away. We are just going into the non-communicable diseases, and we do a survey, a very short survey of that village into what are the real problems, whether it is smoking, whether it is, women's problem, or knee pain, or back pain. All that is done in a small population, where it is surveyed. So here, we were thinking of Hoblis in Karnataka, and like talukas. So it's a lot of work. But I'm very happy to tell you that Dharma Foundation of India has already signed MOUs with DSU, with MGM Aurangabad, with VK Patil Ahmednagar, and with KLE in Belgaum. Yeah. So Maharashtra and Karnataka, we have been able to really work, believe me, and that's been after 14 years, the establishment of Dharma Foundation. So it's going to take a lot of time. Yeah. But we hope in this forum, there must be people, there are, the universities really come up, but because we hope that we can then apply for a joint funding to be able to do this, work right with many universities, so we can show that this is going to be a very relevant aspect of healthcare for the rural backdrop. So the methodology, like I said, is collecting information of NCDs. Then we can, we choose volunteers in this village, yeah, and then we teach that village on those, that we have surveyed, maybe back pain, maybe neck pain, maybe knee pain, whatever we have done, we have collected, and then we are going to teach them. We are going to give them pamphlets in their local languages, and yeah. So that is how, and believe me, we are so fortunate. I mean, taking the example of MGM and DSU, and of course VK Patil, and Belgavi is really great, KLA. They already have the hospital, where there are physicians, there are physiotherapists, right? And, the information is coming right to the hospital, where one person in that village, may be having diabetes. Yeah. So the early detection of diabetes, we all know, we have all read, that is what we are teaching. Just as an example that I'm telling you, we are teaching about diabetes, we are teaching about hypertension, we are teaching about maybe if you have a stroke, what will really happen. Yeah, maybe we are teaching about breast cancer and how they can take care of, through their self-examination. So empowering the community, I hope you all will agree, has become the order of the day, right? I have been all over the world, right? And, there have been, regarding the technology, the devices, this, that, but it will be people one-on-one which will make a difference, right? Where we can really capture information, right? And these 4 places that we have signed an MOU, it's very interesting because each place is very different from the other. Like we have Google Meet with MGM and DSU, and MGM has a total different idea of how to empower, how to percolate, how to send awareness, right, to the person in the grassroots level. And another thing, so we have taken the policies of the central government, the state government, the WHO, and also the sustainable development goals of UNESCO. So the sustainable development goals of UNESCO, the 3rd sustainable development goal, the SDG, is on health and well-being, right? How do we really empower people regarding their health, is something that the physiotherapists can do. And there is a great feasibility, and that is to be seen how we are going to go ahead, right? The last point, I know this is the last lecture and you all must be, running home. So the role of, like you heard, like, I'm one of the first person in India to do ICF workshops right from 2007. And right now, we are a team of 7 people who have been, who is faculty of WHO Dutch. They are already a faculty course. So they are the ones who we all take the ICF, all over India. Okay. So how can ICF help? So health literacy program is one, and capturing of information through ICF is the second part, right, of our objective. Why ICF? Because we are capturing, understanding the function of the person on that particular village, that particular person, right? Okay. So ICF is a functioning monitoring tool. You can monitor that person's function, right? And so we know about ICD, we know about ICHI. So ICD is International Classification of Disease. ICHI is International Classification of Health Intervention. I'm so sorry to say that people are just wanting to capture information regarding their diagnosis or regarding their health intervention, whether, X-ray has been taken or a blood report has been taken, but nobody is bothered about monitoring the health of the person. And I'm very, very, very happy to tell you that the physiotherapist can. Yeah, the physiotherapist can monitor the health of a person through ICF. So do you understand? I'll just end it up so that you can ask questions. So we have people in the village, we have universities, we have physiotherapists, team of CBR who are capturing information, and that person in the village is connected to the hospital, for the problem that he or she may have. That's how important a physiotherapist role in health literacy program is. Okay, so I think I did it pretty early, but I want a little bit of questions or answers so that I can answer it. So over to you, chairpersons.
Good afternoon, ma'am.
Yeah. Yeah, please go on.
Yeah, thank you, ma'am, for the insightful presentation. What should be included in the education and training of physiotherapists to prepare them for addressing health literacy? What we should include in the education and training, ma'am?
Yeah, ma'am,
Especially for the
you
physiotherapy.
already have the syllabus, right? What is the third year syllabus? Do they have medicine?
Yes,
Medical
ma'am.
conditions? Do they have medical conditions? Yes. Do
Yeah.
they have surgical
Yes, yes.
conditions? Yes. Do they have
Yes.
pharmacology? Yes. Do they have pathology? Yes. Yeah.
Yes, ma'am.
So I only would suggest that in their 6 months of internship, a good training, taking the example of DSU, I'm sure it's happening in the other universities too, to be able to make the physiotherapist, like, in India, it's gone into super specialization, neurology, cardiopulmonary, whatever. But in US, it's all doctorate of physiotherapy, right? A physiotherapist needs to know everything, right? So when I was a student and I passed out in 82, that's a long time back, we were also studying history and geography and sociology and psychology. It was a part of our syllabus. So the syllabus should be very, very holistic. Yeah. So when we are talking about, the government is talking about, we are talking about being independent professionals. Yeah. So in that 6 months of internship, when the physiotherapist is really looking at a patient, right? That is the time that a very holistic understanding of the patient should be taught. And it should not be specialization. It should be holistic. That a person who has a TKR can also have Parkinsonism. That needs to be documented and taken care of. If the Parkinsonism is not taken care of, well, the desired result after a TKR will never come. I hope you agree to that. So internship needs to be a little bit more structured. That would be my,
Thank you,
advice.
ma'am. One more question.
Yeah.
What role do multidisciplinary teams play in supporting health literacy initiatives in physiotherapy? What multidisciplinary teams have any roles?
Yeah. So, you know about knee pain, right? And you're teaching, suppose I don't know, I have knee pain and I don't know what is happening to me, right? I need to be understanding my condition. I can just tell you, I'm not being able to walk up and down the stairs, or I'm not being able to go to the farm because of the pain in my knee, right? So I capture that information and I teach them. That is what we do in a hospital. So the health literacy model, the modules that consist of information that physiotherapists will need to give to a grassroots level common man. Okay. Yeah. So the multidisciplinary team, can be a doctor or a nurse, like we like I saw at DSU and also at MGM, that the center had a physician who was coming sometimes, and and there were nurses also. But the physiotherapist is the one who's going down there to be able to capture information when the person needs it, right? And the PHC should have the doctors and the nurses already. Yeah.
Thank you, ma'am. Over to you, sir.
Good afternoon, ma'am. Can you hear me?
Yes, I can.
It was indeed a very good information which you have passed. I should thank you for that.
Thank you so much.
And it is a real-time information and real-life information and experience what you have gathered and gained. You have shared it with all the junior physiotherapist students and the participants. And also emphasizing on physiotherapy, how physiotherapy plays a significant role in health literacy specifically. And also you've been mentioning about the active part of physiotherapists being the being this wellness journey, I should say that. Ma'am, one question I have to you is, can you just tell what could be the possible outcomes with your experience, rich experience which you have, which are associated with the low health literacy or a suboptimal health literacy? What are the eventualities or the outcomes which you think of by your experience, which you can you brief it
I
up?
think, Dr. Raghunath, it's going to be an interesting journey for all of us, right? Because each state has its own understanding. Each person in that village has their own understanding. Now the villager comes to the PHC, the primary health center, to just take medicines. So we were talking about how do we deliberate them to be aware about their health, because people in the village, they are from that economic structure, right?
Correct.
So that is going to be a key point where we are going to do this study in the next 1 year. That how do we deliberate, how do we get them out of their house and make them literate on health?
Correct. By dealing with the low healthcare literacy and the suboptimal health literacy. So you mean to say that each and every state has its own challenges and you have to
Has
figure
its
it
own
out.
challenges.
All the challenges are state basis. Real-time situation can be reached out only at the community level. Go there, witness, find out, learn for yourself, and each case is unique by itself. That is what you.
Absolutely. And each case, each individual, like the SDG goal says, leaves no single person behind. I think you all know the SDG theme. Leave no single person behind, right? We have made it a point to take all the guidelines that are already in this world so that we can get the funding, right? So that is why we have taken every guideline of a state, of central, of WHO, of UNESCO in this particular program.
So you're going to make it a hybrid model and reach out to the community and society and make a tailor-made, which is actually required for that particular community.
Absolutely. So technology, how do I use that, as a hybrid, right? So maybe in the next 3 years, we can use technology. Yeah.
But
But
the basis
right
of
now,
all, yes, go ahead, ma'am.
Yeah, please.
But the basis of all these, the importance of the healthcare literacy is education, self-management, preventative care, promotion of health. Are these the pillars for the whole stuff?
Absolutely. This is basically a preventive health revolution.
Yes.
So please don't call it medicine. Preventive health revolution. Right? We are not even calling it a health revolution. We are calling it a preventive health revolution, where early detection becomes an integral part, which will interest everybody.
Thank you.
And who can do it? The physiotherapists can do it. Yeah, they are trained enough to do it. But again, my input would be to really strengthen their internship models. Yeah.
Got it, ma'am. Got it, ma'am. Thank you so much for sharing the information and your practical experiences. And over to you, madam, the compere.
Thank you, Alakananda ma'am, for giving us a beautiful insight on the role of physiotherapists in health literacy. I would also like to thank the chairpersons for the session, Dr. Shweta and Dr. Raghunandan, for having a wonderful discussion on the same topic. Now, I would like to thank all the delegates who have participated for today's session. Today, we had 2 plenary sessions along with 8 innovative talks. I hope you all have enjoyed the sessions. Tomorrow, so today is our first day of symposium. Tomorrow we'll be having a hybrid session. People who will be attending offline, I request you all to please attend it, be in the venue at 8 o'clock sharp morning. People who will be attending online, they can join through the link. I also request all the delegates, if you have any queries, to please put up the questions in the WhatsApp group as well.
Thank you so much. Thank you. All the best. Thank you.
I again, okay, ma'am, there might be a network issue. Yes, ma'am. Chairpersons and people who have participated excellently and put their initiatives in the discussion. I again thank all the organizers, sponsors who have made this day a wonderful success. And again, I would like to request you all to please attend tomorrow's session, which starts at 9 o'clock. I request all the delegates who are attending offline to be at the venue at 8 o'clock, and delegates who will be attending online to be to get in the link at 9 o'clock. I also request all the delegates, if you have any queries, to please put up your queries in the WhatsApp group. Thank you again for joining us and making it as a successful event. I request you to please put up your queries if you have any in the WhatsApp groups which has been met. Thank you, everyone.